we'll do a brief after the lectures get over. So again, welcome, good morning, and I'll be happy to get my chairpersons in. I see that the image is already flashing. Over to you, Dr. Mantri, and if the other chairperson's a little late, then Dr. Samir can take over till they join. Thank you so much.
Hello. Good morning, everyone. Switching gear from foreign body to persistent air leak or bronchopleural fistula. The first topic is basics, no? Or reading.
So the first topic is clinico-radiological aspects of bronchopleural fistula. So we have Dr. Harish. He is the consultant radiologist at Apollo Hospital, Jayanagar. He specializes in thoracic radiology. So Dr. Harish, over to you.
Good morning, everybody. Thank you, organizers, for giving me this opportunity. I will be just talking about radiological diagnosis and its role in managing bronchopleural fistulas. So, bronchopleural fistulas are potentially lethal complication. No, it's okay. Lethal complication after pneumonectomy. So, diagnosis and thank you. Diagnosis and identification of bronchopleural fistulas may be challenging, often requiring repeated imaging, including invasive as well as non-invasive. MDCT is the most important and diagnostic imaging of choice presently. Nuclear scintigraphy can aid in diagnosing in subtle fistula cases. So by definition, any pathological communication between the pleura and airway is called bronchopleural fistula. It can be between the bronchus and the pleura, or it can be from just a parenchyma, that is alveolar-pleural fistulas, where most of the time it is ruptured subpleural bleb or bulla are the cause. So this is pictorial representation of the same, where we can see that there is negative pressure area in the pleura, which is separated from the high pressure area, that is pulmonary alveolar spaces, by thin visceral pleura. Any disruption in visceral pleura leads to leak of the air into the negative pressure pleural cavity. So broadly, they are classified into either bronchopleural fistula or alveolar pleural fistulas. Again, central or peripheral bronchopleural fistula, because central are which are very close to the main airway, that is up to the lobar bronchi, and anything beyond that lobar bronchi we call it as peripheral bronchopleural fistulas. So there are many causes. So most important being the post lung resection or pneumonectomy. And there are many non-operative causes, including infection of various etiology, spontaneous rupture of bullae cysts, percutaneous biopsy aspirations, and erosion from the malignancy or foreign bodies. So again, this is how a pictorial identification of a alveolar-pleural fistulas and bronchopleural fistula, where we can see that bronchus all the way leading to the pleural surface. So for known reasons, the bronchopleural fistulas are more common on right side pneumonectomies compared to the left side pneumonectomies. So it is because of lack of mediastinal coverage on the bronchial stump, lack of dual blood supply on right side as compared to left side, and vertical orientation of the right main bronchus, which results in pooling of secretions as well as leading to the secondary infection and dehiscence. Most commonly it occurs post-operative day 8 to 12. So there are, apart from these anatomical risk factors, there are many patient-related risk factors, which depends on the lung resection, to the extent of lung resection, residual or recurrent cancer at the stump, infections, diabetes, steroids, etc. So diagnosis, the central airway related bronchopleural fistulas were very easily diagnosed clinically. Small airway are the one which requires non-invasive CT and scintigraphic studies. CT is not only useful in identifying the fistulas, it is also useful in identifying the number underlying pathology which aids in the treatment planning. So before going to the abnormality, so let us see how normal post-op pneumonectomy cavity looks like. Initially it is completely air filled. Gradually it is filled in with fluid, and over a period of time, the post-pneumonectomy cavity is completely opacified. So when to suspect bronchopleural fistulas in post-op chest X-ray? So either it is appearance of the new intrapleural gas, or failure of the pneumonectomy cavity to fill in with the fluid, persistent or progressive pneumothorax, persistent or progressive increase in the subcutaneous emphysema as well as mediastinal emphysema, any drop in the height of the pre-existing air fluid level in the pneumonectomy cavity, consolidation in the normal lung. That is also one of the sign of a fistula in plain radiograph, which is because of spillover of the fluid from the pneumonectomy cavity. So this is exactly the opposite of sequence of events we have seen in the normal. Then it is completely opacified in post-pneumonectomy cavity. Gradually there is an appearance of new air, and which is increasing in size, and CT we can see the dehiscence of the stump. Though radiographs can give indirect signs of bronchopleural fistula, but it cannot localize. That is the limitation of plain X-ray. Coming to the CT, before going to the pathology, when you are shifting the patient to the CT gantry, please take care of preventing aspiration of the fluid from the post-pneumonectomy cavity into the normal lung. By doing so, we can put adequate drainage catheter before shifting the patient, or keep the normal lung on the upside compared to the pneumonectomy cavity. Whenever possible, acquire the CT images with sub-millimeter thickness, where we can reconstruct post-process using advanced reconstruction algorithms, so that we can better visualize the fistulas. So large fistulas, we don't have any difficulty. Most of the time, the bronchus will be leading to the pleural surface. The one must be very careful when you are analyzing the small, subtle, indirect signs, that is, extraluminal air bubbles at the post-op stump. So this is one example where we can see, this is the post-op right upper lobe cavity, but we can see there are a lot of other small air pockets, which is indirect sign of this fistula. We should always look for carefully the thin bronchopleural fistulas leading from the stump to the post-op cavity. So here we can see that the initial post-op X-ray, and later after 3-4 days of the post-op day, we can definitely see the increase in the height of the air. So CT is definitely initial modality of choice in identifying both peripheral and central bronchopleural fistulas. So peripheral bronchopleural fistulas are identified when there is clear-cut disruption in the visceral pleural surface. Advanced multi-reformations are useful in viewing the images in different planes, where we can clearly demonstrate the fistula. So coming to the few examples, here we can see there is small subpleural cavity which is given away into the pleura. So on coronal reformated images, this is alveopleural fistulas. There is no bronchus leading to the cavity. So this is most common cause of spontaneous pneumothorax, as we all know, where we can see there is disruption of the visceral pleura. We have to carefully look for the visceral pleural disruption. This is one more example where we see a lot of holes in the lung, but you should always pay close attention to this white line, that is visceral pleura, where focal disruption will lead to the pneumothorax. So pneumothorax, multi-advanced reformations not only useful in identifying the bronchopleural fistulas, it can aid in accentuating the fistulous tracts. So if it is single subpleural blebbar cavity, it's very easy to identify, but when whole lung is emphysematous, then it is a very difficult cases to identify the bronchopleural fistula. Just try to trace this white line, where we can see there is focal disruption on the white line, that is the potential site of the leak. So another few tips I can say. So whenever you are looking for the bronchopleural fistulas, always look for the site of maximum thickness of the pneumo, where most of the time the culprit will be. So identify the site, size, number of bronchopleural fistulas. When bulla are the cause, usually CT has limited role because of very thin wall or different orientation of the fistula. This is one example where there was a large bullous, ruptured bulla, which was visible on the CT, but we couldn't localize from where it is leaking. But fluoroscopy was demonstrating the bulla was collapsing with respect to the phase of the respiration. So what is the advantage of doing reconstructions is when you are tracing the bronchus on the axial images, it's very difficult unless you see in the cine mode. But in reformatted images, it can be easily visualized on the so another example of where we can sometimes see in coronal reformatted images, we can see only short length of the fistula. But if you do curved reformatted images, we can all the way trace back the main bronchus, which is the source of the fistula. So this is same example and follow-up where we could block the corresponding segment of the bronchus with sparing the rest of the lung. One more example where the importance of identifying exactly the site of bronchus and segment involved. So in the post-occlusion, we have put blocker in the corresponding segmental bronchus because already lung is bad, which is compromised. We can't compromise more lung in these cases. And CT is not only helpful in identifying the fistula, but also in the underlying pathology. In this case, it was a tuberculosis cavity, which has resulted in rupture into the pleural cavity, where we can see the post-occlusion, there is complete resolution of the pneumothorax. So one more example is when we see on the axial images, sometimes we feel it is just alveopleural fistulas, but on reformatted images, we can see there is bronchus leading to the fistula, it will convert into bronchopleural fistulas. One more example, on axial images, we can see only small cavity, but on coronal reformatted images, it is the bronchus which is leading to this thing. But what is the advantage of this? Because whenever there is bronchus leading to the pleural surface, definitely it needs more surgical intervention than compared to the just alveopleural fistulas. So some authors have tried using contrast CT after bronchoscopy, but I think this use is obsolete in the present day advanced CT machines. So CT is definitely most useful and imaging modality of choice, but when there is bulle or the cause of pneumothorax, probably we have limited limitations in identifying the fistulous tracts. So nuclear medicine is having limited, earlier it used to have important role, but with the advance of thin slice, multi-slice CTs, I think it's no more used as a practical aspect. So using nuclear scintigraphy, the specificity and sensitivity is very high, but it needs utmost patient cooperation. In uncooperative patients and critically ill patients, it's often difficult to demonstrate the fistulas. So can a radiology play an important role in clinical management? Yes. Depending on the whether fistulous tract is single, multiple, it is coming from the single lobe or single segment or entire lung, definitely we have to block the corresponding, if the fistulas are corresponding to the single bronchus segment, we can go and occlude the single bronchus without compromising the other healthy lung. So underlying cause of BPH should be identified and treated along with the fistula itself. So studying anatomical relationship with some of the important complications, that is pseudoaneurysm following the either cavity, tuberculous cavity, whatever it is, and hypertrophic bronchiolitis have to be addressed simultaneously before going for the treating the bronchopleural fistulas to avoid dreaded complications. One study has correlated when CT was showing the bronchopleural fistula on CT, so there was need for more surgical intervention compared to the non-identification of the bronchopleural fistulas on CT. That is because most of the bronchopleural fistulas which we have identified on CT is bronchus which is leading to the pleura, whereas alveopleural fistulas are the one which is self-limiting, can limit it to the bronchus. So in summary, whenever there is new air in the pneumonectomy cavity, always suspect bronchopleural fistulas. CT is useful in identifying and localizing the fistula and number of fistulas and underlying pathology. And when fistula is seen on CT, definitely it is candidate for surgery most often. And when ruptured bulla or the cysts are the cause of air leak, we may often not be able to identify in the CT. Thank you.
Thank you so much, Dr. Harish, for a really comprehensive overview of the radiological features of bronchopleural fistulae. The audience, if you have any questions, please, we have a few couple of minutes for questions if anyone would like.
Dr. Harish, thanks a lot. Now the question is clearly that how does the pulmonologist get a handle on this? First of all, our radiologist geared up towards helping us, because now you're not only looking at it from the point of etiology, you're looking at it from the point of view of fixing the problem, which is either some sort of bronchoscopic strategy, which is the main focus of today, or a surgical strategy. So what tips would you give them? How would you look at a CT differently compared to what you were doing before from the point of view of prolonged air leak?
Yeah, whenever there is a clinically pulmonologist comes to us with persistent air leak, so unless we identify a bronchus which is leading to the pleura, it's challenging cases. Most of these cases are related to the emphysematous related changes. But when there is bronchus leading to the fistula, so it is our duty is to identify as many number of fistulas are present. Sometimes what happens, there will be one fistula which is corresponding seen in the only one particular segment. But most often we see there are multiple bronchi fistulas leading from upper lobe as well as lower lobe. In those cases, we need to identify and recognize those fistulas where we have to block the corresponding, multiple segmental bronchi. That's the one thing.
The second question was related, that since we don't have access to collateral circulation strategies here, like the Chartis system and so on, how important is it to look at the fissure and so on in case we're planning endobronchial strategy?
Yes, sir. This is often useful in particularly when there is a lot of emphysema. So fissural discontinuity is one finding we have to look for when there is persistent air leak in spite of occluding the visible bronchopleural fistulas. So visual disruption, again, one more problem with these patients. If the patient cooperation is good, image quality is good, we can easily identify the visual disruptions or discontinuity, which is normally seen in up to 20% of the normal individuals. But when patient is not cooperated and scan quality is poor, then definitely we have some limitation in identifying that visual discontinuity also. But you have to always look for visual discontinuity in spite of optimal occlusion of the visible bronchopleural fistulas.
Yeah, so just wanted to ask that, CT scans are performed, and is there any specific strategy or a reading or a reconstruction strategy which you recommend, or all these can be missed on a cursory examination of a CT? I mean, because there are radiological, interpretation variabilities at all levels of practice.
Yes, sir.
So what do you recommend?
Yeah, one is particularly for bronchopleural fistulas, because otherwise more than 1.25 usually we reconstruct images. But when we are dealing with the bronchopleural fistulas, always we can reconstruct image as thin as 0.6 millimeters. Those are very important, particularly when you want to, and most of the time I would recommend you to view the images in the workstation rather than in our department systems, in laptops, whatever, or computers. Because in our reformation and in our console in the CT room or our workstations in reporting room, have better resolution of screen, and we can reconstruct using multiple planes. That's what I advise, rather than seeing images in your respective OPDs or wards. I would recommend you to always review the images in the CT room.
Thank you.
I didn't hear you.
PET CT. The question was, how does PET CT add, if at all, any information to
PET CT has
localization?
no role in bronchopleural fistulas except identifying the cause, particularly sometimes if there is tumor recurrence or residual tumor in that bronchial stump. So that is the only indication for PET CT, because PET CT images are too thick for identifying bronchopleural fistulas. Even if you recon PET CT images, image quality is very poor. We don't often recommend.
And so how the nuclear medicine help in localizing BPF? What exactly the mechanism is, as you mentioned?
No, nuclear medicine, usually whatever, when we inhale the xenon aerosol, so there will be equilibrate between the lung as well as the pneumoctomy cavity. That's how it identifies that there is bronchopleural fistula. But problem is it can't exactly localize where it is. And some patients, particularly in COPD, because of breathing movement, so it can mislocalize the site of leak. It just says there is fistula, particularly when it is beyond the resolution of our CT.
Whenever we put ICD and ask them to cough, if it is severe during inspiration and expiration also, you can see a bubbling. That's why we say that it is a BPF or rarely clinically. But in a radiologically, you do any maneuvering, like you make
No.
inspiration and expiration, ask them to cough and do a particular way of doing it as
CT
a protocol.
CT is very sensitive for motion, so we need utmost rest. I mean, cooperation from the patient. We don't ask patient to, because we have to hold the breath while scanning the patient. So there is no role for these maneuvers. Only thing we would recommend is put negative pressure and suck as much as possible lung towards the chest wall, so that we can see more, we can stretch the visceral pleura and we can identify the collapsible nature of the bronchopleural fistulas. That's the only role.
I think move on to the next talk. Thank you, Harish. Overview and classification of persistent air leak. I welcome Dr. Karan Madan. He is a faculty at AIIMS Delhi. Over to you.
Thank you, Chairpersons. Can we have the slides, please? So at the outside, I'd like to thank our dear friend Dr. Ravi for inviting me for this topic. Giving an overview about BPF, I think it's a non-interventional overview before the interventions actually begin. So I'll give you a brief overview of what this problem means and what clinically the consequences of this problem are, and how you basically at the bedside decide that whether there is a leak or not, what are the causes, and what are the physiological mechanisms that how it actually impairs the outcomes and the patient clinical status. That would be the focus of my talk. So do we move the slides with this? Okay, yes. So first the question is that we are talking about persistent air leak, and as was alluded in the previous talk, the leak is basically from the visceral pleural surface. If you actually see that there is the parietal pleura and the visceral pleura, the approximation of the parietal and visceral pleura is essential for breathing, because what we essentially do is kind of a negative intrathoracic pressure generation. When our inspiratory muscles move, they draw out and expand the thorax. That transmits the pressure to the pleural cavity, which becomes more negative. And because of this negative pressure inside, the air gets sucked in. So that negative intrapleural pressure is essential for our breathing mechanics. And that can only be achieved once there is a complete visceral pleural integrity. If there is any loss of the visceral pleural integrity, that means that negative intrapleural pressure cannot be achieved, and that is going to set off all the breathing dynamics. So that is the essential problem. What you are dealing with, a leak or a disruption in the visceral pleural surface. It can be a very peripheral disruption or it can be a central disruption, and the degree of leak actually depends on how big the disruption is and how large a bronchial communication with that disruption is. So that is the basic mechanism of persistent air leak which we are talking about here. Now coming on to what's the basically how do you, it's not working here. Yes. So this is the basically a communication between the alveoli and the pleural space, and as you would understand, once this communication happens, there is a leak of air from the visceral pleura into the negative intrapleural, the pleural space, and that leads to development of essentially a pneumothorax. So whenever a patient has this alveolar pleural fistula or a bronchopleural fistula, most of the times what you would be dealing is that there is going to be a pneumothorax, there is going to be a separation between the pleural spaces, and you'll get a pneumothorax. Now majority of pneumothoraces clinically in our practice get okay with the intercostal tube drainage. But if you get that bubbling in your intercostal drain persistently, that indicates that there is a visceral pleural disruption and air is somehow leaking through. Now this has multiple problems. The mere fact that an air is leaking from the visceral pleural surface actually impairs the healing process, and I will show you in the subsequent image what the physiological mechanism is. And as far as the definition of a persistent air leak goes, we have to actually give a definition. If following a tube thoracostomy, your bubbling or a leak does not stop within 5 to 7 days, that is defined as a persistent air leak. Now this actually cartoon, very beautifully summarizes what actually happens once you are dealing with, this problem. So if you notice on the first cartoon, this is essentially, once a fistula, develops. In a normal healthy person, there is a lot of negative intrapleural pressure. And once you get that fistula, now that air is leaking into the pleural space. So now essentially what it would do is that the pleural pressure would become more positive. Once this becomes more positive, it pushes the lung medially. So your lung tends to collapse. Now once that lung tends to collapse, transiently your fistula gets closed and it stays at, say a midpoint or some point. Now essentially once you breathe again, the air gets out from the fistulous tract. It makes your pleural pressure more positive, and on the subsequent breath, once the pleural pressure increases, it deflates the lung even more and the fistulous tract, whatever. Now where, there's a balance point. If it's a very, very large leak, your balance point won't be achieved and the fistulous tract will remain open. And this will be a continuous leak happening and lung will be completely deflated. On the other hand, if the tract is a little small, you might get a situation in which at a midpoint or at some point, you get some equilibrium. And this is how, basically you gauge that how, big the fistulous tract is. And sometimes if you deal with a completely collapsed lung, this actually sometimes indirectly may tell you that you're dealing with a slightly bigger leak. Now, what are the clinical consequences? What does it do? One thing is understandable. The first consequence is that your lung gets deflated. Now this means that there is, so can anyone tell me, what would that happen? There is going to be, shunting. So what it's basically doing is, and a ventilation perfusion mismatch. Because this lung is deflated, the oxygenation is going to get, impaired, and the patient can get, ventilation problems or a hypoxia. And the second major problem is that because if the pleural space gets contaminated, it can lead to a flood of the infected secretions into the bronchial tree and a contralateral lung infection. So sepsis is one of the major problems which leads to the poor outcomes in these patients. And in many patients actually septic shock is a cause of mortality. That is why closure of the leak becomes important, because that is the problem. So these patients may have a long chest tube duration, prolonged hospital stay, they have higher resource utilization, higher morbidity and mortality, and it's a very, very frustrating clinical condition for both the clinicians as well as the patient, because the patient is having a drain and the clinician is actually continuously having to deal with these infectious complications. And varying depending on the settings, a very high mortality rate has been also reported. So these are the causes, mostly it's a post-operative setting. Most of the Western literature is on post-operative BPF, but we see a lot of causes of benign BPF, and amongst these the most common remains the pulmonary infections. If you see the previous images were also there, I think tuberculosis and an infected pleural space infection, pneumonia and empyemas also contribute significantly to these problems. Other common condition is an emphysematous or a secondary spontaneous pneumothorax, in which the underlying lung is diseased and you get these leaks. We have a talk on mechanical ventilation. It's a separate topic. Following chest trauma. And another common, it's not a common cause, but with a lot of pulmonary interventions happening, like transbronchial biopsies or thoracentesis or image-guided lung biopsies in a diseased lung can also be associated with prolonged air leaks. So this is, the classification system which is, accepted. This is the Serfolio classification system. Essentially, this was developed for post-operative, leak settings. So basically, you have these 4 categories of leak. The smallest leak is the grade 1, which is actually a forced expiratory leak. Now that you can understand, if the leak is happening on a gentle breathing, this means that the fistulous tract is kind of a bigger tract. And if it's only happening on a prolonged expiration, this means you're having to generate a lot of intra-alveolar positive pressure to get that leak, this means it's a small leak. So it's a forced expiratory, grade 2 is expiratory, grade 3 is inspiratory, and grade 4 is a continuous leak. And it's important to note that most of the leaks, if you see data, are forced expiratory or expiratory leaks, which usually would heal with conservative measures. If you have a patient which is getting a bubbling which is near continuous or an inspiratory bubbling, on the bedside that you are dealing with a large leak. This is important. If on an inspiratory, in a gentle inspiration, bubbling is happening, you can just say that it's going to be a large leak. And in this patient, conservative measures may not work very quickly. So, how do you identify? There are, various drainage systems. These drainage systems should be used because they have a physiological and a clinical sense also. Otherwise, commonly what you see is a single drainage bag or intercostal drain, which most of your patients have. What it essentially means is that the infected fluid and air is all bubbling into that single bag. Now, if you split up this drainage, you can have a 2-bottle or a 3-bottle system. What it essentially does is that if you get those, the infected secretions, they just fall into the first bottle, which is the trap bottle. So, the infected fluid goes into the trap bottle and the water seal is in the second bottle. So what it essentially does is, it does not allow movement of this infected fluid through and through your tube. And this is kind of makes sense that the infection does not worsen and drainage keeps on happening. So the first is the trap bottle, second is the underwater seal bottle, and third is actually the manometer bottle, that if you're attaching suction, the level of bubbling in that third bottle would actually tell you how much suction is being applied. But now we'll also have one talk on ambulatory leak devices, so you will get more clarity on how to monitor suction during the these maneuvers. There is a talk, I would skip this topic, which is the digital drainage systems. These are ambulatory, new pleural drainage devices, which actually allow you to apply suction, gauge the amount of leak, and also, get these secretions in a separate bottle, which can be, detached from patient to patient. The other thing is a post-operative BPF. The reported incidence is between 1.5 to 28%. Rates following lobectomy are a little low. And as was, alluded in the last talk, there is a higher incidence for right pneumonectomy and right lower lobectomy as compared to left side pneumonectomy. The left, bronchus, if you all know, is a longer bronchus, because the right main bronchus divides very quickly into the right upper lobe at a distance of about 1 to 1.5 centimeters, whereas the left bronchus is longer. So the chances of dehiscence are little less on the left side. BPF is a little more common in malignant etiologies, and other reported risk factors include a radiation or a chemotherapy. If your patient has got radiation or chemotherapy, the risk of BPF is actually increased. So this actually summarizes the reported risk factors from various studies. These would vary. This is a combined risk factor summary based on post-surgical, post-lung volume reduction surgery and other setting. So these basically include COPD is a major risk factor in females. Poor lung function. If your lung function is poor, smokers, diabetes, steroid use. Many surgeons are quite reluctant to operate patients once these patients are, have received a recent course of steroids. That also holds true for central airway surgery as well as, lung surgery. Diffuse emphysema, older patients and larger bullae, these are the risk factors. So I think that's all, because it was essentially an overview. Basically, it's a bedside, decision making and how do you take calls.
I'll invite questions from the audience. We do have. I also want
Our online audience to know that they can send in questions as well. We will be looking at the questions sent in by the online audience as well. Dr. Dharmesh, you had a question.
Regarding the underwater seal, I'm sure our mind is from the issue of the underwater seal. How does that help? What's its function? And on looking at the underwater seal, reflect what's going on in the vessel.
Yes, so essentially it's the bubbling. What you actually get is the bubbling. So where, at what point of time you're getting a leak, basically the expiratory, post-expiratory, that's the common thing which we see. So I think these are not accurate, estimates of what your leak is going to be. But I think on a bedside, what you need to take a call is that if the leak is on, coughing and you need to make an effort, then the leak is likely going to be a smaller leak.
Again, Pawan might be touching on it. There are some dry system drainages, right, where you don't apply the water seal. It's an nappy drain.
So we'll have that on the ambulatory devices, Doc.
So one of the questions that came up is on one of our online attendees has asked a question that the pleural space fills with fluid after a pneumonectomy. Is there some thing that helps to determine whether the fluid is related to a dehiscence or a BPF formation, and it's not the normal fluid that one expects as a drain in the pneumonectomy? So I don't know if the question is about whether there's any markers or indicators, radiological or in the character of the fluid. I think Dr. Harish already mentioned the changes that we see radiologically. The question is probably about the character of fluid. Does that tell us if there is a change in character that one is looking for, which says this is not the normal drainage, but is because of a BPF?
I think we'll have a surgical input also, because I'm not the expert on the nature of fluid, but I think it's going to be by the logical if it's getting infected or it's purulent and those. But I think for a leak perspective, it will still be bubbling in the drain and your clinical decision making.
Thank you. In the interest of time, what I'm going to do is go ahead with inviting our next speaker. Thanks, Dr. Karan. And what we can do for everyone is that we'll also have a few minutes for discussion at the end of all the 4 talks of this session. Our next talk is actually going to be an online lecture, and this is about the management principles, an overview of the management principles by Dr. Melvin Tay from Singapore General Hospital. Thanks.
Good morning, everyone. Thank you, Prof. Ravindra, for this kind invitation. So I'm really very happy to be here today to be sharing with you on some insights on persistent air leak. I'm just going to go through principles of management, but there might be some overlap with the previous 2 speakers, and during which I will just fast forward a little bit. Okay, so let's get started. So objectives for today are very simple. First, we're going to revisit some pathophysiology in persistent air leak, and as well as the physiologic effects of chest drainage, and then common chest drainage systems just a little bit, and finally to review the therapeutic options for PAL. So as mentioned by Dr. Harish, so basically the persistent air leak can be classified or categorized into either post-operative, right, which are usually the bronchopleural fistulas, as well as the non-operative or the alveolar pleural fistula. So I like to use post-operative, non-operative, so that would be sort of the nomenclature that I'll be using for the rest of this lecture. So also, I think Dr. Karan touched on this. So the problems with having a persistent air leak is that is threefold. Okay, number one, there is a breach in the pleural space sterility, right? So there's communication between the non-sterile airways as well as the alveolar sacs with the sterile pleural space. And number two, this may also compromise the respiratory status of patients, especially those on mechanical ventilation, and the effects can take place in the form of worsening of the VQ mismatch, or it can affect the maintenance of PEEP and also reduce the tidal volume. And number three, obviously, because the complications would be that it's bad for the patient, right? So they have a higher morbidity and mortality, and mortality can be as high as 70%, and they have longer chest tube duration, which leads to a longer hospital length of stay, as well as higher resource utilization. And moving on, so I'm going to touch a little bit on pleural mechanics. I'm also an intensivist, so I love physiology. So to facilitate the understanding of pleural mechanics, right, we have to just examine three pressures. Okay, so number one, the pulmonary pressure is actually essentially the difference between the airway pressure as well as the pleural pressure. All right. So as you can see, the figure on the left, right, it actually just shows you how the pressures are being measured. So the subject here, he breathes through what is called a pneumotachometer that actually measures airflow. And it's also connected to a pressure transducer that measures airway pressure, right? And then at the same time, there's also another balloon catheter that goes into the lower esophagus that measures the pleural pressure. So what you need to take home is very simple, okay? So in normal breathing, right, spontaneous breathing, the pulmonary pressure that is generated during, that generates tidal ventilation, right, is the result of cyclic changes in pleural pressure, all right? But on the other hand, during mechanical ventilation, it is, right, the transpirant pressure change, right, is actually the result of cyclic changes in the airway pressure, right? And this is the defining characteristic that differentiates between negative and positive pressure ventilation. And moving on, I'm just going to show you some scalars, okay? So I'm just going to bring you through, so don't have to worry about it, all right? So this is a spontaneously breathing patient, and as you can see that the figure here is actually a representation of the morphology of the waveforms pertaining to pleural mechanics in 3 different scenarios, all right? So column A, which is marked in blue here, right, takes place during normal spontaneous breathing. And column B here, right, which is marked in red, it shows the presence of a pneumothorax. Maybe let's be, an arbitrary size of 20%. And the third column, right, it represents the scalar after the insertion of a chest tube with a persistent air leak. Okay, so I just want to direct your attention to this part of the diagram here, right? So as you can see, during spontaneous breathing, right, because the pleural pressure becomes more negative, right, and then there is a mirror image, right, in the transpulmonary pressure, right? It's actually sort of like a mirror image, right? So as the pleural pressure becomes more negative, right, this is what we've talked about, the cyclic change in the pleural pressure that generate the transpulmonary pressure difference, right? I mean, transpulmonary pressure change, right? And generating the so-called mirror image. And as you can see, in the presence of a pneumothorax, what happens is that the pleural pressure becomes less negative, right? And so there's an upward translation of the scalar, right, from normal, right? And you can also see, because of the that less negative pleural pressure, your transpirant pressure is going to suffer a corresponding decrease, right? And this pattern, right, is actually normalized after you put in a chest drain. And I just want to highlight, as you can see here, right, it doesn't, in the tidal volume, it doesn't go back to 0, right, because there's an air leak. That's all. And moving on, also, this is the case whereby a patient is on mechanical ventilation. All right, so just imagine this is just a imaginary patient who is being put on pressure control ventilation. So you can see that the airway pressures, right? Airway pressures, right? And then you can also see the pleural pressures. So how does this differ from the previous scalar that we saw, right? So as we can see that the transpulmonary pressure in the presence of a pneumothorax, right, in pressure controlled ventilation, because the machine, right, the machine is already sort of like calibrated to deliver the airway pressure. So it's going to continue, it's going to give as much pressure, right, until the airway pressure is being reached. And that's why you see that the airway pressure doesn't change, doesn't change. But in the presence of pneumothorax, you can see that actually the pleural pressure is actually less negative than normal, right? And therefore, this actually results in a corresponding decrease in the transpulmonary pressure, right? And also a less tidal volume, right? And that's why sometimes in patients who are with airway obstructive airway disease exacerbations, right? I tend to just use volume control because I want to make sure the tidal volumes are stable, all right? And then you can also see the same pattern that after the insertion of a chest drain, the scalars actually sort of remain, get sort of converted back to normal, right? But always doesn't return to zero in the tidal volume because of a persistent air leak. Okay, and I think Dr. Karen has also gone through the Cerfolio classification, so I'm not going to go through, but I'm going to ask you this question, okay? So in grade 2, why does the patient, right, actually have bubbling during the expiratory phase only? So just hold that in mind. We'll come to the answer in a while. Okay, and in order to better understand pleural mechanics, right, we first need to appreciate that the fact that the chest drainage system, right, as cliches as it sounds, it's like a window to our pleural physiology, all right? And then we already know that the fluid level in the underwater seal varies with respiration, right? So when this normal respiratory variation is lost, it means that the chest drainage system is no longer exposed to intrathoracic pressures, right? And then reasons of this, obviously, clinically by the bedside, you'll be like looking at the tube, whether it's king, whether there's a lot of secretions, clots, whatever, do an X-ray to see whether the chest tube position is in place or not, etc. Okay, so the next part relates to the question I asked earlier, right? So I think it is quite self-explanatory, right? When you cough, you generate positive intrathoracic pressure and you're going to cause bubbling, and that's pretty easy. But what about grade 2, expiratory phase only? All right, so let's try to visualize this for a moment, all right? So if you imagine the pleural space, right, and then with the chest drain inside, right? So if the air leak, right, is being drained, right, just nicely by the chest drain, right, actually the pressures will be sort of in equilibrium, okay? But the problem is when we put in a chest drain, especially, right, if we put in suction, right, and we usually connect it to suction, the local pleural pressure, right, is actually a bit negative, a bit more negative than normal, okay, than normal. And during inspiration, what happens is that during inspiration, your pleural pressure actually becomes more negative, right? Okay. And sometimes this local pleural pressure can become more negative than the negative pressure in the chest drain. That means, right, when this happens, air actually accumulates in the pleural space, right? And therefore, when doing expiration, the entire process, right, is in reverse, right? And that's why when doing expiration, the air that has the small pockets of air that has accumulated, right, due to the local pressure problem in the pleural pressure during inspiration will get evacuated during expiration. And as Dr. Karen has mentioned earlier, continuous bubbling, right, or during inspiration, right, it means that it just indicates a very large air leak. Okay, we're going to finish up on the physiology part. Okay, so talking about lung compliance, right? So I think it is important to understand that the effect of suction, right, is dependent on the lung compliance, right? So a lot of people, right? You want to say, okay, you want to have suction, and then maybe you can evacuate the air faster, right? But there are problems. So the one important thing to note by the bedside is look at the swing, right? The swing of the of the water level in the underwater seal, right? How it oscillates, right? If there are very, very big swings for whatever reasons, this suggests that actually the lung is actually poorly compliant, right? So that means that, the lung is just stiff, right? And therefore, increasing the amount of suction or the suction level, right, may not be the wisest thing to do. In fact, it may cause more harm, right, because it can distort the local pleural surface and injure the local area, all right? So that is one important point to remember. Okay, and now I'm just going to direct you to the normal pressure volume curve of the lung, right? So as with Frank Starling curve of the left ventricle, the same thing is sort of replicated many times in human physiology. So as you can see that the best part, right, to breathe on, right, would be the most compliant part of the PV curve, right, which is this area, okay? So using Campbell diagram, I'm not sure whether you're familiar with it, right? But Campbell diagram, actually, it will sort of like tell you how the presence of a pneumothorax actually affects your lung mechanics very beautifully, right? So just to let you, you know, for those of you who are not so informed, not so familiar with this, so you can see in this diagram here, right? So there's a pleural pressure against the TLC, right? And then you can see the solid line. The solid line is actually plotted, right, by pleural pressures developed by the chest wall, right, during a slow active inspiration, right? And then the dashed line here you see, right, it actually corresponds to the elastic pressure of the completely relaxed chest wall, okay? And you can see that where it crosses is where the functional residual capacity is, right? And then this is the part of the curve, right, that the lung is breathing on, right? So in the presence of a pneumothorax, right, what happens is that the pneumothorax obviously will sort of occupy space, right, within the pleural space, okay? And that actually decreases your lung volume, right? So you can easily appreciate that in the presence of a pneumothorax, the resting FRC drops, okay? And therefore, you're now breathing on the less compliant part, right, of the PV curve. Simple. So when this happens, obviously, you are actually performing a lot of inefficient work. That means that you need a big effort just to produce a small amount of work, right? And you can see that the area this is highlighted is actually the work of breathing, okay? The work of breathing and generated. So therefore, the lungs need to work a lot harder, right, in the presence of a pneumothorax. Okay, good riddance with physiology. Okay, and finally, I think this is the meat of the part, of the talk. I'm just going to review the therapeutic options for PAL. Okay, and I'm just going to first highlight, obviously the most traditional and the most immediate one for any pneumothorax is chest drainage, right? And in terms of suction, right, obviously the jury is still not, there's still no consensus, right, when it comes to the effect of suction on PAL healing, right? Those in favor of suction, right, would say that, yeah, you need to evacuate the air, right, at a rate that is greater than the air leak, right, so that the lung surfaces can oppose, and then this is, causes a resolution of the pneumothorax, right, while, the detractors, right, on the other camp, right, they will say that, yeah, but, if you have a lot of if you take away suction, then the flow, right, and just put it to underwater seal, then the flow through the defect, right, it would be much lower. And this would sort of like promote healing, right? So, but unfortunately, all the studies that have been done that aim to address this conundrum, right, has not been very conclusive, right? And finally, we just need to consider three factors when evaluating the PL, right? Number one, is the volume of the severity of the air leak. Number two, the trend, right, which is to say whether the volume or the severity, is it increasing or decreasing? And number three, duration. So I think just going to skip this. So as a chest drainage system has already been discussed, and there will be another one on the ambulatory drainage systems later. All right, but just to highlight, these are the two commonly used systems in Singapore. So there's a ProEvac chest drainage system, right? And then there is a multi-column graduated air leak chamber to estimate severity, right? So the number of columns that are bubbling, right, is directly proportional to the severity of the air leak. And certain thoracic surgeons, I've also seen them use the Topaz digital or Topaz Plus, okay, digital chest drainage system, right? And it can measure the air leak in mils per minute. At the same time, also dynamic real-time through pressures. And there have been some small randomized studies, as well as I think maybe one international one that said, it reduces chest tube duration, patient satisfaction, hospital length of stay, and cost. But take it with a pinch of salt. Okay, and then I'll just skip this and sorry. And finally, we'll talk about the therapeutic options in PAL. Okay, so the take home or the takeaway is that a patient who is a surgical candidate and agrees for surgery, right, should be given operative treatment, right, because it is the most definitive, right? If not, the strategy is just to either wait or intervene, right? Because we know from research, right, even an old study from Singapore, my seniors, that air leaks from spontaneous pneumothorax, whether it is primary or secondary, will resolve, right, if you give enough time, right, usually by 2 weeks, all right? But we have to balance this against the cumulative risk of pleural infection, right? The longer you have an indwelling catheter in the pleural space, the higher the risk of infection. And finally, when you decide to intervene, or there are factors, that we have to consider, things like etiology, the ability to localize the fistula, as well as expertise. All right. And obviously, the latest, right, just recently published, the British Thoracic Society guideline for pleural disease. So it's just a good practice point that they mentioned. Right, so if a patient is not considered fit for surgery, then you can either do autologous blood pleurodecies or endobronchial therapies should be considered for the treatment of pneumothorax with persistent air leaks in adults. So we are just going to go through the various options, right, of PL treatment, right? So number one, we'll talk about a little bit about medical pleural disease, right? So the pleural disease can be medical, is either you use chemicals, right, such as tetracycline, ALK, and obviously also autologous blood pleural disease, right? So tetracycline, it has been shown, right, to reduce the pneumothorax recurrence, but not usually as a secondary as in a recurrence prevention, but not so useful if in the cases of persistent air leak, okay? And TALC may be better, but the data is also a bit murky because it's extrapolated from non-comparative data. In terms of autologous blood pleural disease, right, I think there was an older review, maybe more than 10 years ago, took into consideration quite a few studies. The overall success rate was actually about 93%, right? And also there was a study that was done also around the same time that showed that with 1 to 2 mils per kg of blood, right, it's probably better than using 0.5 mils per kg, right? So, and that's how you get, and if you read in the literature, it's always between 50 mils to 150 to 200, right? Because it's 1 to 2 mils per kg, most effective, up to 80, more than 80% success in terms of healing the TAL. And next, we have sealants. I think I'm sure later during the practical sessions, you will be exposed to some of this. So the sealants can actually be categorized into 3 types, okay? So there are tissue adhesives, there's hemostatic agents, and sclerosants, right? And then depending on where you are, in which part of the world, right, you may be more familiar with certain types, right? For example, in Singapore, I think my interventional radiologists use a lot of fibrin glue, right? And I think it really depends, on the country, right, and the part of the world that you practice. Okay. And number 3, the third category would be valves. So there are two valves that are available in the market. So there's a Zephyr valve, which is from Pulmonx, right? So basically, and also there is a spiration valve system that is from Olympus, right? And both valves, right, are actually Nitinol framework valves, right? And then the way to tell them apart is that you just need to know Zephyr, the Zephyr valve, right, looks like a duck bill, right? And then the other one opens up like an umbrella, all right? So the success rates, right, if you look at it, right, one important thing I like to highlight in all the studies is that they are always talking about successful deployment. Okay, so successful deployment doesn't necessarily equate to successful treatment of the PAL. Okay, so I think if you really look carefully, so that's why like the Zephyr, the old study, there was like up to like more than 90% spiration, right? Depending on the etiology, right? So it ranges from 58% for like secondary spontaneous pneumothorax, like to 100% for iatrogenic causes of pneumothorax, which is like, you know, most of them don't even, most iatrogenic ones that we see, right, don't even need a chest tube, right? So have to be very careful with it. But obviously, I think there should be a recently, I think maybe more than a year ago, that was the VAST study, which is a spiration valve for persistent ALEC study, a VAST study that, you know, awaiting results to tell us a bit more about this. And also occlusive devices, right? Generally, they can either be spigots or the Amplatzer occluders. So the spigots, or sometimes called Watanabe spigots, right? So they come in different sizes, and you can just plug them in into the bronchopulmonary segments that you think are culprit. The Amplatzer one is actually used for usually the pleural surfaces, right? So basically, there's a breach in the pleural surface, and maybe you can use the Amplatzer occluder, which was originally developed to close atrial septal defect, right? And it's also a Nitinol mesh with a polyester fabric. I've only assisted actually in one of these cases, but I tell you, it's very difficult because, you know, the problem with all these pleural defects, right, is most of the time is the margins are terrible, right? It's inflamed, it's necrotic, right? It's not like a atrial septal defect where it is the tissue is normal, right? So this Amplatzer occluder thing obviously didn't work very well in our patient, right? And I think it may have very limited utility, but that is only my personal opinion. Yeah. And finally, miscellaneous. There have also been people who use laser to close up small BPFs. I think that was reported by the Japanese, like, you know, in the 1990s, I think. Yeah, and 8 patients, right? So they sort of like burn the ablated the margins, right, of the small BPF to induce edema as well as fibrosis, right? But I don't think, you know, I would suggest this. And obviously, there are also people using stents, different kinds of stents, either metallic or silicone, depending on the whether it's malignant, non-malignant, and have customized it, right? And they have published reports, including the Chinese. Okay, and so finally, this is just a summary slide, right, of the modality in terms of medical pleural disease, sealants, valves, occlusive devices, miscellaneous. And you have, when you look at the literature, you have to realize that actually a lot of, you have to see what kind of patients they are. Are they the post-operative ones or the non-operative ones, mixed or not? Huh? And the success rate also, like I said, be careful, because sometimes it's they will say successful, taxation of the ALEC, right? Some of them, they will quote more like a successful deployment of the valve, right? That's a very big difference, because if you look at, for example, the spiration, the study, right? the thing is, yeah, you may achieve like 58 to 100% success rates, right? But if you look at the data, oh, the longest, so the range of like the longest time it took to for the ALEC to heal, right? One and in few of the patients or one of the patients, right, it was 100 days. Okay, that's like 3 months. All right, so that's why I say, whenever we look at the literature, we really have to see what are the primary outcomes, right? Primary outcomes, because sometimes can be very misleading. Okay, and that's it. Sorry for rushing through, but I was given about like 20 minutes. I hope I have not overrun my time by too much. And thank you very much.
Thank you so much, Dr. Malvente, for the clarity with which you took all the participants through ventilatory pleural mechanics and an overview of sealants, pleurodesis, and more. I'm going to open it up for questions from the audience. We can probably have time for maybe a couple of questions. I think I also want to thank you for putting in that really philosophical question of what success really means. Is it a successful procedure, or what does it mean for the patient really? So thanks.
Yeah, Melvin, thank you so much. This is Ravi Mehta, and thanks so much. And your in-depth knowledge of physiology combined with the integration of critical care and spontaneous and mechanical ventilation is always so interesting to watch. So now the question was, I think the practice of, since you took the topic on overview, the practice of PAL therapy seems to be so different country to country, right? I mean, it depends on what you have, what you do, whether you are a pulmonologist oriented country, you're a surgeon oriented country, what do your laws allow, and so on. So we're just trying to put so much of this heterogeneous stuff into one mix to give one common message. It is quite difficult, I understand also, but is there some common thread you would like to leave for everybody, that this is the level at which you can go? After that, it depends on your infrastructure, skills, and so on?
Well, I think, if you really want to manage PL, so the basic principle is if the patient is fit for surgery, right, and you have surgeons on board, then they should be referred for surgery. And for those who are non-operable, I think it would be, at least looking at the BTS guidelines, I think autologous blood pleural disease may be a good, maybe a first sort of like a good option to do. Yeah, because number one, I don't think you need an interventional pulmonologist to do it, right? But even then, the ABP protocols, right, are very different across different parts of the world, right? So, for example, in persistent air leak, some people would clamp it, right? Whereas some of us will not. Like I personally do not clamp it. Yeah. And I like to elevate the chest drain so that, in a sense that the blood will actually go into the pleural space, cause pleural disease, or clot up the fistula, at the same time allowing some air to escape, right? So it doesn't cause a tension pneumothorax. But like I said, all these, I think you're right. There are no clear guidelines on how to do it. So, but I think, at least from now, I mean, from the existing data, one way of looking at it, if you have no patient cannot go for surgery, and then you don't have the more advanced things, right? Then maybe autologous blood pleural disease may be a good first line in those situations. Yeah. And then with regards to sealants, I don't personally use. They are used by my IR, my interventional radiologist, quite a lot. But at least from my observation of their patients, it's really 50-50. I don't think, because I think localizing the fact is really, really difficult. Yeah, by just radiology alone most of the time. Yeah. And then putting in all these devices, that's the other problem. The issue is you think that it's solving the problem, you may create another, right? So maybe you can plug it up, and then patient, gets an infection or an empyema or whatever, right? So at the end of the day, I think it's really quite philosophical. There is just no good way for me to sort of like algorithmize it into something that is very very easy to apply, right? But at least if you read the latest PTS guidelines, I think an ongoing discussion with the patient, right, preferences, right, and then the risk appetite and all those, I think it's still it becomes a very important part of this discussion. Yeah, that's my take-home message. Yeah. Sorry for that long reply. Yeah.
So I think we're just basically taking a science where we simplistically say, see some air, stick a tube. If it doesn't stop, figure out what to do, call a surgeon. And we've sliced, diced, and taken it to various levels of understanding, physiology, CT scans, and so many other talks, which are going to help to comprehend this better from a therapeutic point of view. Thank you so much. Yeah. Back to the chairperson.
Moving on to the next topic, ambulatory pleural drainage to latest devices. I welcome Dr. Pawan Kumar, our ex-Apollo colleague, is working in Mumbai now. Welcome, Pawan.
Introduction. So thank you, Dr. Mehta and Samir, for inviting me for this talk. Most of this part has been dealt in pieces with the previous talks, and I'll try to briefly go through the details on the pleural drainage devices. Not sure it's working. Yeah. Okay, so I'll be concentrating more on the pleural drainage devices, and in this talk we'll go through the indications of these devices, principles of ambulatory management, history of pleural drainage, and various pleural devices which are available in the market. So most of the ambulatory management is a conservative management. It's not working probably. Can you change the slide, please? Okay, see the ambulatory management is mostly reserved for the alveolar-pleural fistulas or small BPF. A larger BPF will require a surgical management or a bronchoscopic therapy, and these are the patients who are not surgical candidate or those who refuse for surgery. Those who are not candidate for bronchoscopic management, especially when you have extensive collateral ventilation, you will not be able to block a particular segment or multiple segments are involved. Then these patients should be subjected to ambulatory management. And if you have a pleural space infection because of these leaks, if there is a empyema, then it's mandatory to evacuate the pleural space, and that's how the ambulatory drain will come in picture. The conservative management is mostly based on the principle of you have to evacuate the air and the pleural space to assist the re-expansion of the lung, promote the natural healing of the air leak, and prevent contamination of the pleural space where the drain is inserted, as well as the contralateral lung to be protected from infection. So the advantage of the drain-based care is it's a very less cost involved compared to a surgery or a bronchoscopic management. There are many devices available in the market. The skills required to maintain these devices or put a tube are very simple and easy to teach. They reduce the length of hospital stay for sure. You can discharge these patients once the patient is clinically stable, and they are very useful for post-op alveolar-pleural fistulas, as Dr. Madan has pointed out, and previous speaker also pointed out, that 70% of BPF will heal on with ambulatory drain management only. So if you look at the evolution of pleural drain, it starts from the Hippocrates, which has described major medical procedures from 460 BC. They use the resection and open drainage so that the empyema is evacuated from the pleural space. The closed water drainage system has been used from 1875 and it has been rampantly used during the influenza epidemic of last century. 3-bottle system has been in use from 1950s, and the current disposable drain has been in practice since 1967. After that, it has undergone many modifications, which we'll see through few next slides. The ideal drain should have following components. There should be a drain tube which connects to the chest tube of the patient and to the device, where there is a collection chamber. There should be a valve. The valve will prevent the entry of the device content into the pleural cavity so that you protect the pleural cavity from pressure changes. If at all suction is desirable, then a suction control device should be there, and there should be facility for diagnostic pleural fluid collection as well as air leak detection, which is a topic of interest for today. So depending on the seal and the suction use, there are various devices available in the market. They are based on the weight suction and weight seal. There is a fluid-based suction, a dry suction weight seal, or dry suction dry seal, which we'll discuss with individual device. It's a matter of debate of whether there should be suction or no suction, but the argument pro for suction is that you remove the pleural content, the pleural air, the pleural cavity air fast, so that your visceral and parietal pleura comes together, they oppose each other snugly, so that you promote the healing. But the argument against this is that if the pressure, the flow of the air through the leak, visceral pleural leak, if it is faster, it will not let the pleural edges come together. So the water seal without a suction will promote that healing in the APF. It decreases the flow across the defects, so the opposition between the visceral pleural defect is better, the tissue healing is better, and the leak heals faster. There is no major consensus, but at present post-op air leaks, it is not recommended to put external suction, because as it doesn't show any benefit in terms of shortening of air duration of hospital stay, shortening of chest tube care, or any improvement in the air leak. The practice differs from institute to institute. Most of the surgical institute, what they do is post lung resection for 48 hours they put suction. After suction, they connect it to the underwater seal and see whether the air leak is happening, and the Surfolio classification is used for that. If the air leak is only on cough or only on minimum air leak is there, then you can, on 5th day, they evaluate for the prolonged airway leak, and if the patient is the leak is smaller, it is expected to improve with the ambulatory care, then you connect one of the pleural drainage ambulatory devices and send then the patient home with adequate education to the patient and family. So if you look at the conventional drain system, and it has been dealt in previous talks, I'll briefly touch upon it. The single bottle system, everybody knows about it. The bottle acts as a collection chamber as well as an underwater seal. So there is a one-way valve which will allow the evacuation of the pleural content, and it will prevent any air to go inside. But what happens as the fluid increases in this bottle, it generates a pressure, positive pressure inside this bottle, and this will cause more resistance to the pleural evacuation. So they are more useful for the pneumothorax. But if you have a large amount of effusion draining out, hemothorax draining out, then a second bottle is added to this system, which will act as a collection bottle, and this underwater seal bottle will prove the one-way valve with the use of a second bottle. If at all the suction is desirable, then the third bottle is added to this system. The third bottle has a long tube, third tube, which is immersed into the fluid level. Now this fluid level determines your suction. That is how the weight suction comes in picture. If the fluid level is around 10 ml, or suppose it is on 10 centimeter, or if it is around 20 centimeters in the water column, then it generates a similar amount of the pressure. That is commonly used pressure is minus 20 centimeter pressure. There are many devices available in the market. For the sake of understanding, I have divided it into basis of the suction and seal used. So weight suction, weight seal means what we have seen now, 3-bottle system, where the water level acts as a seal, one-way valve, and the water level in the third bottle gives you weight suction, or a minus 20 centimeter suction. So the 3-bottle system and a compact system called as Plurivac has been available in the market. The dry suction, dry weight seal, it means the seal is, the valve is achieved with the water level, and the dry suction is the wall mount suction, which will be controlled through this device. The third system is the dry suction, dry seal, where there is no fluid interface. It is all depends on the valve function, and there is a Synapy drain commonly used currently in the market. Other than that, there is Plurivac, as well as Atrium also has a device available with a commercial use. The digital drains are also the dry section dry seal drains, and the Medela Topaz is the commonly used device. Apart from that, German company Atmos also has a similar kind of device. And third, the simplest device is the Hemlich valve. The basic valve, which was designed in around 1960s, is the Hemlich valve. Apart from that, there are modifications in the valve from the Synapy as well as the Atrium Pneumostat device. And the simplest device, the Eurobac with a flutter valve, can be used for management of these patients. So if you look at the 3-bottle system, it is easily available in the market. They are easily assembled in any hospital. Their cost is very low. But if you look at the disadvantages, it's a bulky system. So you cannot ask patient to carry this, or you cannot ask the attendant to carry all this while mobilizing this patient. And the air leak quantifications become difficult. There is a lot of interpersonal variability which will come in when there is a change in shift from the sisters, from staff as well as our doctors. No facility for collection of the fluid. This is all glass-based system. So you cannot put a needle and suck out the fluid for diagnostic purpose, and you have to actually stick the needle into the pleural cavity if at all you want to establish infection or the etiology. The suction depends on the water level. So if device has to maintain upright position, if it is tilted, then your entire close mechanics of the system is disrupted and it will not be useful the way we intend to. To solve these problems, the next device has been developed from the Plurivac. It is a compact 3-compartment system from made of a plastic and a fiber. There is a collection chamber, there is a water seal chamber, there is a suction control with the help of a water level as used in the third bottle. Apart from that, there is an air leak visualization. You can see the bubbles through a window and you can quantify them. They are calibrated from 1 to 5, 1 to 7 in the same device. There's a port at the tube where you can collect the fluid for diagnostic purpose in a sterile way without using needles. And this is a closed system. So there might be more negative pressure will build up when patient is breathing rapidly, or when patient coughs, sometimes positive pressure may build up. So there are manual release valves available to protect the pleural pressure dynamics. So this is more compact, ambulatory friendly, and it facilitates the collection of fluid as well as air leak. But the drawback is, again, it is a water as well as seal as well as suction depends on the fluid level. So it has to be maintained in upright position, and the device has a particular capacity. Suppose 2 liters device is available with the largest size, and you have to change this entire device once this device is full. So during this changing, you have to clamp the device. Again, the pressure changes will happen in the pleural cavity, and there is a risk of infection unless you use a sterile precaution. To solve the suction dilemma, the dry suction is used. It's the same 3-bottle system. Again, there is a collection chamber, there is a water seal chamber, and there is a dry suction control, which will help you to control the wall mount suction accurately between -10 to -40. We commonly use -20 pressure. And there is a special air leak monitor or a window is available where you can measure the bubbles, detect the bubbles as well as quantify them. The advantage is only that it is a better suction regulation. Apart from that, the advantage, disadvantage is same as that of the wet system. To solve majority problem with the seal related issues, the dry seal has come. Dry seal is just a valve, one-way valve similar to that of a Hemlich valve. It eliminates the need of water seal. So even this device, every device has to be kept on a gravity drainage position below the patient level. So during the transportation, it becomes an issue. So even this device is tilted, it doesn't disrupt the integrity of the device. So the advantage is that it helps you to mobilize the patient in better way and better suction regulation. But again, it has a limited capacity. It has to be changed. To solve the changing problem and the cost added because of every time new device is used, the Sinapi came with the solution that there is an ease of drainage with the help of a large diameter drainage tap. At the bottom, you can see there is a tap which you can open to a drainage bottle or a drainage bag and dispose it. And there is the integrity of this closed system is maintained well. So there is no infection chance in this system. As well as it becomes more cost effective as you can use this system if appropriately used for 2 to 3 weeks. And there is a manual bulb on the top where if you press it, it will generate a negative pressure in the device. So it will help you to evacuate the pleural content as well. And if this after pressing, if this bulb re-expands, it means there is still positive pressure in the pleural cavity, indicating there is a pneumothorax and air leak happening. But if this bulb stays deflated, then there is high chance that the leak has resolved and the lung has expanded. But always check the tube whether there is any blockage in the system. If there is no blockage in the system, then do a chest X-ray, see patient clinically and decide whether you would like to remove this drain or not. So coming to the digital drains, if you compare the traditional drains with the digital drain, the traditional drains have all manual reading for the pleural fluid quantification, air leak detection. There is a lot of inter-observer variability in that. There are no alarms whether the device is functioning well or not. There is a wall mount, if at all suction required, then it depends on the wall mount suction and restricts the mobility. The digital drain has all disadvantage over the traditional drains. The commonly used device is the Medela Topaz device, which on the screen you can see the air leak quantification as well as the fluid quantification. So it will give you precise quantification of the airway leak and quantity. It reduces the inter-observer variability. It is easy to communicate what amount of leak and what fluid is being drained. There is an inbuilt suction. So and there is no oscillations in the pressure. The wall mount suction may be unpredictable. So this device provides a sustained suction without changing the pleural fluid dynamics, pleural cavity dynamics much. And the data is presented in digital as well as graphical format, so it's easy to communicate this data. And there are functional alarms and checks are available. If the system is blocked, if the tube is disconnected, the device will give you an alarm. There is ease of mobilization, especially when you use a smaller canister. There's a 300 ml, 800 ml and 2 liters canister available with this system, and it facilitates the decision for chest tube removal. You know, there is a lot of, if there is a multidisciplinary team sitting, there is a lot of discordance between the pulmonology, the surgical team, the intervention team will tell you, no, I want to remove the chest drain. You will say, no, I don't want to remove chest drain. So the device recommends that if the flow of the air leak is less than 20 ml per minute, then it is the high chance that the prolonged airway leak has resolved, or it is very small, and it is not going to cause further pneumothorax, and you can safely remove the drain. The cautions used with this device is that there is a battery in this device. There is a metal, so it has to be not to be used during the MRI. The wireless communication devices like your smartphones should be kept 30 centimeters away, otherwise it will interfere with the device function. Do not connect bilateral thoracic drains with one SYNAPI unit. From both sides you need a different unit, and the canister size is designed for a particular device. So you match this, and this will be displayed on the screen that what canister to be attached to a particular Topaz device. Atom is the German company which also provides this digital DNS device similar to that of the Topaz. The functions is also same. So there has been there are few RCTs which support the use of this device. Few define that there is no special benefit with this, but the systematic review indicates that there is definitely at least 1 day shortening of the duration of hospital stay, chest tube drainage, as well as the risk of prolonged airway leak with the pressure changes is less with these digital drainage devices. Coming to the simple device, which is a Heimlich valve, it's a simple, you can see in this plastic case with a rubber sleeve, which opens up during the inspiration, and in expiration it deflates. So there are two marks. There's a mark of a lung as well as the bottle. The device has to be oriented properly. The lung end should be connected to the chest tube, and the bottle end should be to the drainage device or the environment. So the valve makes a flutter noise as well as the movement of the flutter you can see. So in absence of the sound and the movement of this flutter, it indicates that there is an expansion of a lung, the resolution of pneumothorax and prolonged airway leak as well. But always check the integrity of your tube, whether it is blocked or not, before taking the tube out. If this device is connected in a reverse fashion, it will not function as a one-way valve, and it will create a tension pneumothorax. So before attaching the device, you should carefully select the marks, see the marks. And there is chance of accidental dislodgement of this device, and this replacement should happen in a sterile condition, otherwise chances of empyema. Sorry. So the advantage of Heimlich valve is very small, portable, low cost, and cost is less than 2,000 rupees. It functions in any patient position. It is not gravity dependent. And it's easy to understand. You can educate your patients well for the monitoring of this device. You can connect any size drain to this device, so that if there is a fluid present in the pleural cavity apart from leak, this device will still function, and it can be kept for longer time, around 4 weeks, if it is functioning well. If at all there is a large amount of effusion, if there is a large amount of pneumothorax or thick pleura, this device still can be used, but a regular monitoring, a more frequent monitoring is required. There are other devices for pneumothorax management, and there are few case reports of their use in the prolonged airway leak. A small SYNAPI device, a pneumostat device with atrium. It has a valve and a collection chamber of around 50 to 200 ml from device to device. There's a rocket pleural vent which has been used in UK. It's described only for the pneumothorax. Its role in prolonged airway leak is still not well established. And we should not forget the low-cost ambulatory devices like a Eurobag or a 2-bottle system, which is commonly used in most of the hospitals. I think to conclude, the ambulatory chest drain becomes the first step in management of prolonged airway leak. It may act as a bridge procedure before you come to a bronchoscopic management or a surgical management. It reduces the length of hospital stay, and for a particular problem, for a particular patient, you should select the drain. Suppose there is only air leak, you can just manage it with a Heimlich valve. If there is small amount of fluid is present, then you can use a small chest drains like a SYNAPI system. If there is large volume effusion, then a mobile dry seal drainage system should be used like a SYNAPI or a atrium. And if there is pneumothorax with continuous suction or requirement, or if there is effusion, large amount of effusion post-op settings, then digital drains are better. Suction versus no suction is an institutional practice, and patient and family has to be educated well regarding the device use, their monitoring, and when to change, especially when you are using a home care. And access to your out of our pleural services should be there. Your ER should be trained about the managing of this device, detection of blockage in the device. And for Indian setting, I think we need low-cost indigenous devices to serve our patients better. Thank you.
Thank you, Dr. Pawan, for a comprehensive talk on ambulatory drainage systems. In the interest of time, maybe one or two questions quickly. If there are no questions, we'll move on to the...
Okay, Pawan, sorry if I can. Yeah, so, Pawan, very interesting. End of the day, is there any device which is more friendly towards PL management compared to the other device?
So the dry suction, dry cell devices should be preferred if at all you are managing at home, because some amount of fluid is going to be there during the drainage. So there is a lot of soakage with the valves which happens on the skin. But it should come down to the cost of the device and what your patients will be able to afford. The SINAPI drainage as well as the OSS drainage, they function the same way.
No, thanks. I think this is one of the most comprehensive chest drain descriptions we've ever seen. So thank you so much.
Sir. Thank you.
Yeah, thank you so much. Thanks, Dr. Mantri and Dr. Bhatt. We now move to the next session. The chairpersons of the next session are Dr. Rakesh Godara, Dr. Rohan, and Dr. Ajay Handa. We invite them to take over.
So moving on to the next session on approach and tools. Now this is the crux part of it. We invite Dr. Pattabhiraman to come on stage. He is Chief of Pulmonary and Critical Care at Royal Specialty Hospital, Coimbatore. He will be talking about bronchoscopic approaches towards leak localization and planning the therapy. Over to Pattabhiraman.
Thanks, Ajay. Thanks, chairpersons. First to thank Ravi for giving me this opportunity and for setting up this important discussion on both PAL and foreign body, which is not very common. So what I would be doing is just touching on the basics of case selections and leak localization using bronchoscopy. I'll not go into the therapeutics of it. So just the types of PAL, I mean, there will be considerable overlap, the nature of the discussion is that you'll have a small topic and hence there will be considerable overlap. It's quite okay to get it reinforced. So it is looking at how to localize the leak, what are the techniques, what are the pitfall and the role of fixture integrity, already been alluded to by the radiologist, and somewhat I think are important take-home points. So there is a difference between a bronchopleural fistula, which is the proximal communication at the level of main or segmental bronchus, versus APF, which is beyond the respiratory bronchiole. And this will not be visible on a bronchoscopy. And the common clinical scenarios are what happens in a necrotizing pneumonia with a pleural communication, which is the most common thing, an infection with a secondary involvement of a pleura, or a patient with a pneumonia on a ventilator develops a percentile leak, or a spontaneous pneumothorax with PAL. Tuberculosis can have both, it can have both a peripheral thing or even a central bronchopleural fistula. Whereas a bronchopleural fistula alone is typically a post-surgical or a post-transplant dehiscence. The differences are, APF, the leak is distal, can be difficult to localize, can be multiple. The size of communication is typically small. The collateral ventilation is an issue. That's when the fissure integrity also plays an importance, and it may settle down with time. So APF, usually given some time, it settles down. Whereas a BPF is a more proximal, never a problem diagnosing it. It's usually a single communication, but the communication tends to be a little large. Collateral ventilation is not an issue at all, but it's unlikely to improve by itself. And so if you have a big BPF, you might have to handle it. So what are the guidance? I mean, how will you, what are the things that will guide you as far as how long can you wait? Volume, large volume, may not stop, and so you might have a problem with a large volume leak. And a duration, typically wait for 1 to 2 weeks. I mean, if you have a spontaneous pneumothorax, you shove a chest tube and then you find that there is an air leak. How long can you wait? It depends on whether it's a spontaneous primary or secondary. But the more important thing is the trend of the leak, where at day 1, day 2, day 3, and if you find that if the portfolio grade 4 becomes 3 or 3 becomes 2 and all that, I mean, then that means that there is something that's going to go all right. So conservative measures can actually help. So how do you time it? And this came out, I think Dr. Tay was also alluding to this particular paper, where there is a persistent air leak in spontaneous pneumothorax. What is the clinical course and time? If it's a primary spontaneous pneumothorax, about 75% of them recover in a week, and about 97%, close to 100%, resolve in about 2 weeks. So if it's a primary spontaneous pneumothorax, just put in a tube and then wait. Whereas in secondary spontaneous pneumothorax, 2/3 of them improve in a week, and after that you might be pushed to do certain things. So this is what I said. So wait between 1 to 2 weeks, 2 weeks for primary, and in a week, and look at the trend for secondary spontaneous pneumothorax before you try doing something. Post-surgical, again, I think it was discussed, especially this particular paper was discussed, how it was managed in terms of an ambulatory setting. So this is, again, done by Serfolio himself, and this study was purely about post-procedural air leak. About 8% of them develop a air leak on a POD4, and for those people they did an ambulatory thing and reviewed in 2 weeks, and they actually provocatively clamped and removed. Most of them resolved. So that is where this magic 2 weeks came. Whatever be the reason for air leak, wait for 2 weeks. Even in post-surgical things settle down. So this is what came as a paper in Predictors and Treatment of Persistent Air Leaks by Serfolio and group. And this already, I think Karan took us through the predictors of PAL. Who are the people who have developed a propensity and who actually will not really get better unless you intervene. So how do you decide to intervene? You intervene after conservative measures fail. How long you wait? There are no guidelines here. Surgical intervention may be more definite, but the population who fit for surgery needs alternate, who not fit for surgery, sorry about that, needs alternate strategy. There are no guidelines at this point. The best that they could come up with in 2023 was, it's probably useful to have some endobronchial, thing. That's what I think Dr. Tay was also saying. CT would be an important thing to localize, and that we had a good discussion. Bronchoscopy gives info regarding localization of the leaks. So CT, especially the reformatted, like in this case, you can see that there is a, upper lobe anterior, there is a bronchial thing that actually leads on to this. Whereas in bronchoscopy, if you have such a kind of a thing, this is the right middle lobe, and if you do a bronchoscopy, this will be a more definite way of identifying or localizing leak when the bronchoscope actually goes into various subsegment and ends up in a space where you can see an ICD. So this is an easy way to localize. But this is a very large leak where bronchoscopy is inside the pleura and you can see the ICD. There is no problem with localizing. Whereas bulk of it you localize only by doing what you use by using a balloon. A simple Fogarty balloon is the one that you usually use it. Now, how do you do that? Typically we use a patient who will be sedated, ideally with endotracheal tube, a big size to give a better seal. Use a bronchoscope, you have a Fogarty balloon, keep the ICD bag visible. So these are the things that you start up front. You start by occluding the main bronchus, because obviously you have a right-sided air leak. Occlude the main bronchus and make sure that the leak stops. So that is just to test whether your apparatus is working. And after that, you go from proximal to distal. You wait for 3 minutes, 2 to 3 minutes, because once you stop the airway and then you ventilate, till such time that air distal to that goes off into the ICD. So there will be some kind of a bubbling that happens after you close it. Doesn't mean that there is a leak. So wait for things to settle down and then you decide. But then go to global, segmental, further segments if possible, based on what your CT shows in a certain alveolar pile. But it's not very simple. Now, what are the challenges in localizing leak? Let's just think about this. Think about the fact that you balloon blockade. It does not stop the leak. However, if you look at the CT, there is a leak exactly from the place that you've seen. So the radiologist has seen, you've gone to their department, you find out that it is in certain section, upper lobe, anterior, A to B and all that stuff. You go in and block, it doesn't show. Why does that happen? It might happen because of a fissural integrity. So that is one thing that you should understand. And also, you have a bulla, and you know that this is a bulla that is ruptured. You remove that bulla, the surgeon removes that. There is still a 20% recurrence in pneumothorax. Why does that happen? Also think about this. Why is that a pleuro disease is more important when preventing pneumothorax than just removing the bulla? So there are studies which shows that if there is a bulla and then you remove the bulla and not do a pleurodesis, there is high recurrence. Whereas if there is a bulla, you don't remove the bulla, if you do a pleurodesis, that's a much better thing in terms of preventing a recurrence. So why are these things happening? That's happening because of an entity called pleural porosity. It's not a single point. It's not that bleb that is causing a problem. It's not this small number of blebs that just rupturing the time of thoracoscopy and surgery, whereas the remaining areas around the blebs are also very porous. Those are called as a pleural porosity, and these are the areas of disrupted mesothelial cells. These are, replaced by an inflammatory elastofibroblastic layer with increasing porosity, allowing air leakage into the pleural space. So that was actually shown by, applying a dye, and then you see the whole red color thing is that the whole area is porous. It's not the leak that happens in a single bleb. So that is the reason why you also do a symphysis procedure like a pleurodesis after doing a bullectomy. So these are the issues with the bronchoscopic leak localization, where you stop you find out in a CT there is a bleb here and this is the airway that's leading, you just block there, but this still, you might not be able to see that the localization is proper. There is also this incomplete fissure thing and the collateral ventilation which can cause a problem. More than one segment can contribute, and there is this pleural porosity. So these are the issues why your leak localization with the bronchoscopy can fail actually. But since there are certain, there's a good percent of chance that you might actually do that. So you'll have to do that. What are the other issues? Because you're ventilating the patient, the air leak may reduce or it become intermittent after an anesthesia or induction for bronchoscopy. So that is also something that you'll have to factor in. A small endotracheal tube can cause a problem. And also to circumvent this, some of the people have used an endotracheal oxygen insufflation to make sure that the leak shows up when you're doing this procedure. The other bronchoscopic methods like a methylene blue instillation through the bronchoscopy, you put in a catheter and then instill a methylene blue, and xenon gas was also discussed in the first session, or an EtCO2 measurement coming from different lobes, and you find that certain lobes, the EtCO2 can become less because some of the air is going out into the pleura. And so whenever segment, in some segments, if the EtCO2 is less, then you know that that is the segment that is actually leaking. Again, we have the CT, and just let's look at how it is done. So you can see that this is the bag that is visible, and you can see that this is a patient who had a right anterior, upper lobe anterior, and this is a cerfolia grade 4 now. And because this patient is ventilated, it's usually grade 3 become grade 4 on the table also, so you should also appreciate that. And then you can see that you close the upper lobe anterior using a Fogarty, and you can see that this leak stops. So you can see a considerable stop. What was the cerfolio 4 became 0, or at least 1. So this is how you see, and all you're looking at is reduction in the size of the thing. You don't even need to see the stoppage of things. So even if there is a reduction, you know that that is the segment that needs to be tried, in terms of a therapeutic thing. And then you stop to confirm what we have done is you just reduced it, or rather deflated the balloon, and you can see that the airway comes back. And so this is how it starts. It's a cerfolio 4 when you start off, but once you occlude those areas, you actually can reduce the leak, and you know that this is the place that you got a leak. So take home points are usually wait 1 to 2 weeks before you start anything like a bronchoscopic leak localization. So wait, if you have a peripheral persistent air leak, especially, you wait for at least 1 to 2 weeks. You consider the surgery in case of a large BPF, because you can't do it, especially if it's post-op and it's immediate. The surgeon has to do surgical procedure which has a higher ability. Leak localization, including using a balloon occlusion, is a vital first step in an interventional approach, and that starts well within 1 to 2 weeks. Be aware of the difficulties and pitfalls while embarking localization. You might end up not seeing a reduction in leak despite the CT showing a very clear evidence to the same thing. Be prepared to extend the procedure. This is the most important thing. When you do all this, you're putting the patient on a ventilator. You're just doing a major procedure. Just for a leak localization, no. Always be prepared to go ahead and block this, and that's going to be the topic subsequently. So once you have this, you see this is at the same patient that I'm. Can you just play that video? This is the last thing. So, this gives you a better idea. So you have the Fogarty, right upper lobe, and you can see that this leak is stopped. You can actually confirm it. You go further distally between the two subsegments and then you do it, and then you can still see that. So you can actually spigot that smaller area. So you go as distally as possible. And now you can leave that Ravi's spigot that we did, and that will be in the session in the evening. So we just put in a spigot and immediately stop. So whenever you do a procedure and diagnostic thing, don't do that and then come back. Just be prepared to do a therapeutic procedure also in the same setting. And I'll be happy to answer questions. Thank you.
Thank you, Patabi, for the excellent and crisp discussion and stuck to time. One question is permitted by the organizers because we're running late. Yeah.
That's a great presentation, sir. Thank you for the points. Sir, like you showed in the BPF of grade 1 and 2, portfolio grade 1, we will face the practical problems, like if the patient is already sedated, when we are trying to localize the BPF, so maybe it is when it is BPF will be only on force expiration or expiration only.
No, so it changes once you once you intubate and then ventilate, it becomes a different thing. You're forcing stuff, so you might. The two things that can happen once you start ventilating: either the leak can stop because of the smaller tube, and lung can have the collapse, and so you might stop that. I mean, you suddenly realize that there is no leak after you thought you should be doing. So for that, you'll need to use a bigger tube, and that's why there's certain people who use an oxygen insufflation or some kind of a thing to ensure that in each segment, and then find out whether the leak appears. And the second thing is, it could also, because of the positive pressure, you can have a bigger leak than what it was in a.
Yes, so that is the most common practical problem that we face when you try to localize. If it is a small grade, and before the procedure, if you say, like I'm doing in a conscious patient, for example, if you are doing, if the column is moving like 10 to 15 centimeters before the procedure, so after we localize, after we block it, so how much percentage to be reduced?
No, I think it will be eyeballing, and if it reduces, then you know that it is there. I mean, you can't really have any number to that particular thing as far as I can.
Great, sir. Thank you. Thank you, sir.
Yeah. Thank you, Patabi. Excellent.
Thank you.
So the next talk is on the bronchoscopic approach endobronchial valves by Dr. Udit Chadha. May I hand over to Dr. Udit Chadha?
Hello everyone, I hope you all can hear me clearly.
You're not audible.
Not audible?
You're not audible?
Hello, can you hear me now?
No.
No?
Is it a technical issue from there?
Hello?
Yeah, you're audible now.
Okay, thank you. Okay, so first of all, thank you to Ravi for the kind invitation. I apologize if any of these slides overlap with the last talk, as I did notice that some of the content will be repetitive. And I also want to clarify that this is largely an evidence-free zone. So a lot of what I present here will be opinion. So feel free to contradict and ask questions. So I'll be dealing with valves mainly, but I wanted to just generally touch upon some aspects that have been touched upon already about persistent air leak. Largely the definition is if you have a failure of re-expansion of the lung with a persistent leak for 5 to 7 days. And as has been discussed, that this number is arbitrary. 5 days was the expected length of stay after a lobectomy, and that's where all this, hoo-ha about 5 days started. So it's a very empiric definition, and as has been touched about, the most important thing that we need to look at is a trend to improvement. And if you are seeing a trend to improvement, the key is to wait. So if there is a trend to improvement, be patient. If there is no trend to improvement, do your best to get the patient to water seal, underwater seal, if that has not been done already. And the benefits of water seal come mainly from surgical data. A study in 2001 from Surfolio, where they randomized 140 patients who were post-op, and 33 of them had a leak on day 2. By day 3, the patients who were randomized to water seal, 67% of them had complete resolution of their air leak, while only 1 out of the 15 patients in the suction group had resolution of air leak at day 3. And those patients who did not have a resolution of air leak on suction were switched to water seal on day 3, and 13 out of the 14 of them had a resolution of air leak on day 4. In the second study on the right of the screen, we can see that patients were randomized and there were 15 patients in each group, and the duration of chest tube was shorter and the duration of air leak was shorter in the patients randomized to water seal. This basically shows that air leak goes along a pressure gradient, and if you place someone on water seal as opposed to suction, you are no longer perpetuating that leak. So you are allowing the leak to heal, basically. And this has been touched upon, that patience is the key. In a primary spontaneous pneumothorax group, almost everybody had resolution by day 14, while 80% of those in the secondary spontaneous pneumothorax group had resolution by day 14. So if you have no tools at your disposal, and even if you do have tools at your disposal, the key is patience. And if you can get them to water seal and be patient, you're doing the right thing for your patient. You don't have to aim for complete lung expansion. You have to aim for resolution of symptoms and signs of distress. So treat the patient, not the X-ray. The value of patience was in a surrogate indirect way shown in the PSP trial, but I'll touch upon a video that was shared with me by Gary Lee and his group from Perth, Australia. And really, when the lung shrinks down, I'll play this one more time, and you do not re-expand the lung, you are sort of allowing the wound to shrivel upon itself and therefore heal better, as opposed to when you put a lung to suction and then sort of stretch the wound and largely make it harder to heal. So in the PSP trial, what was noted, and this is definitely not even a secondary, outcome of the trial. So this is obviously taken with a huge grain of salt, that the recurrence rate at 12 months was half in those who were managed conservatively as to those who had their lung re-expanded right away after a primary spontaneous pneumothorax in the intervention group. So let's say you do all of this. You try water seal, you be patient, it's still not working, right? Then you really have 3 options: surgery, pleurodesis, or some sort of occluder device. And I'm going to touch upon valves. So for valves, it is reasonable to try valves first if the patient is a difficult operative candidate, which will be a large number of patients with secondary spontaneous pneumothoraces, and in those in whom there is no near complete lung expansion. And I say no near complete lung expansion because that excludes them from pleurodesis, despite being on water seal. Now, the risk for pleurodesis may not be acceptable to certain patients, and in them, valves may be considered. On the contrary, in some patients, if you have tried the tincture of time and it hasn't worked, you may try valves earlier. And those are patients with a true bronchopleural fistula. For example, let's say a bronchus intermedius stump dehiscence in a post-op patient. So valves, to talk about them specifically, what is the benefit compared to other bronchoscopic occluders? They're easy to place. You can get to tough angles with them. You can do it all with a flexible scope, and they are stable and they have anchors so they don't move. The challenge with valves is the availability, the cost, and then the largest valve available on the market is 9 millimeters. So if you want to occlude a large proximal airway that is more than 9 millimeters, that cannot be done with valves. The issue with alveolo-pleural fistulas, especially in those with secondary spontaneous pneumothoraces, is patients have collateral ventilation. And when we use there are two valves which I'll touch upon. When we use the spiration valves, we can get a STRATEX analysis on a CAT scan, which will let us know with high degree of accuracy as to what the degree of collateral ventilation between lobes is. Similarly, if we use a Zephyr valve, which is made by another company called Pulmonx, we can use a flow sensing balloon or a balloon with a flow sensor at the end. And using this flow sensor, if there is a drop in flow after balloon occlusion of a target lobe, you know there is no collateral ventilation, as opposed to maintained steady flow, which indicates CV positive. However, you need to be prepared for lobar occlusion whenever you are trying to do this. So it's important to know a patient should tolerate lobar occlusion. And I mentioned this also, in lieu of this study that I think was mentioned earlier today, where a SPECT CT was used to localize the site of air leak. And very well, they could localize it to RB3, anterior segment of the right upper lobe. However, to stop the air leak, they still needed to occlude the entire right upper lobe in this study. This is largely a research tool, but it's interesting where saline thoracography, where about 500 cc's of normal saline is injected through a chest tube, and the CT is obtained during different positions. During vocalization, you can see bubbles and sort of get a surrogate way as to where the air leak is coming. This is all good for research, but practically the best way to localize an air leak is bronchoscopically. And once you do decide to proceed to bronchoscopy, you need to use any balloon at your disposal to occlude the target segment to notice a stoppage in the air leak ideally, but as a secondary consolation, at least a decrease in the air leak. So as I mentioned, there are two valves. This is the first valve system called the spiration valve. It's by Olympus. Basically, these valves come in 4 different sizes, 5, 6, 7, and 9 millimeters. They are umbrella shaped with anchors at the back, and they're very easy to deploy. Really unsheathing the valve is the mechanism of deployment. They need a therapeutic scope, anything with a 2.8 millimeter channel or more. And here you can see a valve being deployed in the right upper lobe, where the catheter sheath is unsheathed, and then the umbrella shaped valve with the anchors at the distal end takes position. These valves tend to settle about 1 millimeter or 2. So if they jut out a little bit, it's still fine. The other company that does provide valves is the Pulmonx, which makes the Zephyr valves. These valves are duckbill shaped on the proximal aspect. So you tend to place them with your posterior anchors on some target carina. And again, you deploy them really with a push out mechanism. And here you can see this valve with its duckbill shape being deployed again in the right upper lobe. These valves come in 2 sizes, 4 millimeters and 5.5, but they have a large degree of size ranges that they cover. So the 4 covers a 4 to 7 millimeter range, and the 5.5 covers a 5.5 to 9 millimeter range. So they are more flexible in size accommodation. Coming to the data, there are really small studies. I've only included the 3 largest case series, and I mentioned these are all case series. There is no randomized data that is available with valves. And these are hard studies to do because A, the population is not that large with this problem. So the problem is not that prevalent. And 2, it's just a very ethically difficult problem to randomize patients to. So the 3 largest studies I've summarized here that you can see that air leak resolution in studies that were anything between 60 to 70 patients was about 80%. So not everybody who you take for a bronchoscopy for valves will have success. Maybe 1 in 5 or 1 in 4 will fail despite the attempt. And even after in these studies, when you say success, right, and the studies define success by the ability to remove the chest tube. Had the air leak stopped during the procedure, all these physicians performing these studies would take the chest tube out the very next day at the latest. So success is also defined as slowing down the air leak, which allows a smaller degree of volume to leak across the pleural defect, which allows it to heal better. So the median days to chest tube removal is not 1 in any of these studies, as you can see on the graph on the right side. This is an example of a patient who had a BPF from a persistent air leak from sarcoidosis, and the valves were placed in the upper lobe. And these are 9 millimeter spiration valves, which we used here, which led to immediate success. So just to summarize, avoid empiric definitions of persistent air leak, follow trends. Patience is a virtue, and it will work better than any intervention. Valves are a great option for BPFs, but they are sort of a mediocre intervention for alveolar pleural fistulas. They will work only about 66 to 80% of the time, and they should be considered as a salvage intervention after you have tried water seal trials, patients, and ruled out surgical candidacies in healthier individuals. Look at the CT scan for fissure integrity. If you are using either a spiration valve, you can look at the Chartis. If you're looking, look at the StratX report. If you're looking using a Pulmonx valve, you can use a Chartis as a surrogate for fissure integrity. But be prepared for lobar occlusion, because at least intra-lobar collateral ventilation is going to be extremely common in most of these patients. And acknowledge that most of these valves and these procedures are best done under general anesthesia. So your patient should be extubatable after general anesthesia once you are compromising a lobe, or if you are not able to do anything and then have to extubate them without putting a valve in. That's all I have. Thank you for your time, everyone.
Thank you, Dr. Udit Chadha. Any questions from the audience?
Hi, Udit, are you there?
Yep.
Yeah, hi Udit. First of all, thank you so much. A few of the audience know that you're speaking from New York, where it's 1 a.m. So greatly appreciated, and the alacrity and the content was really excellent and put things into perspective. So the question I had, Udit, was we've been struggling with these PL challenges, geographic issues, and a lot of the data which comes based on what people see in their own setup. So just dwelling on the first point, when you mentioned patience, point well taken. But then the caveat of patience here is, where do you draw the line? Is patience a function of the underlying pathophysiology? So being a Mumbai gentleman, you're very well aware of the fact that we have horrible pathophysiology. So does the patient's call get left shifted when you know that as an educated and smart pulmonologist that this is not going to heal easily? So does that also put things into perspective? Because linking to point number 2, the cost of patients in India is infection and a series of, you then double the problem where you not only have an air leak, but you have an infected space also. So just to put things into perspective from the Indian from the Indian point of view, wanted to raise these points and get your thoughts on it.
Yeah, it's obviously just a judgment call, right? There are patients who will have a clear BPF post-op, and it is a rip-roaring air leak. You have a continuous grade 4 air leak, ongoing right from day 1 to day 2 to day 3. Now, in these people, you don't have to wait the 7 days. But, on the other hand, if you have a patient with emphysema who has a secondary spontaneous pneumothorax, and you are noticing a trend where you are going from a continuous to an expiratory to a forced expiratory air leak, even if it's day 7 and day 8 by now, I think patience is a bigger virtue. The second thing you have to factor in is how much of the lung do you need to valve out before you're going to really do something. I mean, just yesterday, I had a patient who, a young woman with endometriosis, had leak from all 3 lobes on VATS, failed mechanical and chemical fluorodesis. And literally the consultation to me was, can you valve out the whole right lung? So a medical pneumonectomy. So really, you have to factor in everything. And your point is well taken that, some people you'll do it before 5 days, some people you'll wait for 14 days, and you have to factor in the risk factors for prolonged air leak in those patients.
It's patients with experience and due diligence would be the way to think about based on your spectrum, especially in this country of destroyed lung and post-tuberculous disease. The second question, if I'm sorry to hog the whole thing, chairpersons, but your controversy on suction versus collapse, that YC Gary Lee thing you showed is very interesting. 20, 25 years, no one settled it. Experienced surgeons of yours will say, suck it, take it up. And if there's approximation, you're going to get healing. And most surgeons will swear by that, versus what you said, that let the lung shrink and let the healing happen. I think we still go by the suction part of it, unless it's a florid, absolute grade 4 leak where you're going to be in gas exchange suffers. Any thoughts on this? Because it's the first time I've seen a provocative, confident statement made by somebody that let the lung fall.
It's interesting that most of the surgeons fight for suction, and the data against suction comes from them. So it's obviously not a settled debate, right? RASPER is an ongoing trial in the UK right now, where primary spontaneous pneumothoraces patients are being randomized to suction versus no suction, just to look at this. Again, I can tell you which I've clearly expressed which side of the fence I lie on, because it is physiology backed to keep someone on water seal, let the hole heal, and then take it on from there. But the key here is your patient should be able to tolerate that. And you have to have the mindset to fight any other consultant to say that I am treating this patient and not the X-ray. So I can tolerate a small pneumothorax as long as the patient is on water seal, keeping in mind that this will get my patient out sooner and possibly prevent an intervention. The other caveat really quickly with suction is that there are many patients who have trapped lung and who come in on suction. A patient with trapped lung on suction can have an air leak forever sometimes. So really, you try someone on water seal, see what happens. There is no harm. You're standing by the bedside. So try someone on water seal if they're already on suction, see what happens. If someone's decompensating, put them back on suction. So I do not think there is any argument to start with suction unless you are doing it for a few seconds in someone who's an extremist in front of you.
Udit, this is Dr. Sajal Duria. Hi.
Hi, Sajal. How are you?
Yeah. I'm good. So I have a different question, different from your topic. It is on iatrogenic pneumothorax. So we do a lot of cryobiopsies on patients with interstitial lung disease. So several times we encounter a pneumothorax. So what is your take on doing a pleurodesis in such patients? They have a bad lung, but it is an iatrogenic pneumothorax, and the patient might become a transplant candidate. Your take on pleurodesis in such patients?
So in general, the dictum and even the BTS guidelines recently just touched on this with iatrogenic pneumothoraces is not to pleurodese because you cannot predict their recurrence rate. Anyone with a secondary spontaneous pneumothorax will have a high recurrence rate. Of course, the degree and the risk of recurrence will vary depending on what their underlying lung looks like. So in those patients, it is very reasonable to have a discussion at the first event. But in iatrogenic pneumothorax, you've induced the damage. Now, pleurodesis in a patient with ILD who may be pre-transplant is a very local decision because that depends on your surgeon and their comfort with doing pleurodesis of doing a transplant in someone who has had talc or any other chemical agent beforehand. And we've encountered both. Our surgeons are comfortable, so we always do it. But there are people who are not. So it really depends on your local surgeon.
Yeah, Udit, this is Karan from AIMS. Just a quick question. So just wanted to ask you that now since that valves are available with you, are they your go-to choice for any bronchoscopic procedure for leak closure, or you have some other options which you also consider as good alternatives?
So I can tell you about my practice. I mean, everything we do in this space is off-label. So if there is a bronchoscopic intervention, everything else has largely been tried. So it is very rare to do something like trying a blood patch from the inside or something like that. So most of the patients who are taken with an alveolo-pleural fistula or a segmental bronchopleural fistula, we will try valves. We will not try spigots or something like that, just because of the ease of availability of valves. In our hospital, for example, there are 3 boxes available at every time. So in theory, we could do 3 patients a day. On the other hand, if we can avoid valves or anything like that and do something simpler, why not do that, right? Though it's arguable if there's anything simpler than valves. These are not technically challenging or emotionally challenging procedures. So if there's a large BPF where a 9mm valve won't seal it, then we'll try something else. Then like an occluded stent, or my personal favorite is using bovine pericardium with some sort of fibrin glue. But again, if it's a smaller airway, anything 9mm or smaller, we always go to valves if a bronchoscopic intervention is pursued.
Udit, now you have mentioned autologous blood patch. So for a small alveolo-pleural fistula with a forced expiratory leak, it is not going away, say after 10 to 14 days. You still try that blood patch thing there, autologous blood patch.
So I'm sure you're very familiar with the blood patch data, Sajal. So the first controversy with blood patch is, does it patch or does it pleurodese? And I stand on the side of pleurodesis. I do not stand on the side of patch. But again, there is no clear understanding of how blood patches work. Do you need to do 1 blood patch? Do you need to repeat it on day 3? Do you again need to repeat it on day 5? So really the key answer for us is that we always try a blood patch, because if someone consults us for bronchoscopy, we're not doing it today, we're doing it tomorrow. If someone's consulted for surgery, they're not doing it today, they're doing it tomorrow. So we at least try a blood patch once. And if it doesn't work, the next day or the day after that, if it's time, we'll try it again. But otherwise, if the procedure is scheduled, we'll go for it.
Just to add to this point in 30 seconds, I totally agree that blood patch is like a shotgun approach. Throw something in there, whatever it does, whether it irritates the pleura or shuts off a hole, you're just going to be happy with that. The second problem we found with blood patches, and we've never been able to replicate the literature of 82%, is infection. If these guys have been with tubes long enough and you try a blood patch, the chances of somehow infection go up because you're instilling some 7,500 ml of blood, you may be doing it repeatedly, and then you may convert into a worse empyema. Again, Indian setting, anecdotal observations, but it's worried us a lot. And then again, you're complicating the issue more. The only thing we did not do is send a blood culture of these guys before doing a blood patch. But short of that, it's been a problem for us to deal with some of them as a consequence. Well, the late part of it is part of PA's story. On one side, you're patient, the other side, you're late. So we can take on, next time I'm throwing in a topic on controversies in PA, I can throw in all this now. Early versus late, suction versus no suction, have a lovely pro-con debate. Udit has stirred this small hornet's nest, so to say. But anyway, thank you so much. Interest of time, I think I hand over to the chairpersons. Udit, personal thanks to you. Thank you.
Thank you.
Hello. So then for the next lecture then on bronchoscopic approach, the other devices other than the valve. So now I would like to call upon Dr. Sameer. Over to you.
Thank you. Morning all. Thank you for coming today and attending the talks on persistent air leak management. So I would also like to thank the previous speakers because I think they've set the stage for my talk in general. So moving on to our talk, I'll be specifically describing about various bronchoscopic devices which can be used for management of persistent air leak. Now, so what we'll be discussing today is, briefly, we'll just talk about the principles of management. I think that has already been covered. The major goal for the management today is, for management of persistent air leak is, okay, you do something, you try and reduce the leak to as low as possible, so that at least the patient is not symptomatic, not in distress, and you can subsequently remove the chest tubes and all. So, of course, it has been talked about, you wait with the chest tubes long enough, give it some time, say 10 days, 14 days, 15 days. Yes, that holds true for maybe smaller leaks. And of course, you've got to see the trend also, whether the leak is reducing, the leak is stopping, or the leak just continues at a higher grade or not. So yes, smaller leaks, of course, we can wait, we can see the trend. But what if the leak is large? I know. Yeah. So yes, of course, for these larger leaks, we generally, or rather, the recommendation is, okay, the patient is there, the leak is just not stopping, or rather the trend is also such that the leak does not reduce. These leaks may require some closure. Of course, traditionally it's a surgical arena. Dr. Arvind will be taking a talk later on how to manage these large air leaks surgically. But is surgery always helpful? Say, for example, a patient, especially in the context, in Indian context, okay, the patient has a very poor functional status. There are active infections such as tuberculosis, wherein we see quite a lot of these persistent air leaks. Other than that, the cost factor also, or maybe the patient has already undergone surgery, which has been largely unsuccessful. Now, what for these patients? Of course, what we have is various endobronchial therapies. So broadly, it can be divided into various substances, or it can be various devices. So substances, I think Dr. Arjun will be talking about later majorly in terms of glues and all. So I'll talk about devices. Dr. Udit has already covered the endobronchial valves. So we'll talk about certain other devices which we have used, and I'll just go through certain case discussions. So let's talk about the ASD, VSD devices, or the atrial septal ventricular septal defect devices. These are unconventional choices. However, literature is replete with these devices which have been used. They are majorly used for congenital heart defects, and they usually can be fully deployed. They can be repositioned, retrieved also, which gives them an advantage for accurate positioning and covering the whole fistula. Now, as you can see in this picture, there's presence of these two discs, which leads to greater coverage from both the sides of the fistula and increases the likelihood of the closure. It also induces some local inflammation, which may lead to granulation tissue formation, which further may potentiate its occluding capability. As you can see over here, this is from one of our patients, the right upper lobe fistula, which was occluded using this Ampletzer device or the ASD device. Now, I just want to present a case, a 42-year-old male who underwent a right upper lobe lobectomy for an aspergilloma following tuberculosis, following which there was a stump blowout. There were 2 failed correction surgeries, and there was pleural space infection. So I'll just run you through the video. Now, this is the chest X-ray which was showing post-surgical site infection. So you can see the bronchopleural fistula which was localized to that right upper lobe. We used a forceps to just determine the size of the fistula, and ultimately the the support also, the anchorage also, whether it will be nice or not, whether it can hold the device. And this you can see the clamshell, a double umbrella structure for the occluder device. We used a 12 millimeter. As we enter, you can see that is the fluoroscope. This was just for guidance, whether it is, and under vision, we just deployed it. Ampledger was inserted over the guide wire via the bronchoscope, and using a fluoroscopic view, we actually positioned it across the fistula. And later on, you can see the endobronchial view of the device being deployed as well. So ultimately, this was the device. As you can see, the endobronchial view, how it is sitting nicely, and the patient still follows up with us for quite some time. Occasional check bronchoscopy, surveillance bronchoscopies for in the secretion clearance. You see the fluoroscopic view of the same. So later on, as you can see, the X-ray and the CT also, this device nicely sitting out there. This is an axial view which was showing the same thing. So is there literature? Yes, of course there is. Majority of these studies have been done by Kramer and Fruchter. So the first paper which I've just posted on that was the left side is the chest paper, which was showing, this was the various, the follow-ups also. Nowadays there has been a latest study also which has shown long-term follow-ups up to 7 years, 8 years also with these devices. Now the major thing is that these devices are used for larger fistulae, the proximal fistulae, and that is where the utility of these particular devices come from. As far as long-term follow-up is concerned, majorly, yes, there may be some secretions which may get, the stagnation of secretions, but overall it leads to a good success rate per se as far as closure of the fistula is concerned. Now, other devices, the customized stents. Now, usually silicone stents are preferred. Other than that, there are fully covered metal stents also. They're majorly used for large BPFs in the mainstem or the lobar bronchi. Now, Hahn in 2018, he designed various stents. Now, as you can see in the pictures also, with the right limb occluded, the left limb occluded. So this is another schematic which you can see. If you can customize the stents to occlude various different segments, which will be helpful in occluding the fistula. This was a paper. It was actually a nice paper which was there. So Zeng also subsequently described these customized silicone stents. Now the success rate as far as his study was concerned, initial cessation was seen in about 94% patients. Clinically success was achieved in about 76%. Advantages, yes, it can be modified, it can be cut and sutured on the spot, whereas SEMS usually requires manufacturer to customize it for you. It also provides for easier removal, lesser secretion, but of course there is limited sizing and type, so that's the disadvantage. As you can see over here, there are types of various customized silicone stents, how the limbs are sutured out there. Now this was one picture is showing left main bronchus, the left main bronchus fistula, which was covered either with a single stent, which was occluding, or there's a Y also with the pinched off left limb. Now, we also had done one case wherein we placed a customized stent. So this was a 32-year-old male who underwent right pneumonectomy for tuberculosis a year back. ATT was also given. There was proximal stump blowout. He underwent a thoracoplasty along with a muscle flap, however, did not succeed. Chest tube was there with persistent infection. There was significant comorbidities, LV dysfunction. So he just came in for an out-of-the-box solution. As you can see the X-ray over there, the cavity, the residual cavity which was there. So surgery was of course ruled out since he already underwent one which failed. So other blockers, they needed some follow-up. So majorly the whole idea was, can we use a stent in this case and maybe with some way prevent migration. So we decided to use a metal Y stent, which was useful to stop migration. However, the limbs, we tried to pinch off those limbs to function as an occluder. As you can see over here, I'll just play the video as well. So you can see as we went inside, so there's the right bronchus intermedius leading to the pleura and the right upper lobe also later on you can see in the video, which goes on into the pleura. So what we decided, we customized the stent, pinched off both the limbs on this, and we started deploying it. And this is the fluoroscopic view, using the marker wherein to deploy the stent or open the stent. And under this proper fluoroscopic guidance and under direct vision also, we opened up the stent. Now this was the endobronchial view. You can see the stent being fully deployed, and these are both the limbs across the right upper and the right bronchus intermediate, which were all pinched off. So follow up, the chest tube was removed the very next day. Resistant organisms were treated with IV antibiotics and it returned to its parent city. And so far, we just had a few telephonic follow-ups and all the patient has been doing well to this date. And the X-ray also, we saw the stent is quite patent. So this is just one of the diagrams, pictures that I've taken just to show you how we actually pinch it off. We sutured the limbs over there and we cut some part of the stent also. So this is how we do it in practice. Now the next device I want to talk about is the endobronchial Watanabe spigot, which was described in 2003 for bronchopleural fistula or air leaks. Now this is usually coated with barium sulfate for radiographic visibility and comes in usually 3 sizes, and it can be easily deployed using a forceps through a flexible bronchoscope in whatever desired segment is there. And this was the paper. Now, do any of these devices offer superiority? This was a paper by Keshishian who reviewed all these devices, namely the spigots with the blood patch, Amplatzer occluders and metallic stent. You can see overall the success rate is 75% to 100% or so, but roughly in the range of about 80-85% or so. But majorly we can talk about certain disadvantages. They can have some migration, especially the conical stents up to 28-30% rate of migration. SEMS requires the manufacturer to customize these. The Watanabe spigot is available only in 3 sizes, so not useful for the larger fistulae. AST devices are usually permanent, and EBVs, as Dr. Udit also said, the cost is the major factor and the availability. The mean valve cost is about $2,500 to $3,000 or so. So can we come out with something else? Can we come up with something else? So I just want to show this case also. A 63-year-old who presented with right-sided chest pain, a chronic smoker with a large secondary pneumothorax on the right side. The chest tube was inserted, but persistent air leak. As you can see the X-ray out there, it seems to be bullous emphysema. This was the CT scan as well. So majorly the large leak was continuous, persistent despite conservative management. Suction worsened the leak. He was a poor surgical candidate, so we thought whether there's some IP intervention which is possible. Either insert 2 intercostal drains with suction, but it already worsened the whole thing, whether to put a blood patch or any other endobronchial technique. So we took him up for a bronchoscopy and localized the leak to right upper lobe segments using a Fogarty balloon, as Dr. Patabi already showed. What we did was we blocked the whole area at the right upper lobe with a large spigot which measured about 9 millimeters. I'll show you the video. These are the spigots which you can see in the picture over there. And this was how it was placed, covering the entire right upper lobe. Now this was one of the first patients wherein we actually deployed the spigot. And what it resulted in was fully expanded lung, leak stopped, chest tube was removed 2 days after doing a pleurodesis. In 10 years done, the patient still follows up with us. So this was the CT scan which was done about 6 months later. You can see the whole lung well expanded. So another case, a 42-year-old male with diabetes, sputum positive tuberculosis outside, course was complicated by left pneumothorax, new onset ACS and hospital acquired pneumonia, persistent pneumothorax despite conservatively being managed for about 17 days with ICDs. You can see it's grade 1, a grade 4 leak out there, continuous bubbling which was happening. So CT scan was also done to localize the leak to lower lobe segments with significant amount of consolidation. So we did a fluoroscopy earlier, majorly to triage the whole thing, how big is actually the fistula. And you can see during fluoroscopy, we could actually see the leak out there. It was just bubbling away to glory. So we knew, okay, this is a big leak, so we definitely will have to do something as the talk, how much to be patient for. Now we know, okay, this is the problem. There is big consolidation. Of course, it's going to take time. So whether we can afford that. So the whole thing was, should we continue with this conservative management, insert a second ICD, or rather just, block the whole thing with some sort of a blocker? So what we did initially, we placed a second ICD. However, the leak continued, as you can see in that picture over there, a pigtail catheter along with another ICD. So we took him up for a high-risk bronchoscopy subsequently for placement of one of these blockers. Can you just play the video? So we localized the leak to left lower lobe segments using the Fogarty balloon, as you can see out here. This was the blocker that we decided to place. Now, the whole question was, as Dr. Udit also mentioned, sometimes you cannot just localize it to a particular segment because of the collaterals, and you may have to block up the entire lobe, and that is precisely what we did as well. We had to place about 2 or 3 blockers into different segments to finally achieve the whole, the cessation of the leak. And this was the glue just to make sure that just to reinforce the blockers out there so that the patient doesn't accidentally cough them out. Now, post-operatively, the lung expanded, ICD was removed, no recurrence, patient was discharged with Heimlich valve, blockers and catheters were removed after a month, and he continues to follow up with lung fully expanded 4 or 5 months post-operatively. So this was the paper that we finally published using these blockers back in 2018. With 31 patients, about 49 blockers were placed, which with a success rate of about 84% with migration in about 5 patients. And this was more recently, CSP, what we used in combination with other modalities, blood patch and the Heimlich valve. Now, again, the major goal is to either stop the leak completely, which may not happen all the time, or rather reduce it significantly to allow for lung expansion, expedite the drain removal, and prevent further infections. So to summarize, yes, it's a complex problem with significant morbidity and mortality. Bronchoscopic options do offer a viable alternative as compared to surgical closure. Usually it's the last resort, but maybe, it's time to rethink this whole mindset, whether we can do it early, especially when the patient is not feasible for some sort of a surgery. Multiple endobronchial devices are available, such as balloon stents, spigots, AST, VST devices, and sometimes the innovative and out-of-box thinking can also be very useful for these cases. Thank you all.
So any questions?
Presentation, Dr. Sameer. How do we select the size of the spigot? We are not able to directly visualize the BPF. How we select the size of the...
No, so again, the whole thing is because your spigot has to be anchored somewhere. So first of all, once you try and localize the whole leak, what we do is either using a balloon, we inflate the balloon and see how much the balloon can be inflated up to, and that is usually the diameter of the balloon is possibly the proximal end of your blocker. Or sometimes you open your forceps and see how much the forceps is being opened up to, and that can be a guide to, just mold the blocker. We'll see on the stations also how we do that according to the size and stuff. It's either the balloons we use sometimes or the blocker, and now over time, we just get an idea, okay, maybe which blocker may fit or not. I mean, that just comes as we see multiple cases.
So, Sameer, one thing that's because I have used this that Vatanovich we got, and I have seen that because if we reinforce with the glue and later on we remove it, because and 2 to 3 spigot we need to put it inside, they generally come out with en masse because they are completely stuck with this one. The bucket handle, it works very well. Otherwise, it's very difficult to hold them and then get it out, because they are, and slightly sometimes we are pushing it with the sizes, because then we have limited size, they slightly pushed inside. So that's why the bucket handle, it worked very well.
No, absolutely. The whole thing is that we also tend to place this bucket handle, as you rightly put it, because it just helps, facilitates an easy removal for the blockers.
Yeah. Even with their Watanabe also, because they have very small, the head for that hold to the things. Okay. Yeah. Thank you. So the next lecture on the bronchoscopy approach after the valve and the other spigots. So now we have a sealants, and so I would like to invite Dr. Arjun Srivanathan for that. Dr. Arjun.
Thank you. Very good morning. And after all the activity that we've seen over the last few lectures, it's going to be a very, very tame sort of lecture, because it's going to be primarily theory on what are sealants and when do we go to them, and what are the things that people have used. Pulmonologists, especially intervention pulmonologists, we like we said yesterday, we tend to beg, borrow, steal. We want to do, we've never had the opportunity to have everything with us, so we tend to use a lot of stuff with the other specialties, use and see how it works. And sealants is a topic in persistent air leak which is consistent with that. So basically we have borrowed and sort of copied from what the gastroenterologist does, what the intervention radiologist does, what the surgeons have been doing, And we've used a lot of these modalities that have been available to them. And so if you look at it, so just reiterating the fact, so what you have here is, what you have here is the leak, and once you're done with sort of localizing the leak, sealant is basically something that you spray there to make sure that the leak sort of goes away, so you can take the tube out. And by definition, sealant is something that has got an inherent property to close a fistula, or it acts as an adjuvant to that effect, in the sense that either it fixes another agent in place, like Samir has shown that a lot of these custom spigots or Watanabe spigots, though the Watanabe spigot has sort of rugged side surface, generally people tend to use a sealant along with that to make sure that it stays in place till such time there is adequate granulation tissue to make sure that patients don't cough it out. Or sealant might be another way it acts is like, it causes a local reaction which leads to inflammation, cell proliferation, granulation, scarring, and eventually closure of the fistula. So if you look at sealants, I'll try and go with what are the sealants where you've got the maximum amount of literature. And we have been talking about autologous blood patch. Autologous blood patch has generally been placed from the pleural side. And this is one large paper from China, which they did a RCT, the three-way RCT, multi-center trial. They had 50 patients each. They looked at conservative management versus autologous blood patch through the bronchoscope versus a Watanabe spigot. The autologous blood patch that they used 20 to 30 ml of the patient's own blood. This was combined with a thrombin solution, 3 ml, containing about 2,000 to 3,000 international units of thrombin for activation. And Fogarty was kept. So initial Fogarty was used to localize the leak, and only patients in whom the leak was localized were included in the study. And the Fogarty was kept inflated for additional 5 minutes after the blood was inserted inside. 50 patients were there in the autologous blood patch arm, 50 patients in the other arms also. So when they did that, they found that there was a success. See, there was no, whenever you're looking at leak, we are interested in what is the size of the leak, but there was no mention of the size of the leak in this paper. But all the patients had pneumothorax, which was extending more than 50% of the pleural cavity. And when you look at the autologous blood patch, it was successful in, like Dr. Ravi said, this was the paper where they showed 82% success. 41 of the 50 patients had a closure of the leak. And again, the duration for the leak to stop was an average around 6 days. Duration of the lung to re-expansion was also again about 6 days, and the hospital stay was about 8 days after the procedure. So this is the largest data for autologous blood patch through the bronchoscope. Surgeons to make sure that the suture doesn't give way. So this contains two, this basically has two agents. It's HCl, which has either sodium phosphate or sodium carbonate. So when you press the syringe, it sort of, both of them combine, a polymer forms. The polymer subsequently binds, and the polymer sort of expands in nature. So it hardens by about 10 seconds. The hardening completes by 4 minutes. It expands for up to 4 to 24 hours later. It is absorbed by 2 weeks, and it can clog, like with cyanoacrylate glue. It can clog and damage the scope if it is not if you are not careful. And excessive use can turn it into a foreign body. Then you are dealing with yesterday's stock, and the patient may cough it out also. So if you look at it, this is, there have been other 1 or 2 case report, but this is the largest paper, about 22 patients. They were treated with 1 to 3 applications of this synthetic hydrogel. And again, there is no mention of the size of the leak. 19 patients, 86% had complete resolution, and the average time to chest tube removal was around 4 days. Like I said, there is no mention of regarding the size of the air leak. So the other thing is, instead of hydrogel, you have something called now you have multiple, you have flow seal, tissue seal, these are multiple, it's a combination of fibrin glue, where you need two things basically. You need the thrombin component. The thrombin component comes as this, so it has to be reconstituted before you use, and it can be kept for 24 hours afterwards. Once this thrombin component is reconstituted, you'll have to combine it with an activator, which is basically gelatin matrix in this. So once you combine it, then it is activated and this forms a clot. Again, this has been extensively used by intervention radiologists, and also it has been extensively used post-surgery. A lot of surgeons tend to use it when they feel that there might be a leak. They tend to use it on the thoracic surface, but no, there have been only about 3 or 4 case reports that are available from the bronchoscopy side. But the principle is the same, so some people have used this also. Cyanocrylate glue, this is something that all of us have used at some point of time. This is an agent because it is easily available, it is very cost effective also, and it leads to immediate crystallization on exposure to tissue, and that is something that that gives us nightmares whenever we are dealing with that, and that's something we are very careful when we have trainees with us also. So if you look at the data for cyanocrylate, this is the largest data that you have. This is by a surgeon group that they looked at 14 years data. Initially it was published for about 10 years and then they subsequently extended for 14 years. 20 cases, they reported an overall success of about 70% with cyanocrylate glue alone. They reported that the highest success was when the fistula was less than 5 mm, which is 92%, 12 of the 13 patients had a closure. And the lowest success was with the large fistula, which is more than 5 mm. Only 28% could achieve success. All empymas associated with either small or early leaks resolved with the use of cyanocrylate glue. Only 1 of the 7 fistulae which was late and large and associated empyema resolved, and these patients tend to have a very high mortality of about 57% also. All these patients were all post-surgical patients. If you look at the largest, next largest paper, which is about 9 paper, this is by Dr. Rakesh Chawla and the group from Delhi. They reported in 9 patients. Here also they reported in the size of the leak. The largest size was about 8 mm, which was unsuccessful. And they were able to achieve a success in 8 of the 9 patients. And the intercostal tube was removed on an average anywhere between 48 hours to 4 days after the procedure. So again, it has been used along with cyanocrylate glue, along with PVA. So again, this was about 7 patients in which they reported. Again, fistula size was maximum of 8, and they had a failure in 1 patient. So what about corrosive agents? So a lot of corrosive agents have been used, or sclerosing agents have been used. So central bronchoscopic fistula closed by bronchoscopy injection of absolute alcohol. This was a Japanese paper that came out long time ago. Like with most Japanese, they are very diligent. They went ahead and injected 21 times around the fistula. I mean 21 places, average of 21 to 104. So 104 was multiple times. It was done 4 times, about 20 to 25 times each. And the only here issue was the time to resolution was anywhere between 4 months to 15 months after the procedure was done. Whether it has got anything to do with the procedure or not is not very clear. There's only one other paper other than that which reported about 2 cases wherein absolute alcohol was injected. Again, people have injected ethanolamine oleate. This is the largest paper that you have. About 15 patients, they reported a success in about 12 of the 15 cases. Again, there was no mention of the size of the fistula in this paper, but most of them could get the tube removed in about less than 2 weeks time after the injection was done. People have also pushed in carbolic acid through the fistula. Again, this is not something where they have injected, they have actually sprayed in carbolic acid, and they have gone ahead and sprayed up to 7 times carbolic acid. The size of the fistula again was quite small, but again here, what you have to take with a pinch of salt is the time taken for removal of the chest tube. It has taken anywhere between 2 weeks up to 7 weeks for. So when you have a very small fistula and it is taking 7 weeks after the procedure, it is likely that probably the fistula healed on its own rather than because of the interventions that we have done. Again, people have used silver nitrate also. This is the largest paper that we have. Again, 5 of the 7 patients, there was a resolution of the fistula. Again, if you look at it, most of the fistula were less than 5 mm in size. So other agents, there have been case reports of polidocanol, which is basically a sclerosing agent which is used to treat varicose veins. Tetracycle single case report, again tetracycline was used and Fogarty was kept in place for some time. Surgisil that we often use to take care of hemoptysis, there has been a single case with Fogarty occlusion. There is something called tissue expansion, that is albumin glutaraldehyde tissue glue. There has been again a single case report with again. So these are the other agents that have been used over a period of time. So sealants as adjuvants, sealants to hold endobronchial devices in place, we just seen in the last talk, especially with the larger leaks. So again, we said that most of the leaks where I have shown sealants have been used, they have been used in very small leaks which are less than 5 mm. So if you're using, it is to make sure that the occlusion related to the occlusion device, either the device is held in place or whatever the surrounding leak is sorted out, sealants have been used. Most commonly reported sealants have been either a fibrin glue or cyanide glue. And conclusions, there has been a wide variety of sealants that have been used. These have been based on the availability, desperation, and institutional conviction. So if you use it in one patient and you feel it works, then you tend to use the same agent again and again. And they have been shown to be effective when the aperture is small, which is less than 5 mm, or it can be used as an adjuvant when the size is bigger. What has been seen is more, a lot of times you may need to do it multiple times, and we need to have due diligence. You need to sit down with the patient. We need to sit down with all the concerned parties, sit and discuss what we are trying to achieve. It's not that you're going to do one procedure and we are going to be done with it. And we'll always have to question ourselves whether we need to do this procedure. And we have to be careful about the amount of sealant that we use whenever we are using this. And we also have to take care to make sure our scopes are protected. Thank you.
Thank you, Arjun, for the excellent talk. One question? Yeah.
Yeah. So Arjun, just wanted to ask that, have you, your experience with these agents, is it only cyanoacrylate or have you ever tried another agent? I actually tried to I went to surgical OT, but the challenge was to find
long catheter, yes. So again, that one thing with hydrogel also, you need to find a catheter which will take both the nozzles at the same time and you're able to use it. So those are the challenges if you use something beyond the cyanoacrylate glue. Our experience per se has been limited. It's very limited per se, and on top of that it is only limited to cyanoacrylate gel. I think they mostly use radiology to try and measure, and if they are able to see, then they are able to look at. See, a lot of these leaks are actually post-surgical. So sometimes the surgeon is able to tell them as to what is the size of the leak, or they have looked at the radar. It's not clearly mentioned. They've just mentioned it in the table. The size of the leak is 3 mm, 4 mm, 5 mm. So mostly I think it's a radiological correlation. They are able to pick up the size of the aperture on the radiology, CT.
Mostly it's because of the stump.
So a lot of these cases are all post-surgical.
Post-surgical. So you see the stump and then you can measure the size of the visible, I mean. That is one. The other thing was I'm very much interested in the Chinese paper where they've injected 30 ml to 50 ml, you said.
30 ml, 20 to 30 ml.
So what were the complications reported?
So they said that both the Watanabe and this one had about 11 or 12% initial hemoptysis that happened. Other than that, they have not reported any increase in infections per se.
But if you're injecting blood, the fellow will have hemoptysis. I mean,
it's quite, quite intuitive that way. But they have not really reported any increased risk of infection.
Thank you. for the excellent talk, and thanking all the speakers for this session. We conclude the session here.
Thank you, chairpersons, for chairing that beautiful session. Now, after going through the basics of persistent air leak management, now we move on to a little bit more complex case scenarios and recommendations. So I invite Dr. Jayachandra, Dr. Ritesh Agarwal, and Dr. Pattabhiraman sir to chair this session. Over to the chairpersons.
Good morning, everyone. So we'll look at the complex scenarios with persistent air leak, and in the first presentation we have a persistent air leak on mechanical ventilation and the role of ECMO for its management, and this will be delivered by Dr. Rohan.
Good morning, everyone. Thank you to Dr. Mehta and Apollo Hospitals, Bangalore, for this opportunity. We'll be discussing about prolonged alveolar leaks on mechanical ventilation, the etiology, pathogenesis, the adverse effects of PAL when on mechanical ventilation, the prevention and management, and a brief role of ECMO in the management of prolonged alveolar leaks. So as already mentioned, any bronchopleural fistula or an alveolar pleural fistula which lasts beyond 5 days is termed as a persistent air leak. If you look at the literature, it can range from around 25% post lobectomy to almost a quarter to half patients post lung volume reduction surgeries. If you look at literature as far as leaks on mechanical ventilation is concerned, there is a paper in 1986 where they mentioned the incidence rate of around 2%. But what we need to remember is in that era, the mechanical ventilation used higher tidal volumes, almost to the extent of 14 ml per kg. Now we have a trend towards using lower tidal volumes and the incidence is much lesser, but you cannot have a pinpoint incidence rate from the available literature. So these are the common causes of alveolar pleural fistula and bronchopleural fistula. All of them have been covered in details in the previous talks. The commonest ones for BPF would be any blunt or penetrating trauma or the surgical blowouts. And for alveolar pleural fistula would be spontaneous pneumothorax or pulmonary biopsies, cryobiopsies, transbronchial biopsies, or infections. So what is responsible for alveolar pleural fistula on mechanical ventilation? It's primarily the barotrauma because of mechanical ventilation with higher tidal volumes, higher PEEPs, higher transpulmonary pressures, or it could be because of increased vulnerability to barotrauma. So in patients who have necrotizing infections or who have ARDS or interstitial lung disease or COPD in the background, even with normal ventilation, there could be a tendency towards alveolar rupture and alveolar pleural fistula. Or it could also be because of inadvertent alveolar overdistension. This could happen if there is a right main bronchus intubation or there is a severe central airway obstruction. Post pneumonectomy patients, when ventilated, there can be alveolar overdistension, or if there is aggressive bag and mask ventilation or manual ventilation. As far as BPFs are concerned, most patients land upon mechanical ventilation because of a BPF rather than vice versa. However, if ventilated and there are elevated peak airway pressures that can lead to disruption of surgical closure, it is much more common post pneumonectomy as compared to lobectomy. In patients who have received radiation and chemotherapy, there can be persistent air leaks because of compromised blood supply to the bronchial mucosa. The other risk factors include if there is resection done in an inflamed lung, there is tension on the bronchial closure, if there is any residual is it important to address these fistulas. So when patients are on mechanical ventilation and they develop an alveolar pleural fistula or a BPF, There is a loss of PEEP, which leads to hypoxemia and atelectasis. There could be a loss of effective tidal volume, which is delivered to the patient, leading to respiratory acidosis and VQ mismatch. There could be incomplete lung expansion, which again predisposes to atelectasis, hypoxemia, and failure of the leak to heal in itself. There could be soiling of the pleural space because of an empyema, or it could also be the adjacent lung which can get infected, or the contralateral lung which gets infected. And because of the air leak, there could be factitious cycling of the mechanical ventilator, leading to respiratory alkalosis and ventilator asynchrony. So what is important is you do your best to prevent these bronchopleural fistulas or alveolar fistulas when on mechanical ventilation. So you make sure that your peak pressures are lower. This will help in preventing BPFs. Lower transpulmonary pressures will reduce, or lower driving pressures will reduce the risk of alveolar pleural fistula. You use lower tidal volumes, minimize the number of breaths, avoid hyperventilation, minimize PEEP, minimize the chances of developing auto PEEP, keep a watch for auto PEEP. Reduce the chances of coughing on ventilation or ventilator asynchrony by adequate sedation or cough suppressants. The best thing is to wean from mechanical ventilation as early as possible. Avoid unnecessary procedures or central lines, and meticulous attention to preventing secondary infections or nosocomial pneumonias. So what do you do if you do develop a alveolar leak when on mechanical ventilation? The main goals of management, be it on mechanical ventilation or otherwise, would be reducing the duration of the intercostal tube drainage, reducing the hospital length of stay and cost, reducing the morbidity and mortality associated with it, and improving the patient's quality of life. So most important, and where majority of patients can be managed, is conservatively. You can continue drainage via chest tube, limit the airway pressure and tidal volume on mechanical ventilation. Most important is treat the underlying pulmonary disorder, including infection, and optimize the nutrition. Most bronchopleural fistulas, which happen secondary to a surgical problem, will have to be eventually managed with an intervention or a surgery. You can obviously buy time with mechanical ventilatory measures and chest tube drainage. And obviously, you have to have a multidisciplinary team, including intensivist pulmonarists, pulmonologists, and thoracic surgeons to deal with them. So conservative management with chest tube facilitates lung expansion. It reduces the risk of hemodynamic complications with pneumothorax. In case of multiloculated pneumothorax or incomplete lung expansion, you may sometimes have to have more than one chest tube. Now, we had a discussion on the role of suction, very limited data. Most places would use small amount of suctions to help apposition of the visceral and the parietal pleura. However, in larger air leaks, use of suction can increase airflow through the defect, thus prevent spontaneous healing. As far as ventilatory strategies go, you have to minimize the peak airway pressures and plateau pressures for BPF and APFs respectively. What happens is reducing these pressures would, one, reduce the amount of air leak across the defects, also reduce the risk of widening of these leaks and development of the new leaks. It will help weaning from, you have to wean the patient from the ventilator as quickly as possible. Use lower tidal volumes, use lower PEEPs in conjunction with, you will have to accept a certain amount of hypercapnia. When you look at hypercapnia, it's the pH which is more important. Avoid hyperventilating the patient and reduce the mean airway pressure. So all these ventilatory strategies will be the mainstay of managing these patients with alveolar fistulas. However, when the conservative measures fail, you will have to think as to what is the next step. All of these approaches beyond the ventilatory strategies and chest tube drainage should be used with caution. You will have to individualize them to each patient because there is very limited data, mostly in the form of case series or case reports. The efficacy is questionable for some of them in terms of improving patient outcomes. And when you're considering interventions, you have to make sure that the risk of the intervention itself does not outweigh the benefits. So what are the approaches which have been available in literature? Chest tube manipulation with the help of external PEEP application, intermittent intercostal chest tube occlusion, alternative ventilatory strategies in form of high frequency ventilation or independent lung ventilation. All of these have been tried anecdotally with small case reports, case series, very limited data for their success. However, now recently we have more data emerging for the use of endobronchial occlusion devices like Spigot stents, customized endobronchial stents, and you can have pleural-based approach thoracoscopically, and you can use sealants or blood fluoridesis or chemical fluoridesis as well. So this is one of the recent papers published where they have used interventional procedures for the closure of alveolar leaks or mechanical ventilation using customized endobronchial stents and thoracoscopic approach. None of these patients were on ECMO. There's another paper, again very recent, where they've used endobronchial valves in persistent air leak on ECMO. A series of 10 patient, 80% success rate in terms of survival to discharge and closure of the leak. 2 patients died of complications other than endobronchial valve placement. They were basically, they ended up with septic shock and multi-organ failure. So coming to patients who have persistent air leak with very high ventilatory requirements, you'll have to think of ECMO for the management of prolonged alveolar leaks. It can be used in patients with ARDS and bronchoalveolar fistula. The cause of ARDS could be either infectious like influenza, COVID-19, MRSA pneumonias, or it could also be e-cigarette and vape-associated lung injuries. Traumatic or surgical bronchopleural fistulas can also be managed, where ECMO can be used as a bridge to buy time for things to get better and then use definitive measures. Again, limited data, limited case series. What is the principle for using ECMO for the management of the air leaks? It helps you maintain the oxygenation and ventilation. At the same time, it allows dramatic reduction in ventilator settings, allowing lung rest and healing. So the bottom line is you need time, you give time for the lung to heal. Use ultra-protective lung ventilation, which has lower transpulmonary pressure, lower tidal volumes. What do you mean by ultra-protective lung ventilation? You keep a minimum of PEEP, up to 5 to 10 centimeters of water, driving pressures around 10. You'll use extremely low respiratory rates, 5 to 10 breaths per minute. And you can also use these interventional procedures like endobronchial valve, surgical repair, when the patient is on ECMO. This is one of the, these are the multiple case series where they have used ECMO in the post-surgical setting with almost 100% success rate in most of these case series except for one. Most patients were discharged and had a survival benefit. As far as a particular subset of ARDS and prolonged alveolar leaks is concerned, almost 10 to 30% of ARDS patients
Rohan,
get
you have a minute
complicated
left.
with,
You have a minute left.
yeah, sure, with a BAPF. 2% have a persistent air leak, and despite the using low tidal volumes and the reduced the transpulmonary pressures and high respiratory rates, these can impede the closure of a bronchopleural fistula. So this is another paper where they've used ECMO for ARDS patients with prolonged alveolar leaks. 4 patients in this series, all of them had BAPF closure with ECMO alone. They used ventilator strategies even lower than the ultra-protective lung ventilation, with further reduction in transpulmonary pressures and respiratory rates to mediate the closure. They've also proposed an algorithm for patients having bronchoalveolar fistula on mechanical ventilation. If they have a significant pleural apposition in absence of a significant PAL, you can continue standard care. However, if there is significant ventilatory requirement, as in patients with ARDS, you can consider ECMO and ultra-protective lung ventilator strategies. If the leak resolves with the use of ECMO, you can continue and step down to standard care and wean from ECMO and mechanical ventilation. However, despite ECMO, if the leak is refractory, you can consider using blood patches, endobronchial valves, or surgical repairs. So just to conclude, most patients with prolonged alveolar leaks on mechanical ventilation can be managed conservatively. Lung protective ventilation not only helps prevent but also treat prolonged alveolar leaks. Endobronchial pleural-based interventions can be used in case for conservative management fails. ECMO with ultra-protective lung ventilation leads to rapid fistula closure in most patients, and can be used as a bridge to definitive surgical and endobronchial interventions. Thank you.
Thank you, Rohan. The presentation is now open for questions or comments. Yeah, Ravi?
I think COVID brought this to the forefront, the need for this, and suddenly we saw explosion of leaks. The papers done, we ourselves had one which Hari had spearheaded, 9% leaks and so on and so forth. ECMO also came in COVID. There are centers with 15, 20 machines right now. Transplant also came in COVID. So one of the questions is PAL in COVID, for example, and hopefully such diseases don't come, was taken up for transplant early. How would you look at it in light of whatever you've gone through?
So whatever we've seen with patients having very severe COVID as well, those who are on 100% FiO2s and have tided over the crisis, we've seen remarkable recovery in the lung. Now patients coming back with normal oxygenation, significant reversal of fibrosis. So I think consideration of a transplant early, probably if they were stable enough or could buy time on ECMO, we would have seen significant amount of recovery.
The second thing is, would you say there's a shift of mindset towards using technology like ECMO, if everything else falls into place, to make your endobronchial strategy slash surgery more effective? Because they operate on ECMO also now.
Yeah, it is absolutely seen more and more use of ECMO in current practice. We've also had patients in COVID being on ECMO and done well.
When should in mechanical ventilation you give up and say, I can't do anything? This is not going to get better at all. Or should we get into all this, refer it to a center who's handling all this?
Yeah, absolutely. If
The old time thought was, I'm so sorry, old time thought was just give up. They leak away, you try all ventilative strategies and they die.
No, now with the advent of ECMO, advent of these endobronchial strategies, obviously if you have the expertise, you deal with it yourself, or you should get people who can deal with it. I don't think it's the time to give up. With whatever is available, you should try your best and get the patient out.
Yeah, Karan, please.
I think on the ground, getting an ECMO referral for most of our patients in best of settings does not happen. So, short of it, any specific ventilatory strategy would you recommend to assist? Because there's always a discussion which ventilator mode you put them on. What do you do? So, anything you want to.
But you have an ECMO in your unit, isn't it? Don't lie. I thought you have an ECMO in your unit.
One is there, but
then what is the problem? He's got an ECMO in his cylinder. You can't do. I mean, the problem is for us. We don't have an ECMO unit, so what I should be asking that question?
Post-COVID, there are units which have given their ECMOs out to any places they wanted. 14, 15 units sitting in places. Dharmesh, you were saying something?
No, yes. The dilemma is that, as far as the ventilation is concerned, tidal volumes, by reducing that, right, you may be trying to reduce the leak. But on the other hand, how much of permissive hypercapnia can you tolerate? If you increase the tidal volume in these patients, then you may have a chance of increasing the leak, isn't it?
Yeah.
Because that's what we see. So where is this sort of balance which we achieve? I mean, this is the old debate of permissive hypercapnia and how much can we accept it? Because they keep on leaking, the tidal volume keeps on leaking in this.
So if the concept of permissive hypercapnia, you would want to have a pH which is acceptable. At the same time, you do not like the oxygenation suffer as well. So maintain the oxygenation, accept a carbon dioxide level as long as the pH is more than 7.25 or so. If it's getting acidotic below that, the entire physiology is going to be difficult to maintain. So that's where you take a call. If it continues to leak, you'll have to manage the leak, but at the same time maintain the oxygenation and make sure that the patient is alive. You just can't let it go to a pH where it's difficult to sustain.
I'll answer that question in a little more detail because we are a resource limited center where we manage these patients. So what we do is we use the lowest possible tidal volume. If the patient has normoxic hypercarbia, young patient, we go to pH as low as 7.1 also. Okay. But if the patient is elderly, has myocardial ischemia and so on, there you don't go below 7.3. There the risk is there. So that is one. We always try to use a blood patch, autologous blood patch fluoridesis. That is the only thing which we can do at our center. We don't have a ECMO. Referring these patients, especially those with ARDS, is difficult. Taking them to a center where there is ECMO itself is fraught with danger. So that itself is a very risky venture. So the practical thing on the ground is lowest possible tidal volume. Normoxic hypercarbia, you can go below as low as 7.1 and do a blood patch fluorescence and wait for it to heal. Nothing else can be done. We've tried once independent lung ventilation. For that, changing the tube to a double lumen tube itself, the patient collapsed. So that was a problem. So everything, the several things.
The boon of ECMO will become evident as it's available and so on. Currently, it's better than before, but still has a long way to go.
If your center has an ECMO, then I mean, it's a no-brainer. You will obviously put the patient there. Any other questions? Otherwise, we'll move to the second talk. Thanks, Ron.
Yeah, and so the second talk of the session would be by Dr. Dharmesh Patel from Vadodara, and he'll be taking the pleural strategies and perspectives in persistent air leak.
Thank you, gentlemen, and thank you, wonderful friends. I'm the pleural part of the bronchopleural fistula, in case you've missed it. And really, when you look at this whole science in an impartial way, you cannot but agree with William Osler's aphorism when he says that empyema needs a surgeon and 3 inch of cold steel rather than a foolish physician. And I guess for the PAL also, I may not be very wrong when you look at it in a very impartial way of saying that, BPL needs a surgeon with 3 inches of cold steel rather than a foolish intervention pulmonologist, because and this is a very good sentence from, sadly, no author was listed, that the best way of ensuring a divided bronchus remains closed is to observe these 3 principles, which can be only achieved through surgery. And therefore, it shouldn't surprise us. When Valyappan in the editorial with his colleagues on, I think, one of the adjoining article or accompanying article on probably one of these intervention stuff, shows us that surgical results in most of these cases are far better than any other methods which is there. And that is what has been echoed even in 2010 by the American College of Chest Physicians. The first is evaluate for surgery, and when that sort of doesn't work, the latest British Thoracic Guidelines, just published 3 days back, also talks about if you have a situation in an adult with spontaneous pneumothorax and ongoing air leak, excluding post-surgical patients, which treatments are better than ongoing chest tube drainage alone at improving outcomes, and there is insufficient evidence to make any recommendations. But the good practice point is if patient is not considered fit for surgery. So surgery does still remain actually, the first and foremost way of managing these. However, you and I, we've seen these sort of patients. These are all post-surgical patients which they talk about. We've seen more tuberculosis, we've seen infections, and we've seen our patients who are with a very low BMI with a number of other problems. And therefore, it's more important is where other non-surgical methods come in, and this is where intervention pulmonologists come in. And akin their job is to this old mythological story of the boy who saves the city by just putting his finger in a leaking dike. And it's a mythological American story talking about a Dutch boy who worked very hard to save his family from all the various penury and poverty. But then he also helped to save his town when he saw that there was a dam leaking where he put the finger in. And really, that's exactly what we are doing. We are trying to plug the hole and then asking for help. But we have to understand what Abbas says, who is supposed to be a good thoracic surgeon now at Brown University, that one must always remember that the danger to patients with, this is post-pneumonictic BPF, comes not from the hole on the airway, but from the breach of the barrier in the pleural cavity. And therefore, the order of the business should be first to manage the pleura, because a contaminated pleura will not help either an endoscopic procedure or, for that matter, a surgical intervention which is there. And what does a breach in pleura cause? A breach in pleura cause air in the pleura and cause symptoms, or it can cause an empyema. In both these cases, therefore, you need to manage the pleura and PAL. And therefore, I've just taken the liberty of changing the topic given to me by saying, how do you manage the pleura in persistent air leak? But let's ask this question, do we really need to manage the pleura and PL? And why I answer this question is of an excellent clinical commentary which came through. First, let me go back to what Patabi and others showed. And this is a long, old paper of Chi, which says that majority of the PSPs and the SPs do heal by themselves without really doing anything. a conservative care. And this is the clinical commentary and which Walker and his colleagues asked, challenging the paragon of persistent air leak. Are we prolonging the problem? You put an air drain, a chest drain in, and 5-6 days later, you see the lung collapse more than leak is. Why I'm transgressing a little bit on this topic is to show you that when we meet together in such meetings, we don't do ha-ha and drink and go back. Last year, at the same time, this paper or commentary came in just 2 days before when we were sitting in that other hotel, and Ritesh will remember, and Sajal, I just showed them this commentary. And it made, it just made us think, and made them think rather than me. My job was only to show them. And why they say that when we stick a tube into a pneumothorax, they support their 3 observations. One is, of course, the SPS trial, which said a majority of the leaks heal without even putting a drain in. Then they talk about SP, and that is PSP and secondary pneumothoraces, where they pushed in CFC tracer, and then they put a needle aspiration into the pleural space, and in about 30 to 40%, there was nothing coming out in the aspiration saying that the leak had already sealed. The next day, furthermore, also, they did not pick up the tracer CFC gas in the needle aspiration from the pneumothorax, further emphasizing the fact that a large number of these spontaneous and secondary and primary pneumothoraces heal. And third, they talk about is the manometry studies. Why supporting these 3 things, they say that putting a tube in a patient, a chest drain in a patient with pneumothorax, may actually be deleterious, and you're probably causing more harm. The same talk about the it's all about gradients across the leak, and if you have an inadequate gradient, then it probably will enhance, and if you have a more optimal, it will close the leak, and if you have a larger transpulmonary gradient across the leak, you probably might be causing more harm. We saw that physiology earlier on today, talked by Dr. Tay and the others. So what their conclusion was that we propose that chest drain insertion may exacerbate visceral air leak, and challenge the view that a persistent air leak is an effective surrogate of visceral pleural defect. That's what they say. It is not possible to predict the duration of visceral air leak before the intervention. We know that it's difficult, and that any intervention may prolong an air leak that otherwise may have healed spontaneously, depending on the mechanisms. And therefore, the advocacy was patience. Don't put a chest drain in. Of course, they send a caveat that a symptomatic patient and a patient with a large leak, you do need to put a drain in. Accompanying this clinical commentary was an editorial by Gary Lee and Bhajan Singh from their unit in Australia, where said, well, it's an interesting premise, but then it's dangerous as well. Because if you don't put drains in appropriately in patients, then you might land up with a patient getting more sick. And the 3 supportive reasons they have given, the previous commentaries, were not very scientifically plausible, in the sense that the PSP trial actually never was done to look into this. The tracer thing they said was it was nothing to do with, needle aspiration and tracer not picking up. It is possible that the leaks healed itself. And the pleural manometry was talked about in 2 different manners. That is the drainage dependent leaks and drainage independent leaks, something which really I haven't been able to understand. Physiology, like all intervention pulmonologists, though I don't call myself one, is not a forte for us. It is of Sajal's and Dr. Tay and all, but Sajal's missing, and he was going to help me explain this, which we will do after this. Thanks, Sajal. So but now it comes the point. So you don't put a drain in, you put a drain in, and it's surprising that our colleagues from India are acting as arbitrators between 2 giants. On one hand, you have Gary Lee, on the other hand, you have, the Najib and his colleagues, and they say, okay, hang on, you don't want to put a tube in, you want to put a tube in, do one thing, put a tube in, don't put it to underwater seal, just wait. And they give an algorithm which they say that if you have persistent pneumothorax, you place an ICD, you connect to a water seal, and you check for air leak. If your air leak or normal expiration, then remove the water seal and keep checking 24 to 48 hours. And if there is no air leak, only on forced expiration, then remove the ICD. So a very simple thing, put a tube in, but don't attach to the water seal, put a bacterial filter, and just wait and keep assessing 20 to 48 hours. If I'm right, Sajal, you may add on to this. The T0, T1 was a bit over the head. So anyway, you read about that, you'll come to it. But I brought this to this notice because of that. Let's get to that. Let's get to the topic, which I have 3 minutes to say. As a pleural interventionist, you will be called upon in persistent air leaks for 3 questions. Can you drain the pleura so you have the ability to insert a chest drain and its management? Can you shut the pleural space? So knowledge about pleurodesis, and is there a role of medical thoracoscopy and insight into this procedure? Pleural space drainage and its management doesn't form, but we would love, Ravi, if you have a third time to touch these controversies on chest drain. Small versus large, surgical versus Seldinger, water seal versus active suction, single versus multiple drainage system. 2 things to read, which for all of you all are nice chest drainage paper, and of course Dr. Arvind Kumar's YouTube video, which talks to all about chest drains, etc., which is there. Pleurodesis, can you shut the pleura in PAL? Non-surgical procedure, standalone procedure in non-suitable candidates, surgical or bronchoscopic procedure. In selected cases, such as small leaks, patient preference over ambulatory drainage, if it is there, you could do that. It is additive to, or it can be an additive to partially responsive surgical or bronchoscopy methods. It has actually a high failure rate as pure chemical pleurodesis. In fact, the first paper of Wang, which showed 6 patients had an 83% failure rate. Light had his 113 patients, out of which subset of 38 were the persistent air leaks, out of which about 33 or 35% failure rate. Talc may work, as a case report shows, and it has got some adverse effects. This is from Switzerland, and they talk about when everything failed, including the bronchoscopic procedures, 4 unsuccessful bronchoscopy glue applications. What did the trick was just a doxycycline pleurodesis, I think, which was there. So full recovery and 2 years follow-up. Talc in pleurodesis in PAL is effective in selective cases, unsuitable candidate, simple and rapid. For small leaks, be cautious about it and see that there is 90% lung expansion, because it is intuitive that if you have both the pleural, parietal and visceral places far apart, pleurodesis actually wouldn't work, isn't it? Because you have to bring them both into apposition. So avoid in pneumonias and empymas, and comparison with non-surgical alternative needed. And as is always, I love to talk about Norman Bethune, because when I read about Norman Bethune's life, I actually see Ravindra Mehta in him, because Norman Bethune was somebody who was used to think out of the box, which he does. Norman Bethune was an iconoclastic, which is there, which I think he is. And Norman Bethune was a communist, but we don't know political leanings of Dr. Mehta. But what is more important is Mao Zedong actually wrote an obituary. The only person, a non-Chinese, on whom Mao Zedong wrote an obituary was of Norman Bethune, a Canadian. And it wonders that if, God forbid, and he's a sweet man, if Ravi has to write an obituary, who will write his obituary? Only Ravi himself. Nobody else can write that, which is there. So autologous blood patch is the second pleurodesis. First report by 85% success. And this is something really which I came to know last year. I wasn't very a big fan of autologous blood pipe, but when you look at the stats, we've heard about this. I don't want to spend time, but not only in spontaneous, but in all other forms of persistent air leaks. In lung volume reduction surgery, 80% success. After in ARDS also a success. In ILDs as well, the recurrence rate 0 to 29%. And I will just show you a case vignette, which was last year after I attended this meeting. A young chap diagnosed as, Sajal, you know the case, anti-MD5 positive dermatomyositis, on steroids, mycophenolate hydroxychloroquine, doing well, acute presentation with neck and upper chest pain, breathlessness and hoarse voice. Here's the X-ray, here's the CT scan. 4th day post-admission, conservative care, continues to worsen. ICD goes in, 5 days on the ICD, he still continues to worsen. Of course, it's a bad lung disease, we know. Fortnight into admission, exertional breathlessness, varying oxygen needs, full suppression, broad spectrum antibiotic. He's got a persistent air leak, rapidly progressive interstitial lung disease, 5 to 7 liters of oxygen. This is the one which I decided, let me push in this blood, which was being talked about in this meeting, which is that that's the second post day after putting the plug in. Third post-op day, where the lung shows an expansion, removed the ICD on the 24 hours after that, stayed on, but there was subacute emphysema. The disease being bad, on the 72 hours later, it collapsed again. So really, it may have been a partial success or it may not have been. You guys have had more experience probably, so you can tell me about that. So when and how, earlier the better, 50 versus 100 versus 120 mils, 120 mils better. We heard 1 to 2 mils per kilogram in the previous exam. Single installation suffices normally. ABP and PAL, cheap, easily available. What I like is it's green medicine. It's the patient's blood. We're not doing anything, artificial into him. Easily administered, efficacious, well tolerated, minimal adverse effects, and it's worth trying. Role in leaks due to pulmonary infection, don't know. And whether we are infecting a sterile pleural space. Lastly, medical thoracoscopy. Do you really have a role? Probably not actually, unless you want to see pretty pictures like CF. Unless if you don't know how to tackle it, there's no point putting a scope in and just looking at blebs and bullae or this rare hydatid cyst plopping from the lung into the pleural space. However, there is some role in pushing in fibrin and stuff like that through the thoracoscopy, and we saw the glue which we showed. And the last, just one case where everything failed. Interesting, 80-year-old, this is I think from Bethesda, 80-year-old COPD, cirrhosis, hepatic hydrothorax, admitted with a large spontaneous pneumothorax secondary to ruptured bleb, 7 days with 2 ICDs, surgical reference, not fit, interventional pulmonologist, bronchoscopy, finds out through Putter's way of finding out where the leak is. It's found in the medial segment of right lower lobe. Partial re-expansion after putting thrombin and blood patch. Third chest tube goes in, stable pneumothorax and symptoms. Previous 2 ICDs removed. Clamping, by the way, this is all a surgeon doing these tricks. Clamping, the third, is Arvind Kumar coming next? Oh, he's listening. Clamping, third, increase in pneumothorax, repeat bronchoscopy. Now it's the right upper lobe anterior segment, emphasizing the fact which Pata, you were saying, one hole and one leak is not a theory. It has got several holes around it which is leaking. So the collateral ventilation. Electromagnetic navigation being now used to put the blood patch into this segment. Transient resolution, third bronchoscopy leading to continuous leak. There comes the pleural man. Medical thoracoscopy, only 20 mils of fibrin sealant does the trick, followed by doxycycline. Patient died 3 months later of an unrelated complication, which is there. So the role of pleural physicians, my friend, we are physicians first. Follow basic principles, period. Chest drain management is needed and it's paramount. Use Gestalt, some science use it, because you saw throughout this morning, there's very little science really for everything, for whether it be glues or whether it be, for example, the American Indian doctor said, it's not licensed, the valves. I think you need some under humanitarian clause that you can use these valves for BPF. Avoid pleurodesis in bronchopleural fistulas, especially the large ones, and when all fails, ABPP may be a useful option, that is blood patch, in unfit surgical patients or in selected post-op cases, or when endobronchial measures fail or are unavailable, really, I think. And in all else, there's no role you are left with, but, as you know, go to the surgeon who is next, or go to this rather very, very, why do I pull your leg? To a very multitasker. But Ravi, thanks for bringing this dry topic of pneumothorax into limelight. It's a very dry topic. We don't emphasize it. So thank you once again. And for people who want more adrenaline, then here it is. I invite you to Goa next year. I promise you more fun, which is going to be in July 19 to 21st. Next year, not this year. Thank you again, Ravi. Thanks, gentlemen, and sorry for the time.
Thank you.
Do we have time for questions? Dharmesh, what's your take-home message on pleural strategies for us?
I'll tell you, I think the take-home message is, as I've always said, pleura deserves the respect. We just put drains in and we put at good pictures and then we forget about drain management and things like that. So I think it's very intuitive that if you do decide to put a chest drain in, not believing what Naj and Mark Roberts and his colleagues have said, then learn how to manage the ICD. Don't leave it to others, which is there. And I think the blood patch is something which, at the two randomized control trials, number of multi-series, you yourself have used it, Ritesh, and I think it is something which is simple, easy. Why not use it as a first-line procedure rather than going for a bronchoscopy procedure? That's
The blood patch is either bloody good or bloody hell.
What?
The blood patch is either bloody good or bloody hell. It all depends on where you look at it. The blood patch has been either bloody good as per the papers or bloody hell when it's not worked in patients and it delays the whole thing.
Yeah, I don't know if this really, it's 80 to 83% success rate is what's being told.
Again, the same thing. You go by the plural bastions who are talking of PAL and so on. And by nature of it, both names are highly conservative in their invasive pleural approach when done by a non-surgeon. What bias does that get into the whole management protocol? That gets a bias into the whole management protocol, right? Both plural maestros whom we keep quoting from Australia and Oxford are highly conservative people when it comes to the pulmonologist touching the pleural space. The whole literature is biased towards that direction.
Yeah, but you've realized by now, pleural guys are not anyway very aggressive, which is so you really, it's not that jazz like the bronchoscopist, no? There's nothing much you can offer, but you can offer basic good medicine, which is there. With the jazz about valves and sealants and etc. and bronchoscopy you don't have that in the pleural.
Okay. Any other question, please? Thank you. An excellent talk.
I think it's my pleasure to invite Dr. Arvind. I don't think he really requires any kind of an introduction for the legend that he is. And on to Professor Arvind Kumar.
Distinguished chairpersons and friends, a very warm good afternoon and greetings from Delhi. Patabi, am I audible?
Yes, sir. Loud and clear.
Okay. So very warm good afternoon to all of you and greetings from Delhi. And my sincere thanks to Dr. Ravi and his team at Apollo for once again organizing this very thoughtful and very interactive and very informative session. After a series of lectures covering various aspects of interventional pulmonology, medical thoracoscopy, the answer from the surgical side is in the next 20 odd minutes as to what we can do in these cases of persistent air leak. And I'm also supposed to cover the role of a surgeon in bronchial foreign body, which there is minimal, if at all, in the current era of very aggressive IP. There may be some repetition, but I'll run through those slides very quickly. So what are the implications? And once again, as a surgeon, I need to reiterate the differentiation between an alveolo-pleural and broncho-pleural fistula, and then, of course, ending with a key take-home message. So as has been said, anything persisting more than 5 to 7 days, and this, of course, is associated with significant morbidity, occasional mortality, and therefore it becomes an important topic because it increases the incidence of empyema, as was elegantly pointed out by Dr. Dharmesh, that when you have that barrier broken, the first thing that you need to tackle is empyema and not the hole in the bronchus. There is additional direct, indirect treatment costs, and of course, there are issues related to that. So the surgical management purely depends on whether it is APF or BPF, what is the etiology, and of course, one issue which probably has not been given enough importance and is probably often ignored is the fitness of the patient, and more importantly, when I say fitness, the nutritional status of the patient. When you look at so many, and I very carefully listened to the 2 talks before Dr. Dharmesh's talk, where various sealants and various materials have been used, and you've shown resolution after 5 weeks, 6 weeks, 7 weeks, 8 weeks. In the absence of a control arm, we don't know whether they were actually spontaneous closures, or you can attribute the success to the intervention which was done. I, in my surgical practice, have found that the nutritional status of the patient is one of the most ignored but very important factor, which plays a huge role in the final recovery of these patients. Of course, we all know it could be alveolo-pleural or anything which is beyond the segmental bronchus. And if it's segmental bronchus or lower or major, then bronchopleural fistula. Coming to the alveolo-pleural fistula, spontaneous pneumothorax is the commonest cause. We see it very, very, very often after surgery, whether it is lung volume reduction surgery or it is anatomical or non-anatomical resections following barotrauma. In cases of chest trauma now. A lot of patients are being admitted with air leaks, which are because of the peripheral lung injuries occurring as a result of fractured ribs going and touching the head, rather injuring the lung, iatrogenic trauma, necrotizing pneumonia, and of course, rupture of pulmonary metastasis. We all know the management of pneumothorax from simple observation to ICD to mechanical pleurodesis, medical thoracoscopy to surgery. We still practice the second ipsilateral pneumothorax, first contralateral pneumothorax, any bilateral pneumothorax, and more important to this topic, persistence of air leak beyond 5 to 7 days of an adequately inserted chest tube, or the lung refuses, fails to expand, spontaneous hemothorax, and of course, some of the special professions. All these cases, apart from tackling the source of the leak, which could be either a porosity in the upper apical part of the segment of the lung or small blebs. So commonest finding that we have found is a small bleb. Next is a porous area at the apical segment of the apex of the upper lobe. And third is a little nodular kind of looking area in the apex with leash of blood vessels going there, but there is no air leak seen at the time of surgery. In order of incidence, these are the three commonest findings. And of course, nearly 1/4 of the patients, we find no air leak, no anatomical abnormality, and therefore we do a pleurodesis so that in case a leak was to occur again in future, they don't have a recurrence of the thing. We have been practicing this mechanical pleurodesis for a long time, but for the last 4 years or so in these patients, we have switched from mechanical pleurodesis to now doing a total pleurectomy. It was based on observation of recurrence in few cases of young patients with spontaneous pneumothorax. Of course, you might say that it was actually why just a few cases should change the practice. But then we looked at the literature and we did find a small difference reported in the long-term recurrence rates following a blebectomy with mechanical pleurodesis versus blebectomy with pleurectomy. And since pleurectomy does not pose any additional morbidity or a surgical challenge, we've now switched to doing blebectomy, a pleurectomy in all these cases. Talc being put per primum at the time of surgery in these, most of them being young patients, we avoid, for the reason that should they need a surgery in future, a surgeon would have a nightmare. So therefore, we don't put talc at all for per primum in these cases. Of course, 1 or 2 cases where there have been failures after mechanical pleurodesis, when we went in again, we put talc in those cases. Now, most of the patients, this is the most important side, I think, the most of these post-operative pleural air leaks, peripheral air leaks will ultimately prove to be the alveolar-pleural fistula. So we do find more than 50% of our lung resection patients to be having some air leak or the other in the post-op period, but most of it is actually because of the dissection in the fissure. So these are peripheral air leaks from the periphery of the lung. Age of the patients, younger patients have less, older patients have more. Underlying condition, if you have an emphysematous lung or a fibrotic lung, there are more chances, whether there were intraoperative, whether there were intrathoracic adhesions. So whenever there are extensive adhesions between the lung and the chest wall, and you spend a lot of time separating those adhesions, all these increase the incidence of air leak. Preventive measures intraoperatively, of course, we discuss it in the next slide. And if this occurs, we have various post-operative. So intraoperatively, a lot of people have tried buttressing the staple line in cases of severe emphysema. So people have used bovine pericardium as well as artificial material incorporated into the stapler, so that when you put staples, you have that buttressing material coming around the lung between your staples. But there is no trial available till date which has conclusively established a superiority of this method over not using anything at all. Of course, it increases the cost several times. We have talked a lot about topical sealants. There are so many of them available for application on the staple line in the lung, on the staple line in the bronchus. But again, there are reports, there are case series available where people have said that, well, it worked very well, but then there is no control arm. And when we look at the cases where the control arm was there is no report yet which conclusively proves that yes, use of topical sealants reduces your chances of air leak. I think the other factors, how you handle the lung, what was the quality of the lung, what is the nutritional status of the patient, whether you control the infection in the pleura or not. There are so many compounding factors which are equally important rather than just the buttressing of the suture line or topical application of the sealant. Use of pleural tent has been used especially if there is a large bulla occupying the upper lobe area and you do a resection and you have a large space at the apex and the lung somehow is stuck and it's not likely to move up following that bullectomy, you can mobilize the entire apical pleura just the way we do for pleurectomy, but not resect it and therefore allowing it to fall on the lung. And that acts as a buttress to prevent any alveolar leaks from there. When we do lobectomies, so typically in a fissure first lobectomy, you go to the fissure, you look for the blood vessels there and bronchus there, and you dissect and ligate the blood vessel, divide the bronchus, and then you divide the stapler. But there are occasions where there is a lot of fibrosis and you end up injuring the parenchyma in the lobe to be retained, and therefore there is something called fissure last approach, that you take the vessels, etc., and finally you use the stapler to divide the lobe so that there is no dissection there. Use of intraoperative pneumoperitoneum has also, as I said, look at lot of trials available. I would just summarize in one sentence that there is no trial which shows a definite proved superiority of the intraoperative application of buttressing the suture line or putting topical seal, which has been shown to decrease the incidence. This is what I meant by the pleural tent. So you see, this is the lung where after resection of a large bulla in the apical area, there was space and this pleura has been allowed to fall as a kind of a tent or a coverage over that part. And this is what fissure last approach is, where you do minimal intrafissural dissection to prevent the air leak. The most important thing that for me as a surgeon matters in the post-op period is if the lung is expanded or not. If the lung is not expanded and I have air leak, I would do anything and everything to get the lung to expand and the peripheral surface to come in contact with the pleura, because I know once that happens, the buttressing effect of the pleura over the peripheral part of the lung will lead to sealing and stoppage of leaking from all the peripheral air leak. Of course, as I said earlier also, nutrition is very important. It is not your tissue, it is not your sealants, it is not your buttress line, it is the patient's own healing which is going to heal these peripheral air leaks. And therefore, hemoglobin, albumin, nutritional status, no overhydration, doing physiotherapy, being in good physical, emotional condition is very, very important. And trust me, we give a lot of stress to these points while managing these patients. If the lung is not fully expanded, we connect them to suction drains, and we have now Medla available, which of course works beautifully well, and we get the lung. So for us, the challenge is to get the lung to the chest wall. Once the lung reaches chest wall, the answer is no other intervention. Ensure good nutrition, wait, and wait. All peripheral air leaks will close. We have 0% incidence of re-exploration for these peripheral air leaks in cases where the lung was fully expanded. Of course, Sometimes you can do pleurodesis by chemical methods or blood patch, and resurgery, as I said, is not rarely. We have never reoperated for a peripheral air leak where the lung was fully expanded. Again, there is a question of whether after you have achieved full lung expansion, whether continuing to have suction or then converting it to water seal helps or not, and there are conflicting reports. So what we do initially, we use high suction to get the lung to expand. Once the lung reaches the chest wall, we maintain the same suction for 48 hours or so, and then gradually we start reducing the suction to bring it to gravity and then converting it to underwater seal only once the lung is expanded, and then we just let the patients manage the bottle. And another thing that we have noticed is if more than 1 month has passed and the lung is fully expanded, by this time, the lung is already adherent to the chest wall in most of the areas. And we have a new thing which we are just testing in more patients before reporting, that we do a CT to ensure that the lung is adherent to most of the part of the chest wall. And then beyond 1 month, we just cut the chest tube, leave it open for 48 hours and see if the lung does not collapse, which it doesn't do in all the cases that we have tried. 48 hours later, we just pull out the chest tube. In few days' time, that leak stops on its own. This is something which we accidentally happened, observed, and have started doing it now. Coming to the other more surgical. So this was alveolo-pleural fistula following surgery or following pneumothorax, but in bronchopleural fistula, which occurs in about 5 to 20% after pneumonectomy and less than 1% after lobectomy. So right pneumonectomy has higher chance. Pneumonectomy has higher chance than lobectomy. Patients who have received chemotherapy and radiation therapy have higher chance. Diabetes and those on steroids and poor general condition, past history of malignancy, heavy smokers, COPD, low nutritional status, previous ipsilateral thoracotomy, residual tumor or tuberculosis, active infection at the bronchial stump line, a large diameter bronchial stump, extensive lymph node dissection, particularly if you've used a lot of cautery, and prolonged post-op mechanical ventilation, older age. Now, these are the situations where we have found bronchopleural fistula, malignant traumatic infection. So the problem in these which can occur post-op is if there is no drain, they may have a tension pneumothorax, subacute emphysema, mediastinal and tracheal shift, and the post-pneumonectomy patients, what alerts us to development of fistula is if patient comes and says that I have expectorated a large amount of reddish, whitish water, and you do a chest X-ray and you find a decline in the air fluid level. So earlier after pneumonectomy, the space fills by filling of blood there, and as the blood fills, the air column keeps moving up. If you ever see a decline in the air column, that means probably a fistula has developed. So then they develop, ultimately go on to develop empyema. Post-surgical.
Sir, you have 5 minutes left, sir.
Yes, I'll finish in 5 minutes.
Thank you, sir. Thank you.
Ensuring appropriate vascular supply. Again, I refer to Dr. Dharmesh's slide that the two sides should be opposed. Good vascular supply and something buttressing the stump, beautifully, elegantly restated by Dharmesh in that slide. Protecting the contralateral lung from spillage is important, and therefore we put the chest tube. So broad spectrum antibiotics, aggressing pleural drainage, ipsilateral side down, and then for the management of pleural space. So only a small percentage of these BPF will spontaneously heal, and therefore they have to be managed. So preserving principles of BPF closure, preserving the integrity of the blood supply, wide debridement and removal of granulation tissue, and of course, identification and closure of the fistula. The stump has to be reinforced, and there are all kinds of materials, local flaps, etc. available. Important component of chronic BPF is as empyema is almost associated with BPF. So after the initial drainage with the chest tube and then drainage with the trying to buttress the stump. If it still persists, then the last resort for us is to go for the windothoracostomy. So air leaks continue to be the most common complication in patients who are undergoing chest surgery. It's important to differentiate alveolo-pleural from bronchopleural fistula because the treatment strategies differ. Alveolo-pleural fistula, watchful waiting with chest tube drainage is the gold standard and is successful in majority of cases. Whereas when you have BPF, conservative therapy rarely succeeds. So bronchoscopic management or surgical therapy is required in most of these cases. And the exact what you do will vary whether it is a post-lobectomy or a post-pneumonectomy fistula. Last few words about foreign body. Now, it's a rarity for us to be involved in the management of bronchial foreign body because of huge advancements. So about 8,000 odd cases of major thoracic surgery done in last 10 years. I could pull out only 5 cases where we went in to operate. Only 1 case in Medanta in last 3 years. So it's only when you have failed and there is some amount of parenchymal damage occurring that we come into picture to either remove it or more often to resect the lobe which has been destroyed because of persistent. And this surgery could be, if it's in trachea, tracheotomy or thoracotomy, followed by removal of the foreign body, which could be by open VATS or robotic. Last slide just show the operative photograph of a magnet. So this was a young boy who came from Dehradun with history of ingestion of a magnet. A lot of attempts were made at bronchoscopic removal, but it was somehow stuck in the bronchus intermedius right on the right side and was not coming out, so was referred to us. So we had thoracoscopic approach. We reached out to the bronchus intermedius and after feeling the foreign body, made a longitudinal bronchotomy over the bronchus intermedius, and with the instrument pushing it outside from inside, this magnet came out, and you can see it was a magnetic it was a magnet, so this could be pulled. It was put in a glove and taken out, and thereafter the bronchotomy hole which was there in the bronchus intermedius was sutured by intra thoracic suturing. So again, to conclude that air leaks are very common, but fortunately majority are alveolo-pleural, for which conservative management but paying a lot of attention to nutrition, physiotherapy, etc. is important. When it's a bronchopleural fistula, segmental bronchus, major bronchus, or from trachea, conservative management may not work, and then surgical repair of the fistula is important. And when it comes to foreign body, we have very little role to play in the current era of very, very advanced IP. But as and when you have these can be removed by a combination of open, VATS, or robotic surgery. Thank you very much.
Thank you, Dr. Arvind. That was an excellent talk as usual. So open for questions.
Dr. Arvind Kumar Dharmesh here. Just a couple of questions. One is, I've of course asked you before, but again, I'd like to know, would a pre-surgical chemical pleurodesis affect you as a surgeon when you go in and do your job?
Yes, it will. So which I mentioned also, one of the things which increases the incidence of post-operative air leaks, not necessarily bronchopleural fistula, post-operative air leaks is when there are extensive lesions, which we commonly see in our country because of tubercular process. So first we have to separate those adhesions, and in the process sometimes you end up causing small peripheral injuries to the lung surface. So likewise, if you have caused pleurodesis, whether chemical or any other method, and then we go in and we have to remove those adhesions, it will increase the chances of post-operative air leaks, and of course increase the intraoperative difficulty and the operating time.
My second question is, we now know there is nothing as one hole, one leak. In other words, if you find just one single a fistulous opening or a bleb, are you happy by just tackling that? Or is there other somewhat non-visible areas of leak which you think are not important for you to do anything, or because you follow it up with a mechanical fluorodesis, you're not bothered about those small leaks elsewhere?
Excellent question, as usual, Dharmesh. So when these patients come with blebs, first of all, we do not know why these blebs occurred. We presume that there is some kind of a abnormality in their maybe soft tissue mechanism of wear. So therefore, there is no reason to believe that this patient who has one or two or sometimes many visible blebs today will not develop few or many of these in the subsequent years. So therefore, when you surgically handle them, there are two goals. One is to take care of what is visible today, and more importantly, also take care of causation of lung collapse should more blebs develop and rupture in future. So therefore, if you cause extensive adhesion 360-degree between the lung and the pleura, either by mechanical fluorodesis or pleurectomy, even if few blebs were to develop in future, they won't be able to rupture, and even if they do, they won't be able to cause pneumothorax. And therefore, you have taken care of the problem of recurrence of pneumothorax in these patients by achieving fluorodesis. Dharmesh.
Thank you.
Any other question? Sajal? Karan? Ravi?
Yeah, Dr. Arvind, lovely talk as usual. And I think few people know that he's actually in Japan, though he's saying welcome from Delhi, if I'm not mistaken. So thank you so much. The true global nature of the surgeon.
Sir, this is not right, sir. Lying about your location.
No. Actually, I'm on an academic trips, and therefore so we've done 6 cases of lung transplant, and I thought this was time to revisit the technology and technique part by seeing some different methods. So we were trained in Toronto and Vienna. So now I'm here to watch Hiroshi Date do his way of doing transplants. So next 1 week, I'll be here in Kyoto.
Yeah. So thanks a lot.
Yeah.
So
Please, question.
Yeah, go ahead.
So if it's a recurrent pneumothorax, if the bleb is less than 2 centimeter, and sometimes without doing a bullectomy, resorting to this thing, because there is a size criteria which is mentioned for intervening surgically. You can do away only with fluoridesis in that case, because there is a gray zone in that area.
So did you get the question, sir? So the question was, if there's a pneumothorax and there's a bleb which is more, or a bulla which is more than 2 centimeters, less than 2 centimeters, would you, and it is not leaking, would you still do a blebectomy or a bullectomy, or would you just do a fluorodesis and come out?
So I'll go to the slide at when there is pneumothorax because of whatever cause, whether it is primary or secondary. As I said, the first is conservative management for a few days to see if the lung expands and the air leak stops. Then you convert an emergency situation into an elective situation. But following the indications, once we are in and we see a bleb, and let me tell you, most of the blebs that we have seen in the last 15-20 years have actually been less than 2 centimeters in size. And once you see a bleb, and it's not one, in fact, only about 20% of the patients have one bleb. Most of the patients have many blebs. So apical segment of the apex of the upper lobe and the apex of the lower lobe. And third in order of incidence is the bottom of the lower lobe along the diaphragmatic surface, the margin of it, where oftentimes we have seen a family of blebs which are present and we end up resecting. So at surgery, if you see a bleb or a bulla, you will remove it. One, everything that is visible you will remove, and then you will also do your preferred method of fluorodesis, which could be rubbing or pleurectomy, depending on what your practice is.
So I just wanted to ask, you have multiple blebs, you're trying to unnecessarily intervene, isn't it? They're not leaking. So if you have done a fluorodesis, that should do the job. Why do you really want to do a blebectomy there?
Excellent question, Ritesh. So the practice that I follow is that anything which is easily receptive, as I said, sometimes we see a family of these present all along the surface. So we don't go on removing a lot of lung, but sometimes suppose you have one at the apex and there's another one very close to it, and you can take both of them in your staple line, then we remove them. But there are too many, then we just APC them and then do an effective method of pleurodiscs.
Thank you, sir. Thank you. Any other question for Dr. Arvind? Otherwise, I think we can relieve him and he can have a nice beer, a cold beer in Tokyo.
Dr. Arvind, thank you so much.
Ravi,
Thanks
any
to
question?
all of you.
Thank you, sir. Thank you very, very much.
Thank you. Bye.
So I think we come to the last part of this session, which is Ravi putting everything together as far as PAL goes. Over to Ravi.
Can you hear me now? Okay, that's lovely. Okay, pointer moving. Green one, right? Okay, there we go. Okay, so I think my job is just to stitch everything together. After extremely interesting, detailed, meticulous, threadbare slicing and dicing, as I said before, of all these entities. And it's now coming down to the fact that we have a lot of clarity, a certain amount of ambiguity, and the cycle between confusion and clarity will always continue in medicine, and that's why these topics are handled in a way that we can at least add to understanding and hopefully get more solutions down the line. The other revealing part for us is that every time we do this, we think we're done, but actually we're not done because new things coming out. For example, lovely talk by Udit from New York is trying to show us that keep the lung down, and 2 hours later, somebody's trying to say keep the lung up. So it's very interesting. So will you take a 40-year-old surgeon's experience, or will you take a provocative physiological concept by less invasive people? So these are the questions we leave in your mind, but some semblance of trying to put it all together. So this is also for a little add-on and a little funny note for those of you who stepped out for coffee, or the polite chats, of course, inevitable relieving visits which are so important in life. So what has been covered today is, as we said, all this stuff. Of course, since we are pulmonologists and few thoracic surgeons, we have a focus on bronchoscopy, which actually redefined itself, as we'll talk about a little later. And we discussed modalities, complex situations, and I gave my younger lot the more difficult task of handling things like drains and ventilators and so on, much to their chagrin, but they can't say no, and they have to go and peruse the literature, leading to the arrival at midnight and ultimately leading to some good discussions being done. So I just have to go ahead and tell you what is going on from whatever perspective we've garnered. So by and large, again, we went through this whole stuff. First of all, as they say, as Dharmesh repeatedly points out, the gap, the 3-inch steel wire which he was talking about is what we love, but patients don't listen to that. And when they get weaker and the surgeons fail and the wire monger is not actually so great at it, which means surgical skills are not available everywhere. And then in India, which you will sheepishly walk away from when you go to foreign forums, but actually admit in your day-to-day work is economics. And then it comes down to ownership of the patient. 5 entities, 2 of which are never talked in literature. End of the day, bronchoscopy is here. Bronchoscopy has a role to play. We just have to define it in the right spectrum of care we give. It just comes down to that. So in such a situation, we've talked about how to do this. Lovely talks by Dr. Pattabi Raman and devices galore by 2 good speakers, both Udit and Samir. And then we went through all this stuff. So this science is so fascinating because ultimately, though so many people have come by, there's a lot of patchy literature, nobody's put it together. Nobody's really put a guideline out there. It is reflected of other guidelines. Dharmesh will put a 2023 guideline from British Thoracic Society, who is conservative to the hilt, and we will not see anything more than conservative care. And safety and conservative care do go together with full respect. And secondly, if you have plan B with surgeons galore and thoracic programs replete, you will probably not look at fellows who do bronchoscopy. So this is what we have learned. Then we went through all the gizmos. Interestingly, the devices and sealants have increased in India tremendously. We have blockers, we have all the other stuff, and we have debated the blood patch and so on. So again, in your armamentarium is a multitude of things. The whole question is for a younger person, what do I use? When do I use? How is it going to succeed? How long do I manage? And how long do I, and when do I refer? I think these last two can be addressed by a simple question. Manage and refer in modern times is who do you have a liaison with? For example, when we also talk, it's not necessary that you have to transfer everybody to the major center. Proprietary and ownership is not equal to transfer. It's also that now interactive talking and so on can happen. If Karan calls me from Delhi saying there's a chest tube in the bronchus, how to put a blocker, a video is shot to him, in 30 minutes he does it, it's done. So more and more it's coming down to knowing it, implementing it, realizing who you are and how to do it. But most fascinatingly is knowing the science and knowing what to do, because the confidence of that will lead you to the ability to both manage and also handle complications. So bunch of these devices we've discussed also. As we said, we have all these devices in India except for the endobronchial valve. And so, Ender was asking me, why don't we get somebody to look at it, make it locally? And that's a different process. We're trying to make stents locally and so on, and lots of innovations. But they go through an onerous process of 5 years. And in a field like ours, where it is imperative to the patient, but the numbers are few, and so it's not important to industry. So imperative to patient, but not important to industry, will not make it to mainstream use. So that's been a problem, and that's why the science of this will continue with all the measures we understand and we can implement so far, and that has been the basis for innovation. I have people in the audience who we worked together so many years, see Rajni, Pawan, everybody else, Pawan times 2, sorry, and so on. But end of the day, innovation was not something we wanted to do. We didn't start and say, we will innovate. We were started to saying there is no option for this patient. Either the patient goes bad or we come up with something. So between the current clinical status and demise of the patient with no options was that word innovation. So we have to think of innovation very differently. It is not a glamour story out there. It's not planned in a lab. It's not a startup with a pitch to some Shark Tank. It was a no option situation. Then it was taken to mainstream and then with luck put into a paper. Otherwise, without that, nobody looks at you. And that's how we're trying to present all these things. So that is how it's come and it's become more mainstream. I don't think the EBV, to the best of my knowledge, chairpersons will make it to India very easily. If it's not come for a decade, it will not come easily. So we'll be, end of the day, we'll be dealing with what we have. The good news is we're doing very well without it. So that is the strength of what you do. We don't talk, we don't project, we don't go to international meetings, and we have a smaller voice. It doesn't mean the job is not done. The cases shown in the last 2 days are replete with people with tough situations who have been salvaged with these strategies. I think that's missing out there. Okay. It's not a cookie cutter model. That's what was talked about. And we tried to bring that out in our discussions. It basically incorporates, understand where the leak is. So now technology is there. Thanks to CT scans and COVID, the number of CT scans which people are doing, the lower cost of CT scans, and the wise Indian government, which will probably try to do price control and all these things in a while, your tools are increasing now. So you know how to now look at this from a more mature perspective, and then you start with all the other stuff. Experience, referral patterns, networking. Before referring, you can network, because if networking helps you to manage in your own setup, a true mentor you're reaching out to will help you to network and not say, send me everything, which is more the attitude of referral than of helping. And then, of course, availability, which is also galore at this point. And with innovation, it comes at cheaper price points, which is such a lovely thing to think about. So to understand it from a rhetoric to a concrete point of view, For a central BPF, you have all these modalities. You have your customized stent, a time-based phenomena. It doesn't come overnight. Amplats are a little challenging to deploy and also more expensive. You have these blockers, which in our experience, which we hope can be emulated by as many people as required, not just because it's us. You have a blocker and you have a commercial blocker, so that can also help you. And then, of course, other stuff which was talked about is not as useful for central BPF, absolute ethanol glue and all, because you can't take a large hole and try to plug tons of glue into it. Peripheral, of course, all these strategies can be used as mentioned out here, and the blocker also comes out there. So we have added to the armamentarium of available options with proper thinking, due diligence, and how to utilize them for the good of the patient. So this is what has been the story so far in the history of PL across the world and in India. Other deciding factors which was harped on so much by the surgeons also is patient status. What actually is your substrate? It's not easy. So surgery starts with anesthesia. The moment you rule out anesthesia, it becomes a problem. Surgery goes on to the technical part where the surgeon can come in. It goes to the post-operative response and it goes to recovery. All of those require all these factors of nutrition and infection, and that's why it becomes a challenge. And that is why, again, a multimodality surgical bronchoscopic discussion goes a longer way. Post-op PAL, again, as Dr. Arvind pointed out, may in expert hands be handled with the right thinking, or sometimes it just gets too bad. And don't forget that as master surgeon's rendition of his experience is based on his hand operating. When we take it to community, it is not going to be the same thing. And there are people in various learning curves. Every cardiothoracic guy is dipping into thoracic when they reluctantly or compellingly, and all the time we're facing problems as this happens. So what we don't talk about is that the various levels of care will lead to problems, which ultimately will come in your lap, and you will have to figure out a way to deal with it. So it's a very important thing. Patient's wishes, of course, comes down to a major thing. If you offer a patient surgery versus bronchoscopy, all other things falling into place, you do have to have a discussion. The discussion is inherent in bias. He who talks will push his science more than the other science. So if you're capable of having a good neutral discussion, you'll also at least give them the option. But if you don't know, don't believe, don't evaluate, and don't have faith in, you're never going to offer it to them. So there's inherent bias in all these things which we have to factor in. But like I keep saying, bronchoscopy is here to stay. You can't take it away. Available infrastructure and expertise, which we've also mentioned at length and dwelt on in our discussions. Economics, and of course, time. My God, and next time I think we're going to keep a debate is what I was noting. On one side is patience by the Gary Lees and the Oxfords of the world. On the other side is, proactivity as mentioned in the guidelines and surgical literature. Where does the answer lie? And probably you'll never get the right answer. 5 to 7 was an arbitrary number after 25 years. They felt that 5 to 7 days. In penetration, I don't know who listens to it. Still the pulmonologist will go on the patient's route. So ultimately it's going to be a science of what is the extent of your problem, what are the options for it, and then it comes down to patience or proactivity. Again, the Indian spectrum will lend a unique thing because a destroyed lung and patience is not going to work. On the other hand, small leaks and patients may work. So this is another thing we have learned a lot today. And that is why bronchoscopic management has come in early, middle, late, in combination with pleura, so many things over there. Tough subset is of post-op PAL, again, as talked about, is again challenging. I've mentioned it in the last discussion we did. And by and large, bronchoscopy has now got a dual role. It is either primary fix it or bridge it. And let us not undo the role of bridging. When there's a bad problem, you don't have the surgeon. He's sitting in Japan, obviously doing the right things for his program. You will have to do a bridging strategy. And so many of us suffer from it. We also, and not only that fluctuation, we go through surgeons who leave, and so many things are happening. So end of the day, it's either fix or bridge. That role is also very important. And we've learned all the modalities which help us to do that. Again, literature is not much at all. Again, like we said, it's a field waiting for formal recommendations. And it's not that what we say is panacea. When you come up with plan B, bronchoscopy, B for bronchoscopy would be one way to think about it. You're not going to stand up and say, this is the fix. There are problems. For example, when we look at all these devices, there's issues with migration. We admit that also. There is chronic airway irritation, so that's another issue over there. Seeding of devices with infection, which leads to another big problem. And here, I've listed what after 15 years, I think is all the issues. So this slide covers all the issues with this field, a one slider for all this. Main stem bronchial PAL, if not surgically fixable. Collateral ventilation in a country where we can't assess it with devices. Surgical skills we mentioned. And second is exit strategy. The acceleration of doing a procedure has to be tempered by the fact that you have to figure out long-term management of the patient. So you can't have a Bush-Iraq situation. You entered, you put a device, he's living for 20 years, and now the device becomes a problem and not the primary issue, or they both compete with each other. And that is why I think the clarion call is that this is a field which needs systematic thinking, knowledge, experience, skills, and then sets the stage for good MDDs. In modern times, you can do it on a Zoom call. So experience of the last 6 months is, if we have a case, we contact one of these guys and say, can we present to you, take a 15-minute appointment, present, and that becomes a modified MDD, again, thanks to COVID. Our contribution to the field in bronchology was touched on by my colleagues over there. We came up with this blocker, and it's done well and validated after that also, and a paper has come out for that. And COVID itself was a game changer. Rarely in life do you do something and then a condition comes like COVID, where its utility is enhanced because there's so many patients suffering. COVID was a plethora of PAL over there. So to wind up the 10 commandments of PAL therapy, if I can put the entire day into perspective, identify and localize, limit the wait and watch. It's a loaded statement. Limit is English, which means neither 2 days, 5 days, or whatever it may be. It is judicious use of that. Delay can be death. The window may be narrow, or patience may be the key. That is something we won't answer. It's a case-by-case basis. Options when you go down the algorithm are surgical or bronchoscopic. In bronchoscopy, if we go ahead for all the right reasons, we have 3 T's: tools, technology, technique, and team. It's very important to put all of it together. And then, of course, drainage devices. End of the day, we have now realized that drainage devices can help you take the mind-brain down required to figure it out. So when you try to put attention into physiology and therapy, you don't have to worry about what's my Bromovac doing, how much to put 100, 20, 500, put 2 together, 5 together, and so on. And Pavan so nicely summarized all that. Exit strategy, as we talked about, they don't live long. Maybe it's better for the therapy, unfortunately, but if they live long enough, it should heal. When they live long enough, it should heal and the device should come out. Otherwise, the device can pose a problem. We are not like stents or cardiac stents that we can sit quietly. And then anti-recurrent strategy, the pleural disease component and pleural anecdotes which were talked about. Never forget infection and nutrition. Network referral I mentioned with the new way which can be done, not necessarily send every patient over. And economics are such an important part of our country, which we have to talk about because that is the way we will be able to give patients life and not have ideal solutions. So this, in a nutshell, is I think the whole day summarized. So this is an algorithm which we sent for Dr. Karan's offer. He's now going to write a book on rigid bronchoscopy, and I think this is Rohan's work where he's come up with this with an algorithm where we pretty much put all this into perspective, where it says that wait judiciously, do surgery, and no one's going to fight that if possible. But if surgery is not possible, then come down to what you can do with the device part. I'll be happy to share this if anybody wants it. It can be just send your mail and we'll share the presentation with you. So, and this is more detailed, that if you get into it, then you have BPF. So if I go back, it started off with what do you do initially, the surgical or no surgical. And then if you can go for surgery, fine. If you can't go for surgery, then you're either doing bronchoscopic or conservative. Conservative goes on the patient's pathway and all the drains which were talked about. If it works, you do pleurodiscs. If it doesn't, you do bronchoscopy. And this is the last 5 talks, all of them combined into one algorithm. What to use, where to use, depending on size and collateral ventilation. So to summarize the whole thing, it's a complex problem and hence the meeting. We keep asking ourselves every time that are we doing the right thing, or should we just focus on the usual, do 5 stations of flexible rigid, or should we actually dwell into these areas? Your reinforcement will help us a lot. Bronchoscopy, we've talked about it repeatedly, is either the last resort as it was, the mid-level technique which it's become, or in first as it is in certain, in a good number of cases now. The knowledge of a science perpetuates its penetration into practice. If you do not know, you will never practice. The good old KEM statement where we all trained is the eye does not see what the mind does not know. So that sort of stuff. Our options are what we've discussed at length and innovation. So again, to put it into a nice picture out here, PAL assessment is tools at this point is CT chest, collateral ventilation without the gizmos of the West, bronchoscopy to ultimately figure out where it's coming from. You're either doing patience or proactivity. Only you can decide that at this point. You can network for that, and you have two tools in your hand. If you are not waiting, then it's either intervene with surgery or bronchoscopy with all the tools available through the scope, adding knowledge, experience, and literature. So ultimately, it's an evolving science, and year on year as we're doing it, I think not only are we learning, but we are also seeing the new contributions to literature. No doubt technology will also add to all this. I'll leave you with one thought. It's either you are go by conventional thinking and you will hand over to conventional thinking and give up, or you will look for solutions based on the signal in literature, so nicely pointed out all day, and will try and make a difference in these complex patients who defy conventional treatment in larger numbers than we ever saw before. Thank you very much. Any one question, anything they want to take from the last sessions also?
Any questions or comments? I think this was a wonderful thing. I mean, usually a PAL is just a Hall-B 20-minute talk, and it's remarkable that Ravi has taken that and then kind of dissected it, put all the appropriate things, and then we had a lovely session, and the summing up was also very good. So if you have any questions or clarifications, you can address it now. Yeah. You could do it even in a collapsed lung. So it would work if it plugs, it can plug it, and then the lung can expand later, and then the same thing will work as a pleurodesis also. We do not know whether it works as a patch or as a pleurodesis. So it can plug, and so it's not necessary, it's not mandatory that the lung there has to be in a position as in other pleurodesis. So that's no problem, and you can go ahead still. Yes, please.
Sir, my question to Patabi sir regarding persistent air leak localization. Sir, your technique, you mentioned about sedating the patient and doing it through the ET tube. So can we replicate to a spontaneously breathing patient? That is one first question.
Sorry?
Spontaneously breathing patient. And second question is regarding the sizes of Fogarty balloons for blocking the right main stem and the other.
Okay. So can this be done in a spontaneously breathing? Yes, you could do with the spontaneous breathing also. It's in fact quite convenient. You can go ahead and do it. The only thing that is required is you'll have to do a bronchoscope and a Fogarty balloon and a visible ICD bag is all the three that is required. You can do it even in a spontaneously breathing patient. So that's no problem. Here when we do a thing, it gets more controlled. When you do with an endotracheal tube, it's more controlled. And if you have to plan for a device, it could be done in the same anesthesia. And that's the reason why we use, an endotracheal tube and follow that up. So that is question number one. Number two, about Fogarty, you have different sizes of Fogarty. So you use largest for the bigger, the main bronchus, and then you can, reduce. There is a 5, 6, 7, and I mean the different color coded Fogartis. I think you can use whatever is available. Even the larger ones can be used for the smaller things also. So that's not there's no hard and fast rule as to you need to change the size of the Fogarty. So I think those are the answers. So anything else anyone else wants to? Yeah.
In a alveolar-pleural fistula, in a case of with an infected lung and an infected pleural space, we just go conservative or any intervention is necessary there. And if in such a case there is we have got the case late and there is already an MDR organism, so what do we do next?
Ravi, apparently question to you.
Can you repeat the question? I only heard MDR organism. Yeah. So that is the whole thing which we had asked Dr. Dharmesh to look at when he conveniently changed the topic and put some beautiful prose to take it to his. What do you do? Because that's the story we face. There's a drain in there. There's been 2-3 weeks. It's infected and there's a leak over there. So that's a nightmare. So that is the category where whatever one can propose at this point on a practical adage, you have two different issues. One is infection and one is leak. And both are creating a problem. Now the issue is that if you can go in, you go in, because at that point you clear the infection, that means surgical by and large, and that gives them a chance to fix the leak with some patches or whatever. Again, I'm hoping this is an alveolar pleural fistula, not a bronchopleural fistula. But if they can't go in, then it's a nightmare. What we have done at that point is either go prolonged antibiotics, do chest tube drainage, which is going on, or do a medical thoracoscopy. Go in minimally, clear the loculations, get the patient fit to have a procedure, because spiking 1 or 2 degrees, you're not going to be able to do any surgery on them. And in that medical thoracoscopy, we often can see where the leak is. So if we can localize the area of the leak, then we go and block it from the other side. Can I advocate this as being a standard strategy? No. But the whole situation is out of the box. So unfortunately, infection and leak go hand in hand. Both take equal importance. You have to deal with the infection to take off any procedure, otherwise it's conservative all the way. So often it's treat the infection fast, do a procedure to clear the loculi, do whatever, and then address the leak. Often if they're okay, we'll take it up at the same shot. So if they're going through the medical thoracoscopy, okay, very quickly we'll take them up for a blocker or whatever sealant, whatever you can. But most challenging. And the idea of today's entire discussion is, please intervene before they get there. And that is where patience is I really feel Australia and UK in infections versus us. So, US also, and I may be biased there, but it's a personal opinion. We get infected very fast over here. So you have to have it to go in and fix whatever you want to before the infection comes. Long answer, but yeah.
Yeah, if there are no further questions, I think we can close this session. I think the most important thing is this being the concluding theory part of it, right?
We have cases now.
Had an excellent
cases.
We've had an excellent series of talks, I would say, from everybody. Even yesterday, extensive coverage of foreign bodies, and today on PAL. I think we have got more coming in the workshops right now. I think now we break.
No, we actually have our cases now. Okay. It's in the schedule. So, yeah. So thank you everybody for the next session. We invite our next chairpersons, Dr. Karan Madan, Dr. Rajni Bhatt, and Dr. Pawan Biraris. And you guys can take over for the 4 speakers who are there. We have approximately 40 minutes. And one leftover case from yesterday was there, Dr. Kaumudi, foreign body. So we will take that followed by the PL cases.
So let me start by inviting Dr. Kaumudi to present the first case for our case discussions today, while we're waiting for our last panelist, Dr. Pawan.
Good afternoon to all. Thank you, ma'am. Thank you, sir. Thank you, Mehta sir, for giving me an opportunity to present a case discussion on complex foreign body management.
Sorry, one more panelist, Dr. Arjun. We can't leave empty chairs over there.
Moving on to the case, this is about a 65-year-old male having history of cough on and off since last 6 years. So he first presented to an outside doctor in 2017 with this history of cough on and off. So they had done a CT thorax which was showing a right middle lobe, foreign body with some collapse and consolidation. So foreign body removal was attempted from outside hospital. They told the patient it has been removed completely, and they managed him conservatively with antibiotics and nebulizations. So the symptoms never resolved. He had on and off history of exacerbations, infective exacerbations in between. After 4 years, he presented again, showing right middle lobe, foreign body. Let's play the video. So CT has been done, which was showing suspected foreign body again in the right middle lobe area with underlying collapse, consolidation, bronchiectatic changes. So bronchoscopy was attempted from an outside center again, and they found some foreign body at the right middle lobe opening. So the options which was in front of us is, it is a long-term impacted foreign body. He is having recurrent exacerbations, infective exacerbations, and some amount of enterobronchial stenosis, which is due to the long-term impacted foreign body. So the options which was given is either go for a surgical removal or a bronchoscopic removal, which will be challenging. And they have, at this point, I would like to ask the panelists what we should choose in such a foreign body, which was there impacted for last 4 years, with some endobronchial stenosis being demonstrated in the CT. What would be the preferred modality, either to go with a surgery or a bronchoscopic removal?
Am I audible? Yeah. So do we have a bronchoscopic image? I think
it was done outside. Our bronchoscopic image will be in the
So I think one most important thing is to actually have a diagnostic look inside the airway, what it actually looks like. A lot of what you do subsequently would depend on the appearance. Yes. You might have a totally complete obliteration in which you might feel that a bronchoscopic excision and removal may actually not work, especially if the lobe is whatever. But I think in this lobe is partially bronchiectatic, it's not completely destroyed. So you may have a look, and then I think that would be important. And second thing is whether you have a history of the exact nature of the foreign body. If you know what was it, if you don't know, then obviously you'll have to see and decide. But I think a bronchoscopic appearance, in my opinion, would be important.
Another case in point is that whenever you attempt a removal of foreign body and the patient is having, so especially if it's an organic foreign body, a lot of times you may end up crushing it, you may not have taken everything out. If the patient continues to have symptoms, so when you take a foreign body out because of the local reaction, patient may be symptomatic for a couple of weeks after you remove. The patient continues to have symptoms. You should have a low threshold to reevaluate the patient to try and see if anything gets left behind. Sometimes the patient in a long-standing foreign body, the patient may be symptomatic because the stenosis, though it resolves a lot of times because the foreign body is out, sometimes rarely you might have a stenosis without the foreign body being inside, and the patient is not able to clear secretion. So these are two possibilities, both of which have to be evaluated. And if you do not evaluate, then you might end up missing it for a few years together. Yeah.
I think, one of the things that happens is when you say that a patient has had a bronchoscopy done elsewhere, is whether you have access to only images or if someone has sent you an actual video. Sometimes, Dr. Mehta spoke about networking and referral. If one place doesn't have all the tools available, if you take a really good video and then send it forward to the next person, that's useful to them. But without at least a video, I would not just trust some images and a report. I would really want to have a look myself.
I think just add one thing, that you'll have a look, see whether it is retrievable or not. Suppose the distal parenchyma is completely destroyed, like partial bronchiectasis is still acceptable for bronchoscopic management. But if you do not have a ventilating parenchyma, it's completely destroyed. Even if you remove the foreign body, the patient will still have symptoms. That time, first surgical management can be considered in those cases. However, yes, bronchoscopy becomes mandatory to have a look first, and whether you'll be able to successfully remove it or not.
Moving on, So the patient and family have opted for a bronchoscopy and removal. So this is the bronchoscopic approach. If we can, we are able to see that middle lobe, it is showing a pinhole stenosis with only a small opening to work with. So at this point also there was this debate whether going for a surgical removal versus and we want to visualize the foreign body also. So controlled balloon dilatation has been done. So we were able to dilate the middle lobe opening and wanted to visualize whether the foreign body is really there or not. So this is the video which is showing a controlled balloon dilatation of the right middle lobe bronchus. So after this, we were with a thin bronchoscope, we were able to visualize the foreign body which was impacted there over last 5 years, around 4 to 5 years. So then initially, so considering the nature, thinking it to be an organic foreign body, attempted cryoprobe, but it started fragmenting. So we had to remove it with the help of serotip basket and forceps. The piecemeals were removed with the help of forceps, and the foreign body in toto was removed with the help of serotip basket. This was the foreign body which was removed. Obviously, it was fragmented. Yes. So, video, please. So, this is the bronchoscopy, post foreign body removal, one surveillance bronchoscopy done later, just to ensure that there is nothing which is been remaining inside. And serial CTs also has been done just to see the progress of the bronchiectasis. There is some amount of stenosis still persist in the right middle lobe, which already was there, but patient. So the main point after bronchoscopies, he had over 4 to 5 years recurrent exacerbations, frequent hospital admissions for these infections and all. Post bronchoscopy, post foreign body removal, after treating with proper antibiotics, he is asymptomatic for the last 1 year, even though some amount of middle lobe stenosis is there, asymptomatic for the last 1 year with no infective exacerbations. So the learning point what we removed was arachinet. So it has mechanical and chemical properties which make it a complicated foreign body. Usually it can fragment, which makes the retrieval difficult. Another point with arachinet is it releases some of the agents like ericolin, papaverine and all, which enhances the granulation tissue formation through IL-4 TNF alpha pathway. It also contains large amount of copper, which is fibrogenic. So to retrieve such a foreign body, we need a plethora of interventional pulmonology tools in our bronchoscopy suite. We should be well equipped before attempting a foreign body removal. And patient with chronic respiratory symptoms, they should definitely be evaluated for a foreign body also. Thank you.
Thank you very much, Dr. Bhavani. I'll invite our next is Dr. Shyam to present this.
Are there any questions from the audience about this, the foreign body case?
I have one question for the team and whatever. So in this case, it's a bronchostenosis and a distal foreign body. You've removed it, and what you make out, there is still a bit of malacia, and there's a raw granulation or a raw surface.
Yeah.
So what should be the approach of a follow-up bronchoscopy or a follow-up dilatation or any role of, these are questions which come in real life, whether you follow up that with a short course of, a steroid or antibiotics. What's your take on this?
Do I have Dr. Kaumud's permission to answer this? So the problem is, it is an undefined event. There's very few things, you really don't know. These things don't happen. Usually you just give up on it. The foreign body's gone ahead. There's been to put Arvind's term, a tent which has formed on it, and you don't know how to get there. So it takes a lot to realize that to get there, you have to actually cause more harm. You have to get a pathway or a channel, which is what we did. After that, God bless, the foreign body came out, which is another challenge by itself. Then this third point 3 is the sequelae, which we know are going to happen. It is a small area, it's been there for a long time. The gentleman is mentally been told his lung is going to go. So you go ahead and do acutely whatever you have to do. It's inflamed. You keep it open. And then comes the inevitable scar, which you cannot predict. So the first bronchoscopy we do is based on stent analogy. That the earliest stent stenosis happens at 3 weeks or so. So usually 3 to 4 weeks we'll call them. Do we prefer bronch CT? Excellent question. Bronch is dynamic, CT is static. So we'll do a bronchoscopy usually. Also from the idea that if it's narrowing, we'll intervene at the same time. If it's convenient, all this counseling is done. If that is okay, then the next one cycles to 2 months and so on. No right answer, Karan, and the panel, you guys can give your feedbacks. In our minds, for 6 months, if you're okay, you're going to stay okay. Also documented by a parenchyma evaluation with a CT scan, because you may be great in your endobronchial evaluation, but if there is repeated infection and bronchiectasis happening, you have to open up. Lastly, this patient is from Pawanland, Mumbai. So if whatever we intervene, we have to follow up or hand over to him. But that sort of thing was another problem. So when we realized that some stenosis is acceptable as long as there is no symptoms, there is no distal bronchiectasis happening, and your panoramic follow-up is a good amount, 6 months, 6 to 12 months, you're probably finding it. So these are the thinking. But again, what you point out is all of us, if we can collect a series of these and put out also as both management strategies and the questions to be raised.
Sometimes we encounter the post-obstructive, the pus which comes out, that usually cultures, it grows on, some bacteria grows on culture, and then then becomes a tricky decision whether to give him a short course of tapering steroids or not. So,
and we'll ask, what is the role of steroids in all these things? We've been giving it for donkey's years. Does it actually make a difference? Anybody's thoughts? Arjun, Rajni?
Ultimately, I think the status of the airway decides whether it's going to come back or not, irrespective of what we do. I think steroids is more to convince ourselves that we are doing something in addition to intervention. That's what it is, because I think the literature also does not support us giving steroids for any bronchostenosis. Again, just adding to that point, more often, I think it's got to do with the fact that once the foreign body comes out, the amount of stenosis that happens, again, that's where we have to be careful about the amount of damage that we do trying to retrieve the foreign body. The amount of stenosis that happens is usually less than what it was before, because the constant irritation is gone. And there, if the patient remains asymptomatic, in the sense that even if the patient has quite a bit of bronchiectasis, what returns to what we used to call it as bronchiectasis sicca, in the sense that the secretions come down, though there is radiological bronchiectasis which is there. And if the patient remains asymptomatic, that probably, it is a sort of medical lobectomy that has been done. Though it is not contributing much, you might end up actually, especially when you do not have access to a good surgeon, you might end up having the patient not being subjected to a surgery at the point.
I agree with the idea that the role of steroids at this point early would, well, I guess the thing is that when you have an impacted foreign body which has been there for a long period of time, we do expect some amount of bronchostenosis after removal, especially when you've had to do this level of instrumentation to get it out. The follow-up visit is what would really be the place where you think about whether there's a role of steroids or not. At that point, you're looking at, is the patient symptomatic, clinically what's happening with the patient, and how severe is the restenosis or is the stenosis now compared to prior. But I don't see a role for it upfront, considering that we do expect some amount of stenosis after removing a long-term foreign body.
fair enough. So I present my case over here, which is probably a case which kind of brings out the difficulties we as practitioners face in day-to-day life. So we have an expert panel. We have, you can learn from the experiences of all of them. So I thought this is the right platform to kind of present this case. So we have this 38-year-old female, no comorbidities. She presents to her local physician with complaints of fever, breathlessness, right-sided chest pain for the past 10 days. Initial treatment was given by the local physician there. She was treated with oral antibiotics, antipyretics, inhalers because of the breathlessness. She did, say some improvement of symptoms, but then it did not resolve. The fever and the chest pain persisted. So she was referred to the local pulmonologist over there, who advised a routine test and an X-ray. And this is what the X-ray film showed. It showed a nice right-sided hydropneumothorax. So she was immediately hospitalized. A chest drain was placed by the pulmonologist. The pleural fluid was sent for analysis, which was an exudative, neutrophilic. The protein was around 4.5 grams, neutrophilic 60-65% neutrophils, an ADA of 20%. The gene expert, the AFB smear, gram stain, all was negative. Even the culture was negative. Despite the insertion of the chest drain, the hydropneumothorax persisted. There was active air leak in the drain. The clinical course, she was treated in the other hospital with IV antibiotics. The clinical condition somewhat improved, but the air leak persisted. She was discharged by the pulmonologist there with the chest drain in situ. And 2 weeks later on follow-up, the air leak persisted, and the right lung, it was still incompletely expanded at the 2-week follow-up. She also complained of a low-grade fever, which kept persisting despite discharge. So it is at this stage, she was referred to our center for further management. So when she came to us, we saw that, so this was probably 2-3 weeks after she had the chest drain placed. The chest drain looked pretty, dirty. So we thought it's definitely a source of infection. We would need to change it. We placed a slightly higher bore chest tube, positioned it to the apex. For what it's worth, we connected to a negative suction and tried to see if the lung would expand or not. We sent the pleural fluid again for culture, and this time it grew Klebsiella. It was ESBL sensitive, so we upgraded the antibiotics accordingly. We did a bronchoscopy, but the endobronchial, there were no endobronchial lesions, but there were a lot of secretions. The gene expert, AFB fungal smear was all negative, but the lavage also was positive for Klebsiella. So we thought we would, and the sensitivity pattern was pretty much similar. So we decided to treat with the IV antibiotics first. But the air leak in the right side kept persisting. And this is where, when we took a surgical consult, and a CT scan was done. I don't have the films as of now because she got it done at the other center, but which basically showed a nice right-sided pneumothorax with a lot of adhesions. By then, there were a lot of adhesions which had formed, and the lower part of the right lung was kind of plastered to the wall, and there was a little bit of pleural effusion at the basal region as well. So a surgical consult was taken, and the surgeon rightly, like, you treat with the antibiotics, and once the infection is settled, we would plan for a DCOT and a BPF closure at that point. But then challenges, the patient did not consent for surgery, mostly because of financial constraints. So that is when we were deciding what to do, bronchoscopic options, or then treat it, just conservatively wait for some more time. But then this is already 4 weeks after the chest drain was put in the initial stage. So then we thought it's enough of waiting, we need to kind of act now. So that is when we decided that we would probably go ahead, try to locate the leak bronchoscopically, and then once we localize the leak, try to plug it off with a spigot. So, the reason I'm presenting this case is in this platform is one of the reasons is that I use some kind of I wouldn't say innovation, but a different method to kind of localize the air leak. So I use the digital chest drain system. So I'm very poor at kind of quantifying the air bubbles, and my technician is even worse. So he wants to finish the procedure fast. So he'll say, "Nahi, badhiya sir, air leak ekdam kam ho gaya." So out of the last 10 cases, only 3 or 4 had been successful. And methylene blue is, I don't know, I'm not good at that. So I wanted to try this device out for localizing the air leak. And this was actually pretty. So you can see, so the moment I localized, so once you inflate the balloon at the right lower lobe, initially you can see when the anesthetist kind of gives the extra tidal volume push, the air leak goes up to 800 ml per minute. And then once I inflate the balloon at the right lower lobe and then tell the anesthetist to push the extra amount of air, you can see still the air leak doesn't increase. It still remains at 10 ml per minute. So that way I could kind of localize the air leak to the distal segments, to the right lower lobe segments, and then we go sequentially furthermore distally. And then, so this I found is a pretty a reliable way of kind of quantifying the air leak when you have numbers in front of you. So this is one of the reason why I wanted to present this case as one more modality to the existing list of modalities to localize the air leak. So once I localized the air leak to the right lower lobe, then went ahead with, I learned to make this spigot under Dr. Mehta. So we used the customized, and I had the silicone remnant piece, so we could make a spigot there. And then I used this spigot, the customized silicone blocker, to place the spigot at the right lower lobe. And then finally finished off spraying some glue over it. So once that was done, the air leak stopped, but the patient continued to have low-grade fever. A repeat bronch was done. So this was probably 2 weeks down after she was admitted to our center. Bronch, the culture, AFB, gene expert, everything was negative. This is the repeat CT, which showed a small loculated effusion at the basal region where we drained out. We thought probably that's the source of the fever. We put in a pigtail and drained that effusion as well. The pleural fluid culture was negative. So, and then after we continued with the antibiotics, clinical improvement, the drains were removed and she was discharged. So after discharge, she complained of fever. So 3 to 4 days later after discharge, she complained, she persists to have this low-grade fever. She was all right during the time of discharge, but once she was discharged, she had this low-grade fever for which she stays 250 kilometers away from Kolkata. She went to her local physician and he, seeing the pleural effusion, low-grade fever, added 2+2, started on ATDs, but this time the fever resolved. And so now, were we missing something? Did we miss the diagnosis of TB? Though the pleural fluid lavage, and this is when it made me think that narrow period, what Mehta sir had alluded to before, that, do you do a thoracoscopy upfront initially when you had the space with you? So, but anyway, she had clinical improvement. So the follow-up chest X-ray 2 months later had a small pocket of air in the right upper lobe. It was partially expanded. The spigot was removed after 2 months. And then 4 months later, you can see she made a good, it shows a good recovery with a thick pleural rim on the right apex. But the patient is doing well, and she'll probably complete her course of anti-tubercular treatment. And so that's the case. So now the questions I want to ask the panelists are, one is, what are the preferred techniques you would use to kind of locate the BPF?
So I think it's an excellent innovation. Obviously, what you might think with experience, the experience with which Dr. Ravi and group they have in terms of localizing the leak and quantifying the leak is not the same as other centers, because we don't see as many as they see and over years. And this is something where if you can see the numbers right in front of you, they matter. And this is a way where we can actually make things easier, and it's an excellent innovation from your side in terms of actually seeing the numbers and like utilizing what you have for something other than what it was designed for. That's excellent work. So only thing I would, and if it is our center, what we would do differently would be that we are aggressive in terms of anybody who comes with an empyema which looks multiloculated. Before we actually put in a spigot, we will clear it out, the empyema part. So one thing is, it takes care of most of what is the focus of infection, gives you adequate tissue for culture also. So like, we are not as aggressive as Dr. Ravi and group, wherein we would generally do this because our expertise at blocking this is not as good as theirs. So what we would do is we'd clear the pleural cavity, put in the tube, and like Dr. Arvind says, if the lung is opposing, after you clear the visceral rind, if the lung is able to oppose and you have a leak, usually it should settle down in 3 to 4 days time. In the meantime, once the fever comes down, if the patient continues to have a leak, then you can probably do an endobronchial blocker and shut it out.
I congratulate you first on this, managing this case well. The techniques used to localize BPF, we have seen CT scan, bronchoscopic management. You can use the dye required for the CT scan, contrast dye, put in through a bronchoscopic. So see the blocker localization technique, replication of the technique everywhere is with experience it comes. At my center, we do both. We physiological analyze the BPF as well as on a DSA panel of a cath lab or intervention radiology. You can go bronchoscopically, put in their multi-purpose catheter and then put a dye through that. So individually, you can reconfirm that these are the segments which are contributing. But physiological way works better because we'll come to know about the collateral ventilation answer. I think that is the only one addition which we have.
And when to call in the surgeon, just a point. So one is you need a very good surgeon. And a lot of times what happens is, no, they go in for a decortication and they see a leak. They end up doing a lobectomy or they may end up doing a pneumonectomy. So that is not something that you would want at that point of time because the patient is left with. So you need to be very clear. A lot of times you actually have to hold their hand and say that I don't want this lobe to go. I don't want to sacrifice the entire lobe or the lung. So that's something that they might end up beginning because it's very easy for them to do that and come out. Yeah.
Yes, so I think we'll have to move on for this sake of time. Also, I'll just ask just one comment on that. I think in this patient, actually, you know, there was a diagnostic dilemma of the cause. Yeah. If it's an infected hydropneumothorax, the two most common things which would come to your mind is tubercular or a bacterial kind of profile. Right. And most of the times, if you don't get the classical history of a bacterial event, many of the times one approach is to do a thoracoscopic inspection and take a biopsy. Right. Or many of the times, if your history is like a slightly prolonged history, it's sometimes common to give them an anti-tuberculous treatment upfront. Another thing which would be very useful is an analysis of the CT scan. If your CT scan shows you upper lobe cavities or a superior segment apical involvement of cavities, central lobular nodules, that can be a useful pointer towards the initiation of anti-tuberculous therapy. From a technical point, I think use a laryngeal mask airway to deploy a blocker. Now, how challenging it can be for manipulation, displacement, in my opinion, I would prefer always a rigid bronchoscope to do a silicone blocker placement. Any difficulties on negotiating? How did you hold it? And, while you took it, any challenges?
Yeah, so fair point. So I always use the rigid bronchoscope to deploy the larger ones, at least 9 mm or larger. This one, so financial constraints. So the moment you enter the rigid bronch code in our system, the patient gets billed for the OT, the OT charges are added. So this is when, so I thought we might as well take a risk and go ahead with the LMA. And fortunately, so I didn't have issues negotiating with the LMA. So
just a quick last point, Cham, excellent way, very well handled, and the medulla puts a new spin to the whole thing. Just to add to her point, the same case of infection and blocking. So if you just treat the infection, but you don't have the source with the blocking treated, you're going to get into trouble. If you only block and don't clear the infection, you're going to get into trouble. Somewhere a closely intertwined tandem process or simultaneous process with a lesser level of anesthesia with some innovations seems to be the key. Thank you.
Thank you.
In my studio, you do a bronchoscopy. Whatever is possible, you use the bronchoscopic modality. But like we had a last case which has an implant which is aspergillus infected. Post lung surgery, the implant was placed and then it got infected aspergillus. In that situation, the thoracic window, which is an age-old procedure, comes in picture where you drain that cavity first, let the infection settle, and then you do a bronchoscopic modality. That's it.
I'd like to invite Dr. Pawan Yadav next to present his case.
A very good afternoon to you all. And I would like to take this opportunity to thank Mehta sir and rest of the team for putting up this program and inviting us here. Little louder. Little louder. So today I'll be presenting a couple of cases from the archives of lung transplantation. So to give a little bit of understanding as to what lung transplantation is, and because I assume that not many centers across the country are doing this procedure. So lung transplantation has picked up in numbers over the last few years because of the aging population and the number of patients who have chronic lung diseases are increasing. And also many centers across the world have taken up lung transplantation, and the numbers are going up. And most interestingly, The survival post lung transplantation also has improved a lot. And when I got into the field of lung transplantation, they used to say this 5-year survival was about 5.5 to 6 years. Now the median survival is about 8.3 years. So it's going to get better and better. And of course, with the COVID pandemic, people had huge challenges, and ECMO was taken up very well in many centers across the globe. Also, the lung transplantation also came into the forefront, and one of the largest number of lung transplantation post-COVID was done in this country. Okay, so that's very promising. And there are a lot of complications that we see in the post-lung transplant period. And most interestingly, the airway complications are the ones which are a great limiting factor in the overall prognosis here. Okay, so there are many things which have improved over the last few years, which has led to the overall survival, longevity, and good healthy lifestyle of the patients who underwent transplant. And most importantly, it has been improvement in the critical care, and the way we handle immunosuppression has got better, and the way we handle airways have gotten better, because airway complications were one of the most limiting factors in the overall survival of these patients. And as you can see in the, you have point. So as you can see, in the earlier part of post-transplantation, we have complications like sloughing of the airways and the anastomotic dehiscence. And dehiscence is the one which I'm going to focus today, because that's the one which is going to lead to persistent air leaks. So to understand as to at what level we will develop dehiscence, let's go and understand anatomical from the anatomical point of view. Okay, so this is how a double lung transplantation would be done. So there are 3 levels of anastomosis which is done. One is the bronchial anastomosis, pulmonary artery, followed by pulmonary vein anastomosis, when it is a single lung or a double lung transplantation. Okay, so now the anastomosis is done at the distal part of a distal bronchial level. Okay, so this is the level at which you expect anastomotic complications to happen. Most commonly it could be stenosis, or quite common it can be a dehiscence as well. Okay, on the other side we have a depiction of a combined heart and lung transplantation, whereas the anastomosis is at the level of the lower trachea, and the other 2 anastomosis is going to be the aortic anastomosis and the right atrial anastomosis. So from our point of view, we'll be focusing upon the airway anastomosis here, right? So here, as you can see, there are 2 levels of anastomosis which is happening. One is at the bronchial level, other one is at the lower tracheal level. So this is the point of focus for today's talk, and as far as this case is concerned, right? So the surgeons would take the incision here as close to the right upper lobe or the left upper lobe bronchial takeoff as possible. That is to avoid the amount of hypoxic injury which can happen at the level of anastomosis. Okay, so to understand as to why that is done, to understand the vascular supply for the bronchus. The proximal bronchus is supplied by systemic circulation with the help of bronchial arteries, which arise from the aorta or the intercostal vessels, and they supply highly oxygen-rich, nutrition-rich blood. As we go distally, it is supplied by more of the pulmonary arterial circulation, which carries a deoxygenated blood. For this region, we have a watershed region here where the mixing of the blood happens, and the more proximal the bronchi is, so the more rich oxygenated blood it is receiving. So we would like to retain the recipient's bronchi as long as possible. Okay. So now this anastomosis will lead to a lot of challenges for when you're trying to do an intervention here, when you're trying to deploy a stent here, and also to do any other further interventions. This is going to pose a challenge, and it's going to be a little bit different than our regular the airway stenting procedure that we do. Okay. Okay. So let me come to the first case. This was a 24-year-old gentleman who has presented to us with a severe form of interstitial lung disease, and it was a very extensive amount of lung fibrosis. The time he presented to us, it was almost like a UIP pattern, and he was dependent upon about 5 to 6 liters of oxygen round the clock. And once we started evaluating him for a lung transplant, we noticed that he has a severe RV dysfunction in the form of PASP was about 110, and TAPSE was around 9 to 10, and cardiac MRI showed a very poor right ventricular ejection fraction. So with a multidisciplinary team in place, we decided to register him for a combined heart and lung transplant. Okay, so after registering, after 10 or 12 days of waiting period, he did get a good organ, and he underwent a double lung transplant along with a combined heart transplant. So post-op, everything went fine. He was extubated on day 2, and the recovery was quite smooth, and he was discharged home on day 20. So post-discharge, he presented to us with history of breathing difficulty and also low-grade fever, and he was taken up for a bronchoscopy. When we did a bronchoscopy, we noticed the lower tracheal anastomosis. The mucosa was not looking too healthy. The mucosa was looking pale, and there was some amount of necrotic tissue along the anastomotic site. So we took some biopsies from there, and it showed the growth of Pseudomonas infection. We started on IV antibiotics for that, and he was sent home with IV antibiotic. After a week later, he came back to us with again a worsening breathlessness. We did a chest X-ray which showed pneumothorax. Okay, and that's when we considered doing a repeat bronchoscopy, and this is what we noticed there. As you can see, the local. I'm sorry. Can you play the video? So this was anastomotic site. As you can see, the anterior anastomosis, the right and left lateral part of the anastomosis is sloughed off. As you can see, the necrotic material over there, and the anterior part of the anastomosis has given away, leading to through and through communication there. And this was probably the site of the leak which was happening, and also the lateral portion was also giving away slowly. Only the posterior mucosal part of the anastomosis was held together. Okay, and distal part of the airway and the bronchi were all kept intact. And so now we had a challenge here. We had to stop the leak from happening here. We had to prevent the contamination of the mediastinum. And as sir was explaining, we have to prevent the development of infection into the pleural space as well, because once that happens, it's going to be a nightmare to manage this patient. Because these patients are under a severe amount of immunosuppression in the form of tacrolimus, mycophenolate, steroids, etc. So they can develop a severe amount of sepsis and end up very sick. Okay, so we decided to stent this airway, and we deployed a stent across the lower trachea and the proximal bronchi to cover the dehiscence. And then it was, as you can see, it was with a good approximation. So right upper lobe is patent, middle lower lobes are patent, and on the left side we have all the bronchi taking off well. So the most important thing here is to see that the approximation to the mucosa is quite good. And about 4 to 5 days later, the leak almost stopped, and we could take up the ICD, and then we sent him home on IV antibiotics. So we called him back for a check bronchoscopy in a week's time, and the stent was in so the stent was in good place. As you can notice here, the proximal part as well as the distal part, there's not much of granulation tissue which is happening. This is one very important difference and observation that we have to see in patients who underwent transplantation, because they're going to be under immunosuppression. They will be receiving steroids. For these reasons, we assume they don't develop a lot of granulation tissue here. That for those reasons, we can probably get away with less amount of complication associated with deploying covered metallic stents in this group of patients. Okay, and after 3 months, so the patient was quite stable. We called him back, and then we took the stent out. And post-stent removal, as you can see, the anastomosis is quite healed and it's quite intact. The anterior, the lateral portions, all the circumferentially, it's quite healed well, and there was no issues. Later on, we called him for a check bronchoscopy, which was done later. Can you play the right video first, please? Yeah, this was a bronchoscopy which was done 1 month later. So the anastomotic site is quite intact, but still some amount of slough is there anteriorly, which was left in place. Next video, please. And this video was of the check bronchoscopy, which was done 1 month later. Okay, so it's a good amount of healing. As you can see, there is not much of granulation tissue as well. So this was one such case which we handled quite well. Okay. Okay, so now what were the decisions that we had to take in this particular patient? Initially, when we did a bronchoscopy, there was only a mucosal breach. Okay, subsequently, when the patient presented with a pneumothorax, the breach had extended across the tracheal wall, and it has involved the muscle layer, the cartilage, etc., and it has become a through and through sinus leading into air leak. So the reason for the particular complication was, of course, the infection there, which was appropriately treated with a good amount of antibiotic coverage, and the patient recovered well with that. Okay. So can I present another case?
I think time is almost done. Can you just run through it quickly, and what are the issues and how it was sorted? That's
okay,
all. Yeah.
okay. Then I'll just skip this.
It's going to be similar then, yes.
Yeah. Okay. So I'll just going through the pathophysiology as to why this complications happen. That's because probably of the poor blood supply to the anastomotic site. because the bronchial arteries are cut off during the transplant process, and the anastomotic site is dependent upon the pulmonary arterial circulation, which carries a deoxygenated blood with low amount of oxygen there. That's why these complications are more common in post-transplant population. And other reasons are because of the ischemia time which is associated with the graft, the surgical technique itself, and mechanical ventilation when you're using high amount of pressures and PEEP that can contribute. And most oftenly we neglect the amount of the usage of vasopressors, which can cause vasoconstriction at the site of anastomosis. Okay. And this is the grading system that we use for the complications. The first step is ischemia or necrosis, dehiscence, stenosis, or malacia. These are the complications that we see. For dehiscence, we have to look at the location, whether it's a membranous dehiscence or a cartilaginous, and we have to look at the amount of circumferential involvement of the dehiscence here, and we classify, and this is how we monitor this group of patients. And this is one such chart we have to manage, maintaining each patient to follow up. This patient has to see how they are progressing during the subsequent follow-up period. And there is a discussion between SEMS for the silicone stent in the post-transplant patients. I think if there are any questions, we can take up this topic. And this was one of the largest series from India regarding the post-transplant complication, which was presented in the CHEST Congress. Okay. Thank you.
Excellent work, Pawan. And yes, and this is post-transplant when the patient develops airway dehiscence. It actually looks a big mess, and it's so it's amazing to see how the body tends to heal if you are able to bridge and tide over that crisis, and you're able to intervene at the right time before the patient develops mediastinitis. So excellent work, and I think this is one of the post-transplant scenario is one where you'll have these stents actually have a role to play in terms of reducing the leak, and this is definitely a completely unique scenario.
Quickly, Pawan, lovely, and I think you have one of the largest experiences in the country, so it's very nice to see it. Just 2 lines on the metal versus silicone, which I know you wanted to talk, but time is limited. All of West will only use silicone, and they must have gone through their own anastomotic complications like crazy till metal came in. Your just take in a minute on metal versus silicone and why you're choosing metal.
So there are a few reasons there. Can I just put on the slide? Is it possible? No. Okay. Okay. So basically, the anastomotic site in the post-transplant patients, these are not like a straightly aligned airways. Post-transplant, what happens? There is a tortuosity which happens there, and to deploy a silicone stent, we need a straighter airway. That is point number 1. Point number 2 is, as I mentioned there, when you do the slicing of the bronchial wall, what happens is the anastomosis is very close to the upper lobe takeoff. So we don't have a landing space for a silicone stent to go and sit there, because for the silicone stent to sit, we need a waist. So there's no waist, there's no space for the silicone stent to hold, and once you deploy it, it very easily comes back, and then putting it back is again difficult. So in that situation, the covered metal stents can take out the tortuosity, and they can sit there with a good amount of holding which can happen there. And the third thing is handling a rigid bronchoscope in a patient who has a dehiscence of that nature is very, very, very tricky, because if you have to put a pressure there to put in a silicone stent, deploy it, pull it, push it, so to manipulate the airway when you have a dehiscence of that nature, it's very difficult. And also, as I mentioned, the hesitancy to use a metal stent is because of one, granulation tissue, which I mentioned, because of the immunosuppression and steroids. It's significantly less in post-transplant patients, and we don't see it often at all. Second is the risk of developing infections. Of course, it is always there. That's one of the most important controversies out there, especially in a transplant patient. So what we do is we do frequent bronchoscopies and toileting of these stents. As you saw there, when the patient came for the follow-up, the stent was so clean. Okay, so that is always there. And then the other points favoring the metal stent is approximation of the airways. Okay, as you can see, as I mentioned there, the approximation is very good there. Whenever we have a dehiscence there, when you put a silicone stent and it's not approximating well, still the seepage of the secretions into the mediastinum can happen, leading into the contamination of the airways. Okay, and the narrow internal to external lumen ratio, especially if you are deploying a stent more distally, silicone stent wall is quite thick as compared to the metal stent with the cover. So these are the few points. I think we have tried silicone stents, but it's quite difficult. I think yesterday we were discussing regarding the newer stents which are available for for the transplant patients. ICAST stents have been used in more distally in the smaller bronchial airways, and 3D printing is something which is coming up, and then of course the biodegradable stents as well. So we don't know how they would behave in transplant patients. We don't have much experience on that. And I think better stents would come as people say that there are no like absolutely perfect stents. So you just have to wait for the one to come.
Excellent points, I think. Really puts everything into perspective.
Yeah, I think his point about lack of granulation in these patients is well taken, because we have one post-transplant guy whom we stented 8 years ago, sitting in Ukraine and refusing to come back to get his stent removed. A metal stent sitting for 8 years otherwise is unimaginable. Yeah.
You're more stressed out than him.
And one more point I missed is the reduced cough reflex in these patients. The transplanted lung is devoid of the vagal circulation. They don't cough much at all. So only the native airways is the one which has the cough reflex. As you go distally, they don't cough much at all. So without cough, there's not much of stent movement. There's not much of granulation happening there. Not much of dislocation happening there. So they do tolerate these stents quite well.
Excellent, excellent.
So good afternoon, everyone. So I'll be taking the last talk of this interesting case session, and due to paucity of time, I'll just go to my slides. And since I'm the last person between the delegates, faculty, and their lunch and the interesting workshop later on. So can we go to the next slide? So this case is regarding the pandemic which had swept the world. So there were many dreaded complications. We have lost many people to this disease. So we had a similar gentleman, 54-year-old, who was treated for severe COVID-19 pneumonia bar ARDS. He was treated at outside hospital, and basically in view of his prolonged intubation, he was tracheostomized 6 weeks into his illness. And he also had bilateral pneumothorax as a complication of both the disease as well as the iatrogenic due to mechanical ventilation. He was managed at outside hospital with bilateral intercostal tube drainage and had grade 4 air leak. Apart from that, he was referred to us for further management. So in the background, we have a gentleman who has underlying lung involvement, grade 4 air leak, and also with a secondary infection. Can we go on to the next slide? So after referral to a center, when we evaluated him up front, he was managed with mechanical ventilation with requiring an FiO2 of around 100%. With sepsis being managed on multiple antibiotics. Can we run the video of the CT scan? So this is a CT scan of the patient. Now, what I would like to point out is the bilateral pneumothorax with ICD in situ. Apart from that, he had significant septal thickening in bilateral lungs. Apart from that, you can see a large bulla involving the left upper lobe. In fact, 2-3 bullas sitting there. And apart from that, there was consolidation involving bilateral lower lobes also. Can we move on to the next slide? So the challenges which we faced in this patient, the patient was frail, sick on FiO2 of 100% with underlying disease lung in the form of consolidation, some fibrotic changes plus bulla in the left upper lobe. And he was basically managed conservatively outside and with grade 4 air leak. Can we go on to the next slide? So how to proceed in such a case? Due to paucity of time, actually I wanted to ask this question to a panelist, but we'll go on to the next slide. So this basically conforms to the questions which were put out by the delegates, that we have a patient who has an infection and also an air leak. So as pointed out, we went ahead with the triage pleuroscopy. So this is the pleuroscopy which was done on the left side. So we could identify this bulla involving the left upper lobe, and it was converted basically into a VATS, and a staple bullectomy was done in this case on the left side. Can we move on to the next slide? So on the right side also, the pleuroscopy was done. Can we play the video? So we could identify this large bronchopleural fistula. And we did a bronchoscopic localization also, in which the fistula was localized to right upper lobe anterior segments. So on the on the pleural side, we were able to deal with it with autologous blood patch. And since we this is basically a sick patient and we did not want to subject him to further interventions. Just for the safety aspects, the blocker was also put on the bronchial side, wherein we were able to localize the fistula to the right upper lobe anterior segment. So this was basically a high-risk procedure wherein we had to take care of the air leak and also treat the underlying lung consolidation which was there. We can go on to the next slide. So the result was later on there was resolution of air leak, and with proper antibiotics and ventilation strategies, we were able to wean him off ventilator. The bilateral ICDs were also removed. The patient was weaned off ventilator, and consequently the patient was also decannulated. We can move on to the next slide. So was it all worth it in the end? Definitely it was. It was a high risk procedure. So this is a CT scan at 4-month follow-up. So we can see the lungs expanded, although there are some residual fibrotic changes there, but he's able to do his day-to-day activities. Patient was decannulated and he has a good quality of life, and also we are able to salvage this patient out of this complicated situation. So this was one of the dreaded complications which we faced during our dealing with COVID-19 patients. So I would just like to ask the panelists that was there any other way or any other modality which we can think of in managing such patients?
No, I think the modality of chosen is an excellent outcome. I mean, the question is not of other. I think the way it is handled is actually fantastic. The question I had was that this patient was on a very high FiO2 requirement, and say you take him for VATS, do a single lung. I mean, how was that handled, or the patient had improved by the time the patient was taken up for VATS?
Jumped the gun first time. We had ECMO on standby. Whole plan was 70% where this is not going to happen. Get out of septic shock. So this is probably the biggest, and we should give so much care to critical care people. Get him out of sepsis, find the window, keep ECMO standby, and if it's not working, go on ECMO and do all these things. Fortunately, that the first port and all, thanks to the leak creates the space. If there's a space, you go in and you're not upsetting physiology in your initial porting, so to say. If the first port can go in and the physiology is the same, then you can start the work as Dr. Shrikant pointed.
So one of the questions, thanks Ravi for that explanation of the level of planning for potential problems that one has to do when taking on something this high risk. One of the questions from one of our online participants, and this would apply across the kind of case that Shrikant presented, Shyam presented, is with an active infection, when would one want to do an endobronchial procedure to block the leak? And similarly, in the case of tuberculosis with a hydropneumothorax, so we have a lot of people we put the combined experience in this room together, we cross a century of experience in very skilled hands. So your thoughts about how do you time it, the placement of an endobronchial blocker, and when do you intervene? I think we did discuss some aspects of it before, but if there are nuances to it in terms of your choice of procedure.
So I think so Dr. Mehta pointed out sometimes delay can be, it can lead to some potential complications later on. So I think so initial conservative management is well thought of, but it should not be prolonged. There is no definite time frame. I feel every case has to be some improvisation has to be done in every case. Like in this case, we had to go full-fledged upfront. Whereas in other cases, which Dr. Shyam showed, wherein some initial conservative management can be done, and maybe the patient can be bailed out with such conservative management. So I think so overall it depends on a case-to-case basis, and based on that we can take a decision.
Rush is rash, delay is detriment. Somewhere in the middle lies the answer.
Yeah, I think to second to that, I think because it's a vicious cycle, because an infected pleural space is leading to an endobronchial communication, and a failure to close, is again leading to the problem. So I think unless your bronchus as such, which is leaking, or segment is so badly infected endobronchially, I think there is nothing which prevents going in early to, solve this problem.
I think that word vicious cycle comes in. There's a pleurobronchial game going on, and you cannot change it. And this is in the midst of already infested with MDR bugs. So the moment you get a window, you go in with, as we talked about, a quick simultaneous/tandem strategy. In this case, it was simultaneous although.
I think it's a very fair point over here that, when you say that it is case by case, it's never just one single point data that you're looking at. You're looking at the patient's clinical trajectory over there, and there's a narrow window. The delay is only worthwhile if you think it is going to actually help in mitigate the risk of a longer procedure that you may want to take up. So the only reasons for the delay would be to optimize the patient's clinical condition on other parameters, if anything else at all. But it would really be based on what's happening with the patient on a day-to-day basis in that.
And just adding to the question of what Dr. Dharmesh raised, so it's not a simple solution. And you can see that the same strategy does not work on both sides of the single patient also. You cannot do what was done on the left side for what was done on, you cannot exchange for what was done on the left side for what was done on the right side. So here you got a bulla which is not contributing to any gas exchange, and that needs to come out. Supposing the same thing, if you take on the other side, already compromised lung, if you want to actually take out with a stapler the area which is leaking, you're going to sacrifice a lot more of actually viable lung tissue. So there, plugging the hole and achieving a pleurodesis subsequently makes sense. So that's why you cannot have a simple solution to fit all patients. Every patient, depending upon what you see, you'll have to take a call from the basket of interventions that we have with us.
I thank the panelists for staying back for that interesting case discussion. Now I'd like to invite Dr. Mehta for the vote of thanks.
Yeah, so thank you everybody. We come to the end of the didactics component of this entire enterprise. We've gone through exhaustively foreign body, PEL. I'm sure we've left you with lots of clarity, a fair amount of confusion, but certainly a lot of questions to be answered, and hopefully enough tips and tools to put into your practice in a more meaningful way. So it's time to say thanks, not because we're finishing, because I won't be able to catch everybody, and there's a whole online panel which is waiting. So no meeting can end without gratitude to all the people who constituted it, whether in participant mode or in planning mode. So my sincere thanks to the organizations, which is APIPA, Apollo, Karnataka Pulmonary Association, and Olympus, who helped to make this possible. But the executive arm has been entirely because a lovely faculty, all sitting in front of me, and so many so close to me, especially from sharing so many lovely memories and these innovations and the pathways and the traumas and the victories, who have come so unconditionally here. The delegates who have spent their time both on site and online to try and learn from this, and not to forget a wonderful team who has incessantly worked in the background to make sure everything from each part of it, from the tickets to food to arrangements to PowerPoint presentations to is my video playing and is the thing available, all that it takes to make this together. Not to mention my eye and my stern look, or sometimes so which has been part of the story. So anyway, so it's lovely, and we will love you to give us feedback, because as we listen to these talks, we also wonder that taking on a different paradigm of focusing is justified or no. So if you want to come back a year on year, we'd love to have feedback. So the feedback loop which you guys give us will be a very important part for us to decide to come back with various such topics, considering that the country has enough and more of general topics going on. So this is our gratitude to all of you. And in terms of actual processes, we thank the online people also, who I think at a certain point now can log off. We'll now be proceeding with the workshop, and my colleagues in 2 minutes will tell you what to do, the exciting part. What I can give you is a preview. It is an amazing amount of stuff over there. Stations, animal models, so many things have been arranged to try and make all this theory actually land on the ground for hands-on practice. So I'm sure you're going to have a great experience. Again, the same faculty will be putting all the energies to to cement what we have discussed. So for workshop flow, I'll invite my colleagues to come and quickly talk for 2 minutes. And the certificates and all the relevant questions will be part of ending it. We are a little picky. The certificates will be given to you when your evaluation comes in, just so that we can all do this better for the future. Thank you so much.
Faculty, y'all can please proceed for lunch. Workshop delegates, just a moment for some orientation prior to the workshop. So following this, there's going to be a lunch right outside, and just beyond the lunch is the hall where the workshop will take place. You all have already received cards with colors on them, and these colors will be how you all will be grouped. So all the reds together, yellows together, and so forth. So please collect with your group, and then we will rotate through the stations. Please note your color. Station 1 will be red, blue 2, yellow 3, green 4, orange 5, and purple 6. That will be your starting station. We will have 25 minutes per station, after which a bell will ring and you all can proceed to the next station. We will also take a small break during the workshop to come back here for a photograph. Another thing, there'll be videos playing on the screens in between the stations for your reference. There are learning points at each station. I would advise you to go through them and make sure you follow the objectives and the learning points before moving to the next station. Once you get to the hall, we have gowns, gloves, and masks ready for you to use. And after the workshop, please fill out your Google form. Once you filled out your Google form, your certificate will be handed over to you. Please proceed for lunch.